that preferentially migrate to the GI tract. The accumulation of such immune cells within this tissue contributes to inflammation that is characteristic of ulcerative colitis and Crohn's disease. As part of a process called lymphocyte trafficking, a small number of T cells are known to express the alpha-4 beta-7 integrin, which binds to the mucosal addressin cell adhesion molecule 1, or MAdCAM1. The binding of alpha-4 beta-7 to MAdCAM1 causes cells to enter the inflamed tissue from the vasculature. This interaction primarily occurs at the vascular endothelium in the lamina propria intestinal submucosa and gut-associated lymphoid tissue, the main sites of MAdCAM1 expression. Entyvio works by binding to the alpha-4 beta-7 integrin, preventing its interaction with its ligand, MAdCAM1. It selectively inhibits the adhesion of T cells to the endothelial surface of blood vessels within the gastrointestinal tract. As a result, Entyvio selectively restricts T cell recruitment from the vasculature into the tissue, reducing inflammation within the gastrointestinal tract associated with ulcerative colitis and Crohn's disease.
Where one expansion leads to the next. Horizontally, we are racing ahead to fulfill both domestic and overseas market with certified quality API even more competitively. Vertically, we are taking new steps to stretch our portfolio beyond pharmaceutical products into cosmetics, food supplements, hospital health supplies, and medical devices sectors. To support our strategic moves and initiative, we have also accomplished our strategic expansions of our plant and its facilities. Our modern warehouse to safeguard the quality of our products. And our new head office to ensure the long life journey serve the country and the world. After spanning over than 4 decades, currently PT Meiji Indonesia has the largest penicillin injection facilities in Indonesia and the largest penicillin API manufacturer in Southeast Asia. Our consistent development and expansion, about which we have always been proud of, is much attributed to the well-planning and execution of the company's strategic direction. Inspired by the need of quality medicine, we bring a vision to gear up with high-quality products to the highest satisfaction of our customers. We bring more to life all over the world and human health improvement. It's an ongoing challenge to render our best of everything we do. It's what we were brought up to be. In the spirit of the company's vision, we are dedicated to carry 3-dimensional purposes to bring PT Meiji Indonesia as a clean, green, and trusted company. A clean company that develops organization where excellence thrives is fostered through constant efforts to reach for creativity and innovation in an atmosphere which encourages sense of urgency through market and partner orientation. A green company where we work whilst taking steps to save environment by improving our customer, employees, and communities' lives through our actions and choices in socially and environmentally responsible ways, and conduct our operation in a way that benefits society and the environment. A trusted company where we strive to continue to move forward to improve the quality of people's lives and the health of patients who need our medicines the most. Today, our factory is fully operated by a highly dedicated professional team which runs under two separated production lines of beta-lactam and non-beta-lactam products, supported by modern technology, facilities, and infrastructure. We apply tight validated production method and tight quality control in each production step to ensure high-quality medicines in compliance with the Japanese CGMP standards. In line with our purpose to bring PT Meiji Indonesia as a green company, our plant operates under eco-friendly processes and environment to produce eco-friendly products. Therefore, it is our ultimate goal to eliminate pollutions and save the earth. Being the largest penicillin injection manufacturer in Indonesia, we are also committed to maintaining our quality products and supplies by building up our own active pharmaceutical ingredients primary plants. Through these practices, PT Meiji Indonesia has gained its trust to supply both domestic and international market within Meiji Group and other pharmaceutical companies as well. In the spirit of such commitment, we shall move forward in quest of excellence whereby the quality of our human resources shall continuously upgraded. Hence, we have been substantially exercising a series of educational and training programs through our esteemed Meiji Book, compliance guidance, and other corporate training programs that everyone has to adhere to, that promote best people in their working place. Moreover, driven by our vision, total customer satisfaction is always our prime priority. We value our relationship with medical professions as our invaluable partner, with whom we work together and to whom we owe much of our success. As a reflection of our mission, we are also committed to pursuing sustainable development and contribution to empower the society and the surrounding communities through our numerous CSR programs. Finally, providing best service is our passion. Walking life's journey with you is our commitment. Our greatest satisfaction is your good health.
Welcome to the virtual Indonesian Digestive this week and the virtual EUS ERCP Workshop 2020.
Entyvio is a monoclonal antibody that has been developed for the treatment of moderately to severely active ulcerative colitis and Crohn's disease, two common forms of inflammatory bowel disease or IBD. IBD is associated with altered functions of the immune system. As part of the body's adaptive immune response, lymphocytes are imprinted for migration to areas of inflammation in specific tissues. Entyvio targets a discrete subset of imprinted T cells that preferentially migrate to the GI tract. The accumulation of such immune cells within this tissue contributes to inflammation that is characteristic of ulcerative colitis and Crohn's disease. As part of a process called lymphocyte trafficking, a small number of T cells are known to express the alpha-4 beta-7 integrin, which binds to the mucosal addressin cell adhesion molecule 1 or MAdCAM1. The binding of alpha-4 beta-7 to MAdCAM1 causes cells to enter the inflamed tissue from the vasculature. This interaction primarily occurs at the vascular endothelium in the lamina propria intestinal submucosa and gut-associated lymphoid tissue, the main sites of MAdCAM1 expression. Entyvio works by binding to the alpha-4 beta-7 integrin, preventing its interaction with its ligand MAdCAM1. It selectively inhibits the adhesion of T cells to the endothelial surface of blood vessels within the gastrointestinal tract. As a result, Entyvio selectively restricts T cell recruitment from the vasculature into the tissue, reducing inflammation within the gastrointestinal tract associated with ulcerative colitis and Crohn's disease.
As a dynamic enterprise with annual sales turnover of over 1 trillion rupiah, PT Meiji Indonesia spread its wings of expansion where one expansion leads to the next. Horizontally, we are racing ahead to fulfill both domestic and overseas market with certified quality API even more competitively. Vertically, we are taking new steps to stretch our portfolio beyond pharmaceutical products into cosmetics, food supplements, hospital health supplies, and medical devices sectors. To support our strategic moves and initiative, we have also accomplished our strategic expansions of our plant and its facilities. Our modern warehouse to safeguard the quality of our products. And our new head office to ensure the long life journey serve the country and the world. After spanning over than 4 decades, currently PT Meiji Indonesia has the largest penicillin injection facilities in Indonesia and the largest penicillin API manufacturer in Southeast Asia. Our consistent development and expansion, about which we have always been proud of, is much attributed to the well-planning and execution of the company's strategic direction. Inspired by the need of quality medicine, we bring a vision to gear up with high-quality products to the highest satisfaction of our customers. We bring more to life all over the world and human health improvement. It's an ongoing challenge to render our best of everything we do. It's what we were brought up to be. In the spirit of the company's vision, we are dedicated to carry 3-dimensional purposes to bring PT Meiji Indonesia as a clean, green, and trusted company. A clean company that develops organization where excellence thrives is fostered through constant efforts to reach for creativity and innovation in an atmosphere which encourages sense of urgency through market and partner orientation. A green company where we work whilst taking steps to save environment by improving our customer, employees, and communities' lives through our actions and choices in socially and environmentally responsible ways, and conduct our operation in a way that benefits society and the environment. A trusted company where we strive to continue to move forward to improve the quality of people's lives and the health of patients who need our medicines the most. Today, our factory is fully operated by a highly dedicated professional team which runs under 2 separated production lines of beta-lactam and non-beta-lactam products, supported by modern technology, facilities, and infrastructure. We apply tight validated production method and tight quality control in each production step to ensure high-quality medicines in compliance with the Japanese CGMP standards. In line with our purpose to bring PT Meiji Indonesia as a green company, our plant operates under eco-friendly processes and environment to produce eco-friendly products. Therefore, it is our ultimate goal to eliminate pollutions and save the earth. Being the largest penicillin injection manufacturer in Indonesia, we are also committed to maintaining our quality products and supplies by building up our own active pharmaceutical ingredients primary plants. Through these practices, PT Meiji Indonesia has gained its trust to supply both domestic and international market within Meiji Group and other pharmaceutical companies as well. In the spirit of such commitment, we shall move forward in quest of excellence whereby the quality of our human resources shall continuously upgraded. Hence, we have been substantially exercising a series of educational and training programs through our esteemed Meiji Book, compliance guidance, and other corporate training programs that everyone has to adhere to, that promote best people in their working place. Moreover, driven by our vision, total customer satisfaction is always our prime priority. We value our relationship with medical professions as our invaluable partner, with whom we work together and to whom we owe much of our success. As a reflection of our mission, we are also committed to pursuing sustainable development and contribution to empower the society and the surrounding communities through our numerous CSR programs. Finally, providing best service is our passion. Walking life's journey with you is our commitment. Our greatest satisfaction is your good health.
Entyvio is a monoclonal antibody that has been developed for the treatment of moderately to severely active ulcerative colitis and Crohn's disease, two common forms of inflammatory bowel disease or IBD. IBD is associated with altered functions of the immune system. As part of the body's adaptive immune response, lymphocytes are imprinted for migration to areas of inflammation in specific tissues. Entyvio targets a discrete subset of imprinted T cells that preferentially migrate to the GI tract. The accumulation of such immune cells within this tissue contributes to inflammation that is characteristic of ulcerative colitis and Crohn's disease. As part of a process called lymphocyte trafficking, a small number of T cells are known to express the alpha-4 beta-7 integrin, which binds to the mucosal addressin cell adhesion molecule 1 or MADCAM1. The binding of alpha-4 beta-7 to MADCAM1 causes cells to enter the inflamed tissue from the vasculature. This interaction primarily occurs at the vascular endothelium in the lamina propria intestinal submucosa and gut-associated lymphoid tissue, the main sites of MADCAM1 expression. Entyvio works by binding to the alpha-4 beta-7 integrin, preventing its interaction with its ligand MADCAM1. It selectively inhibits the adhesion of T cells to the endothelial surface of blood vessels within the gastrointestinal tract. As a result, Entyvio selectively restricts T cell recruitment from the vasculature into the tissue, reducing inflammation within the gastrointestinal tract associated with ulcerative colitis and Crohn's disease.
As a dynamic enterprise with annual sales turnover of over 1 trillion rupiah, PT Meiji Indonesia spread its wings of expansion, where one expansion leads to the next. Horizontally, we are racing ahead to fulfill both domestic and overseas market with certified quality API even more competitively. Vertically, we are taking new steps to stretch our portfolio beyond pharmaceutical products into cosmetics, food supplements, hospital health supplies, and medical devices sectors. To support our strategic moves and initiative, we have also accomplished our strategic expansions of our plant and its facilities. Our modern warehouse to safeguard the quality of our products, and our new head office to ensure the long life journey serve the country and the world. After spanning over 4 decades, currently PT Meiji Indonesia has the largest penicillin injection facilities in Indonesia and the largest penicillin API manufacturer in Southeast Asia. Our consistent development and expansion, about which we have always been proud of, is much attributed to the well-planning and execution of the company's strategic direction. Inspired by the need of quality medicine, we bring a vision to gear up with high-quality products to the highest satisfaction of our customers. We bring more to life all over the world and human health improvement. It's an ongoing challenge to render our best of everything we do. It's what we were brought up to be. In the spirit of the company's vision, we are dedicated to carry 3-dimensional purposes to bring PT Meiji Indonesia as a clean, green, and trusted company. A clean company that develops organization where excellence thrives is fostered through constant efforts to reach for creativity and innovation in an atmosphere which encourages sense of urgency through market and partner orientation. A green company where we work whilst taking steps to save environment by improving our customer, employees, and communities' lives through our actions and choices in socially and environmentally responsible ways, and conduct our operation in a way that benefits society and the environment. A trusted company where we strive to continue to move forward to improve the quality of people's lives and the health of patients who need our medicines the most. Today, our factory is fully operated by a highly dedicated professional team which runs under two separated production lines of beta-lactam and non-beta-lactam products, supported by modern technology, facilities, and infrastructure. We apply tight validated production method and tight quality control in each production step to ensure high-quality medicines in compliance with the Japanese CGMP standards. In line with our purpose to bring PT Meiji Indonesia as a green company, our plant operates under eco-friendly processes and environment to produce eco-friendly products. Therefore, it is our ultimate goal to eliminate pollutions and save the earth. Being the largest penicillin injection manufacturer in Indonesia, we are also committed to maintaining our quality products and supplies by building up our own active pharmaceutical ingredients primary plants. Through these practices, PT Meiji Indonesia has gained its trust to supply both domestic and international market within Meiji Group and other pharmaceutical companies as well. In the spirit of such commitment, we shall move forward in quest of excellence whereby the quality of our human resources shall continuously upgraded. Hence, we have been substantially exercising a series of educational and training programs through our esteemed Meiji Book, compliance guidance, and other corporate training programs that everyone has to adhere to, that promote best people in their working place. Moreover, driven by our vision, total customer satisfaction is always our prime priority. We value our relationship with medical professions as our invaluable partner, with whom we work together and to whom we owe much of our success. As a reflection of our mission, we are also committed to pursuing sustainable development and contribution to empower the society and the surrounding communities through our numerous CSR programs. Finally, providing best service is our passion. Walking life's journey with you is our commitment. Our greatest satisfaction is your good health.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Good morning, professors, doctors, colleagues. Welcome back to the Indonesian Digestive Disease Week 2020. We are very happy to welcome you here today to our symposium. And there will be a lot more topics that will be discussed and shared today. So there will be 4 symposiums and 2 plenary lectures today. And the first agenda is Symposium 5 with the topic AUSBD, Is It the End Era of PTBD? Sponsored by Fujifilm. For this symposium, it will be moderated by Prof. Dadang Makmun, MD PhD, Head of Department of Internal Medicine, Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo Hospital, and Dr. Bogi Pratomo Wibowo from Division of Gastroenterology and Hepatology, Department of Internal Medicine, Faculty of Medicine, Universitas Brawijaya Saiful Anwar General Hospital. To Prof. Dadang and Dr. Bogi Pratomo Wibowo, the time is yours.
Okay, thank you, Dr. Saskia. On behalf of the chairman, Professor Dadang Makmun, I will open this symposium. Our topic this morning is about the AUSBD. Is it the end era of the PTBD? We have 3 distinguished speakers, international speakers from Thailand and South Korea, and as we know, AUS is
Yang dikasih ke saya judulnya bukan
new
itu.
modalities, is an alternative method to drainage the biliary system, and it has a good success and safety. Because we have a limited time, we will start with our first speaker, Dr. Ahmad Fauzi, who will give a talk about the AUSBD in advanced pancreatobiliary malignancy, how to apply. Dr. Ahmad Fauzi, as we know, is the staff of a Division of Gastroenterology, Department of Internal Medicine, Faculty of Medicine, Indonesian University, Cipto Mangunkusumo General Hospital. I think Dr. Fauzi is one of the leading person in ERCP and AUS in Indonesia. So, Dr. Fauzi, we have 25 minutes for you. Are you ready? Okay, the time is yours.
Okay, thank you very much to Mr. Chairman, Dr. Bogi, and of course to our President of ID Indonesian Gastroenterology Society, also Professor Dadang Makmun, that assigned me to give presentation about AUSBD in advanced pancreatobiliary malignancy, how to approach. And thank you very much for the introduction. I think Dr. Bogi also the leading of the endoscopy in Indonesia. In our history, actually the AUSBD is pioneered by 2 doctor or professor that pioneered to puncture the bile duct in 1996, but it is for diagnostic purpose, and also Jacobson that punctured the gallbladder in 2002. But the history of AUSBD actually start by the case report of Giovannini that make a procedure, do the procedure of bile duct access and drainage, a kind of hybrid procedure, because using EUS and ERCP scope to drainage the biliary duct. And this is the first clinical application in 2001, and then gradually developed and mature over the last decade. This is the case report of Professor Giovannini. There is a case of an 56-year-old man with obstructive jaundice, and there is dilated CBD 16 mm, and obstructive jaundice due to pancreatic mass in the head of the pancreas. After doing the ARCP, but the deep cannulation not obtained even after a pre-cut. So Giovannini used IUS scope and ARCP to guide it and do biliary drainage, and then placement plastic stent 10 French through the duodenum, and the CBD drained properly and no complication occurred. This is the picture of the cholangiogram. We see in the left side here the CBD punctured by AUS, and then the dilator or cystotome is dilate the CBD wall, and then the 10 French plastic stent insertion to the CBD, and we can see here the drain well of the CBD through the duodenum, and this is the endoscopic picture of the stent inside the bulbus. And endoscopic retrograde cholangiography (ARCP) usually, even until now, is the current first-line approach for drainage of malignant biliary obstruction. That usually a pancreatobiliary malignancy. But even a success rate is high, but common also difficult cannulation or access due to surgically altered anatomy in patient, or prior duodenal obstruction or stenting, periampullary diverticulum, and if there is a large tumor obstruct the duodenum, so the papilla cannot be accessible, and the failure rate of RCP is about 5% to 10%. The alternative if RCP failure usually is PTBD, but the complication rate is high, about 30%, including fistula formation, cholangitis, and others. The surgery, the alternative is surgery. Of course, surgery gives good long-term patency, but associated with increased morbidity and mortality. AUS guided biliary drainage after Giovannini done and developed and matured, becoming a new technique for therapeutic biliary procedure when ERCP is not successful. The guideline that accept indication of USBD is failed ERCP performed by a referral center with high expertise. So USBD should be done in referral center with high expertise, or in doctor with high expertise and trained well, and altered anatomy or malignant obstruction that can access the papilla or precluding papilla access, and cannulation failed due to tumor obstruction, so the scoop cannot go to the papilla area. And before we know the percutaneous access is alternative is RCP fail, but if percutaneous contraindication such as ascites or USBD becoming an alternative. Now expert consensus and guideline agree that specialist pancreatibiliary endoscopy should perform USBD, but in the backup with surgical interventional radiologists because of still development of risk and complication. But the safety and efficacy becoming improvement with the USBD and new EUS specific tools, and now USBD may not only be feasible as a salvage to failed ERCP, but also as a first-line technique for biliary drainage in malignant biliary obstruction. Compared to ERCP, two important advantages get by USBD. First, it avoids papillary trauma and subsequent risk of pancreatitis. and it does not traverse the malignant structure, hence reducing the risk of tumor ingrowth that ultimately usually leads to stent dysfunction and then the intervention. So this is the indication of the EOS guided biliary intervention. There are two situations. The ampulla can have an ability to reach, or the ampulla cannot to locate. The inability to reach ampulla is such as in postoperative status, like altered anatomy, pyloric stenosis because of tumor infiltration, or duodenal stenosis, or another variants in anatomy. Inability to locate the ampulla, such as extensive ampullary tumor, so the cannulation is difficult. Failed cannulation at the RCP after multiple attempts, also the indication of EOS guided biliary drainage. This is the two category for EOSBD. Papilla can access or papilla inaccessible. This is in papilla inaccessible. This is a compulsory need of EOSBD. Also in now bariatric surgery is becoming more common, and the complication of bariatric surgery is we cannot access the papilla if there is a disorder in the in the bile duct. So EOSBD is an alternative for this kind of situation. So in growing, the name is before is the synonym of EOSBD is many. But now we are common with the term of EOSBD. How we do the EOSBD? The biliary tree can access by two sides. From the left common hepatic duct, that is that's seen in longitudinal section from the lesser curve of the stomach. At this location, the duct is superficial, only 1 to 1.5 centimeter of the intervening liver parenchyma, and the tract is avascular. And the second is the common bile duct, is in cross section from the apex of the duodenal bulb, and usually no intervening blood vessel in the tract. Also, EOS can do puncture the main pancreatic duct also. There are two categories: the intrahepatic approach and extrahepatic approach. The intrahepatic approach is the approach from left hepatic duct. Some study doing EOSBD, and we now familiar with the term with transpapillary or transmural. Transmural is puncture by the intestinal wall via the intestinal wall or gastric wall. This is so there are some type of doing EOSBD. From intrahepatic bile duct, we can go transpapillary with via rendezvous, antegrade, or even transmural, puncture the duct wall and the stain coming into the stomach. From extrahepatic bile duct, we can do also transpapillary, rendezvous, antegrade, and transmural from the intestinal wall. This is the a little illustration. About this is the approach from the duodenal bulb and the needle puncture to the bile duct, usually a little posterior to the duodenum, and then the stent is put. This is from cardia or esophagus distal, approach to the left hepatic duct, and then put the guide wire, and then we can put a stent. This is an illustration of the approach from gastric wall or from duodenal wall, and we can do antegrade stent from left hepatic duct, or here from bile duct, and then stent come out in the intestine lumen, or transmural come out in the stomach from the intestinal wall or gastric wall. This is the appearance of the left hepatic duct that usually punctured from the gastric wall. And then we can put a guide wire and then dilate the wall with usually cautery or non-cautery dilator, and then put stent. And then stent coming from the stomach. We call this AUS guided hepaticogastrostomy. And another is from intestinal wall of duodenum, puncture the CBD, the dilated CBD, and then the stent come out from the duodenum. We can put a stent like this. In the development, some doctor put plastic stent, but nowadays becoming growing some metallic stent that more safe and efficacious, give efficacious. This is a step of EUS-CDS, I think like that. And this is a rendezvous. From rendezvous we puncture, we can approach from duodenal wall or gastric wall, but the guide wire is then pushed coming out to the intestinal lumen, and then by ERCP scoop, so the stent put in the CBD transpapillary. So we call this rendezvous. This is now the new development of EUS guided drainage also from the gallbladder, usually from in patient with cholecystitis that cannot not operable usually, and we can from the duodenal wall or gastric wall we can puncture the biliary. But I think in this situation we need LAMS, lumen approaching metal stent. This is the view of transgallbladder drainage, and then say that the efficacy is similar, EUS guided and percutaneous transhepatic by CT scan. Actually, EUS can puncture also the main pancreatic duct if needed for pancreatic duct drainage. So in 2008, EUS working group is evaluated the hepaticogastrostomy EUS guided, and then this is a picture of our patient that put a stent. We puncture. This is the liver is not so dilated, the left hepatic duct, but still can puncture, and then we can put stent inside from the gastric wall. This is hepaticogastrostomy, and the bile is come out. This is the evaluation of the hepaticogastrostomy. So the technical success is good, and clinical success also is good. And there are several kind of stent that use plastic and covered. This is a study also to evaluate, but this is in a very good center, about 1,000 a year of ERCP. If the ERCP cannot fail to biliary cannulation, but in this study, just in the native papilla, from 524 in this center is very good. The fair biliary cannulation is just 1.7%, and this is the algorithm that used to do EUS-BD. If the distal stricture, they do EUS guided choledochoduodenostomy. This is the result, and there are 3 patients doing AUS-guided choledochoduodenostomy with pancreatic cancer and distal CBD stricture. So in a good tertiary center in this study said that advanced ARCP technique still have a high technical success rate, and they are just need AUS-guided biliary drainage required only in 0.6% of native papilla ARCP. So although a number of excellent indication exists, it should not replace good ERCP technique. But here said all of the EUS biliary drainage was successful in all cases. This is our consensus from the ASEAN Pacific. I think Prof. Dadang also attended here in this. So in Asia Pacific, we use the term of AUS guided biliary intervention with this AUS guided rendezvous ERCP, AUS guided antegrade stenting, AUS guided transmural drainage, AUS CDS, and EUS hepaticogastrostomy. In this consensus, there are a statement that USBD is recommended as the procedure of choice for biliary drainage in patients with failed ERCP if expertise is available and the evidence level is high, and they recommend using the USFN needle of 19 gauge. This is some recommendation. So USBD is recommended, but they also recommend in altered postoperative anatomy or duodenal stenosis that precluding ERCP if expertise available, but antibiotic before procedure is recommended, and 90 gauge AUSFN are used, and do not forget to cooperate with backup of surgery and interventional radiologies because of inherent complication. This is a AUSBD comparing with PTBD. This is a little late, sorry, the screen not come out. Sorry. We can see here why this the screen not coming. Actually the slide is that when AUSBD compared with PTBD, the overall adverse event from AUSBD is 8.8%, and in PTBD 31.2%, and this is significant. So PTBD more risky than AUSBD. This is some study from this is success rate comparing the intrahepatic and extrahepatic approach. Actually, in intrahepatic approach, the complication, the adverse event is more than the intrahepatic. I mean, the intrahepatic is more than the extrahepatic. The screen is not. So now we talk about complication, the potential complication including biliary peritonitis, pneumoperitoneum, bleeding, and slide. And there are some study that this is a complication: biliary peritonitis, bleeding, pneumoperitoneum. There is some study that AUSBD done with even intrahepatic or extrahepatic and many malignancy, and also reason for failed ERCP. yeah, all the procedure is give resolution of jaundice, but some complication occurred like pneumoperitoneum, bleeding, and also bile leak. Some late complication is including migration on occlusion that need reintervention, some with ileus and bilioma and cholangitis, and one with duodenal perforation. Slide. Not working the slide. Oh yeah, this is also the evaluation about AOS-guided hepaticogastrostomy and related transmural intrahepatic AOS-guided biliary drainage. The complication like cholangitis, pneumoperitoneum, and one also death. And this is a study comparing AOSBD with percutaneous transhepatic cholangiography. So even in the AOSBD, the total bilirubin is turned down. So AOS-CDS choledochondrostomy is a viable alternative to PTC with fewer complications and comparable success rate. AOS-CDS may offer a future rate of for novel therapeutic advance. The bilirubin is going down, and there is some study also that figuring the technical success rate and the clinical success that is good, and some early complication of course happen. That the problem with EUSBD, some complication is still happening, but now is going down with the good equipment. Initially the complication is about 20%, but now is becoming turning down about 10%. And in some study also still have 11-16%, but also there are some centers that have no complication. This is comparing the EOSBD and PTBD for malignant biliary obstruction. And the conclusion that EOSBD appear to offer comparable efficacy in patient treatment with malignant obstruction, biliary obstruction, but EOSBD is technically demanding procedure. I think this is in 2012, but in this study EOSBD is comparable with PTBD. But nowadays I think the EOSBD is becoming more preference than PTBD. This is some characteristic of the study in the EOSBD group and PTBD group. And reason of ERCP failure. Now the treatment success is good in EOSBD, even in similar with PTBD, and the bilirubin also going down good. So this is a study comparing also EOSBD and PTBD with patient with unresectable malignant obstruction, and conclude that EOSBD can be an effective and safe alternative to PTBD with similar success, complication rate, cost, and quality of life. This is in 2012, but right now I think there are some study that concluded that the EOSBD is must replace PTBD because of the fewer complication than PTBD. This is a comparative different technique with technical success rate and complication rate, but still EOSBD have some complication rate and even need intervention. This is PTBD and AUSBD in the study that AUSBD is safe. In AUSBD, the adverse event just 8.8%, but in PTBD 31.2%, still in around 30%. But in USBD is becoming decreased the complication.
1 minute.
Oh yeah. Now is coming some modality of the stand that becoming USBD and more safe, efficacy and safe. This is and then some publish also coming about PTBD. This is some publication and this is the advantage and disadvantage of ERCP, PTBD and AUS. AUS have different approach, same session, but AUS can do internal drainage in the same session in if ERCP failed. This is becoming USBD becoming a modality in management of malignant biliary strictures, and this is the algorithm. If the papilla is not accessible, so now USBD, even rendezvous, antegrad, hepatic gastrostomy, or USCD is becoming an alternative, even in the proximal or hilar block, or not working. Yeah, and as a summary, USBD is a safe alternative for biliary drainage in unresectable malignant obstruction where ERCP fails. USBD provide additional advantage because no external drainage catheter, more comfortable, and an option during the procedure in same sedation as attempted in ERCP. Therapeutic AUS, pancreatogastrostomy, and AUS guided biliary drainage represent today an alternative to surgery and PTBD when ERCP fail. And this technique should be performed in centers specializing in therapeutic endoscopy. And rendezvous technique is safe compared to other technique. Transduodenal approach is easier than transgastric. And in transgastric approach, need a larger stent diameter to prevent stent occlusion by foot. Metal stent may be more appropriate for the transgastric approach. And the major advantage of EUS over PTC include the reduced risk of complication and additional benefit of EUCDA's relative ease of performing. And compared to ARCP, EUS avoid papillary trauma and subsequent risk of pancreatitis and does not traverse the malignant stricture, hence reducing the risk of tumor ingrowth that ultimately lead to stent dysfunction and reintervention. Thank you very much.
Thank you, Dr. Fauzi. I think a very nice and comprehensive talk about the benefit of AUSBD, the success and safety. Please, Professor Dada.
Thank you, Dr. Bogi. Yes. Good morning, Professor Nantali. Good morning, Professor Taejun Song. The next speaker is Professor Nantali Posawasti from Thailand. I think now she is one of the very famous world-class gastroenterologists, and she is from the Division of Gastroenterology, Department of Internal Medicine, Faculty of Medicine, Mahidol University, Siraj Hospital, one of the best gastroenterology endoscopy center in Asia. Professor Nantali will deliver a talk with the topic of AUS GBD in acute cholecystitis. When to choose? Professor Nantali, your time will be 25 minutes. Please.
Thank you very much, Professor Dadang. Do you hear me okay? And then can you see my slide?
Yeah.
Okay, good.
Okay.
So once again, I'm very happy to be back again today. Good to see you guys again. And I'd like to take this opportunity to thank the organizing committee for the IDDW 2020 and Professor Dadang for giving me this opportunity. My talk today is entitled EUS Guided Gallbladder Drainage in Acute Cholecystitis, When to Choose. The facts about the treatment of acute cholecystitis include surgical and endoscopic gallbladder drainage are alternative options for patients who are unfit for surgery.
Professor Mentali, I'm sorry. Please share your slide, please.
Oh, you, I haven't.
We have not. Yes, we have not received your.
You did not see my slide.
Okay.
Hang on. So let me. So I'm gonna share screen.
Yes.
Are you?
Yes. Yeah. We can see.
Is there
Yeah. Okay. Perfect. Okay.
All right. I'm sorry. Okay. So I was saying about the where US GP drainage sits in the management of acute cholecystitis. Puncturing of the distended gallbladder using an anti-gauge needle, followed by placement of guide wire. You can do 0.035 or 0.025 basic glide. And we do graduated dilation followed by stent placement. The first transmural gallbladder drainage using a plastic stent and double pigtail plastic stent was reported by Todd Barron and Mark Tafasian, and that was in 2007. The stent options include a plastic stent, nasal stent, or tubular metallic stents, and finally, lumen and pulsing metallic stents, or lens. Just more recently, one-step device has been developed. This device combines the puncturing catheter, and this could be with cautery or without cautery, and dilation device, and also lens. And this device can be used over the wire or freehand technique. A retrospective study from 7 centers was conducted to assess and compare the novel device, which is called Hot Axios, comparing the use of guide wire technique versus freehand technique or direct heart access. What it shows is that when you do direct heart access without guide wire, the procedure can be done within 3 minutes compared to 7.7 minutes if you were to use guide wire. And the significance in the time margin appears to be significant. With the freehand techniques, you can see that it only takes about 4 minutes also to deploy the stent, and the need for fluoroscopic items is less. 41% of the cases did not need fluoroscopy at all during the procedure. Now, I'd like to move on to the clinical outcomes of US guided GP drainage. If you look at the overall outcomes in terms of technical and clinical success, you see that the technical and clinical success is over 90% with an adverse event of 12%. When we and LAMS also have a pretty good technical and clinical success. Everything is over 90% with a reasonable rate of adverse event ranging between 10 to 18%. If I want to show you a little bit more into the detail about the outcome, I want to point out here that if you look at the tubular sense for short and long-term outcome, based on this retrospective study with 63 patients, follow-up period was 275 days. You can see that there is no doubt the technical and clinical success is very high, approaching 100%. You can do the procedure transgastrically and transduodenally. When we look at the follow-up time, the median range of follow-up is 275 days. Very minimal adverse event, I would have to say, with a 3 to 4% of distal migration and nearly 4% of recurrent cholecystitis. But what I like to show here is that patient status on the follow-up, though, 50% of them died, especially for those who did not have a resolution of acute cholecystitis. So just to emphasize that for those who survived the infection, the late adverse event is pretty acceptable, 4%, and the need for reintervention and recurrence of acute cholecystitis is only 4%. What about long-term outcome if we were to use LAMS? A prospective study demonstrated that with a long-term outcome with a mean follow-up of 298 days, out of 30 patients included in the study, we have 90% technical success, 96% clinical success, only 7% with relapsing of acute cholecystitis episodes, and 13% adverse events. So that looks pretty good. So the overall clinical outcomes, I would have to say that it's actually no doubt in terms of clinical and technical success. The long-term outcome data is quite good, although this is in the beginning phase. We would want to see more of the studies showing the long-term outcomes in both mortality and morbidity. Now I'd like to show you the comparison between EUS guided procedure versus percutaneous, which has been around for a long time. This is a retrospective study, but it's a match 1-to-1 with a cohort of 118 patients, 59 patients in each arm. Technical success is very comparable between the two methods. Clinical success is also comparable between the two methods. However, you can see that the adverse event in the EUS guided arm is significantly less than the percutaneous arm. Along the same line, severe adverse events in the EUS arm is significantly less than percutaneous arm, and unplanned admissions related to the need for re-intervention is less in the EUS arm compared to percutaneous arm. A better study comparing short-term outcomes between EUS guided gallbladder drainage using plastic stents and percutaneous. This is a randomized controlled trial out of patients who were unfit for surgery. They were randomized into EUS arm, 30 in the EUS arm, and 29 in the percutaneous arm. Technical success, clinical success will compare, and some of these patients finally underwent laparoscopic cholecystectomy. Some got converted to open cholecystectomy. So I just want to point out that between these two methods, they're pretty comparable in terms of technical success and clinical success. However, and they also are comparable between the ability to send patients for surgery. So with that, I think the newcomer here, which is EUS, seems to provide comparable outcome parameters as the percutaneous. There were some concerns that if you're going to send patients for surgery, would EUS guided drainage prevent the patients to undergo surgery? But based on that particular study, it seems that the patients are still able to undergo surgery. What about comparison between EUS guided and ERCP guided drainage? A retrospective study comparing EUS guided gallbladder drainage using LAM versus ERCP transpapillary drainage using 7 French by 15 centimeter double pigtail stents, demonstrating that if you look at the clinical success comparing EUS versus ERCP, you can see that the EUS has a little bit higher clinical success with a lower rate of recurrent acute cholecystitis, which is interesting. In terms of technical success, they're both comparable, and the adverse events are comparable in both groups. Now, moving on to comparison between the 3 modalities, EUS versus percutaneous versus ERCP. This is pretty much the biggest study, which is a meta-analysis just recently published comparing the 3 modalities. This study included a total of 7 studies with over 300 patients. I like to demonstrate here the technical success and clinical success comparing the 3 methods. The technical success in the endoscopic versus percutaneous, that they seem to be comparable, as well as the clinical success. The adverse event also seem to be comparable. The recurrence rate, however, it seems as though the percutaneous arm has a little bit higher recurrence evidence compared to the endoscopic arm. But if you look at the p-value of statistical significance, you can see here that the technical success, they're pretty. The endoscopic arm seems to be advantageous when you compare with the percutaneous. However, overall seems to be pretty comparable. So with that, I think that the newcomer here EUS guided gallbladder drainage has a pretty good promising data to be comparable to the percutaneous, which has been around for a long time. It's been the almost like a gold standard for alternative treatment. So before we decide which modality we should use, I'd like to show you here the pros and cons of 3 methods. If you look at the technical success, I think that the EUS and PBD are comparable. Percutaneous are comparable. They are equally high. In the ERCP, however, sometimes when the cystic duct is blocked, you cannot perform cystic duct cannulation. So the ERCP technical success dropped a little bit, as shown by earlier study. Clinical success, EUS are comparable to percutaneous. ERCP is acceptable, but again, if the cystic duct is not patent, ERCP outcome might not be as good as the other 2 modalities. Short-term adverse event, long-term adverse event, I think they are relatively low. Long-term adverse event, however, in the percutaneous arm seems to be higher than the other 2, especially infection or leakage. The need for reintervention percutaneous arm seems to be higher compared to the endoscopic modality. The availability, however, is the other way around. EUS is the least available method, whereas percutaneous is available pretty much everywhere. Cost-wise, EUS is quite expensive, especially in this part of the world, in Thailand. Obviously, endoscopic ultrasound is more expensive than percutaneous. So before I finish my talk, I like to conclude with the proposed algorithm here, that if you have a patient with acute cholecystitis who are not fit for surgery, you would look to see whether or not the gallbladder is perforated. If there is a clinical suspicion or imaging suspicion for gallbladder perforation, or the patient is too unstable to tolerate sedation, obviously percutaneous is the way to go, no doubt. Nonetheless, if there is no perforation on imaging and clinically is not suspicious for gallbladder perforation, and if the patient is able to tolerate the sedation, you would consider transpapillary gallbladder drainage as an initial method, which is ERCP guided cystic duct stent placement in the presence of ascites or potential future of surgery, or the patient needs to undergo ERCP for other reasons. For example, they have coexisting cholangitis. You need to take care of the gallbladder, of the CBD stone. Then ERCP is the way to go. If fails ERCP, you can definitely undergo percutaneous. However, if the patient has duodenal obstruction or gastric outlet obstruction, then that's when you would consider EUS guided gallbladder drainage as an initial modality. Obviously, the case should be discussed with the surgeons, because like I said, sometimes if surgery needs to be done, the fact that you puncture the gallbladder may create adhesions, making surgery a little bit more difficult. However, if the patient has duodenal obstruction or gastric outlet obstruction or indwelling metallic stent occluding the cystic duct, or large stone burdened within the gallbladder, sometimes you cannot cannulate the gallbladder or cystic duct, then EUS would be your technique of choice. If fails, obviously, percutaneous gallbladder drainage is your backup plan here. And with that, I hope you have a better idea in terms of where the EUS guided gallbladder drainage sits in the management algorithm of acute cholecystitis, especially in non-operative candidate. I'd like to thank you for your attention, and I'll be happy to answer any questions. Thanks.
interesting lecture. Yeah. And the next, I would like to invite the third speaker.
Hi, Professor Dadang.
Hello. Can you hear me, Professor Nantali?
Professor Dadang.
Okay, now I can hear you.
Okay. So thank you so much for your interesting
Professor
and comprehensive lecture.
Can you hear us? The studio?
Hello. Yes, I can hear you,
I think,
Dr. Bogi.
Prof. Nantali already finished the lecture.
Yeah.
Could we proceed?
Yeah.
Professor Dadang?
Yes. Okay. Okay. Thank you, Dr. Bogi. Thank you, Dr. Bogi. Then I would like to invite the next speaker, Professor Tae-Jung Son from South Korea. Professor Tae-Jung Son from the Division of Gastroenterology, Department of Internal Medicine, Asan Medical Center, University of Ulsan, College of Medicine. Professor Tae-Jung Son will deliver a talk with the topic of the role of IUS BD in surgically altered anatomy. Professor Jun Song, your time will be 25 minutes. Time is yours.
Yes, thank you. Do you hear me?
Yes, we can hear you.
Okay. Can you see my slide?
Yes, perfect. Very clear.
Yeah. Thank you for your kind introduction. And good morning, ladies and gentlemen. In this time, let me talk about the role of EUS-guided biliary drainage in surgically altered anatomy. As you know, frequently encountered surgically altered anatomy include Below 1 distal gastrectomy, Below 2 distal gastrectomy, subtotal or total gastrectomy with wrong-Y anastomosis, or pancreatical duodenectomy. In patients with surgically altered anatomy, a standard ERCP is difficult or even impossible in many cases. So identification of minimally invasive alternative options for this patient population is essential. In patients with below 1 distal gastrectomy, standard ERCP can be performed with a conventional method because the remnant stomach is connected with the duodenum and thus papilla is accessible with the traditional approach. In below 2 distal gastrectomy patients, ERCP can be performed. However, depending on the length of afferent rim and the angulation of the anastomosis, standard ERCP may be feasible but sometimes challenging. We reported the outcomes of ERCP using cap-pitted forward-viewing endoscope in below 2 distal gastrectomy patient. The technical success rate was 87% and clinical success rate was 85%. And according to our recent systemic review, side viewing endoscope and forward viewing endoscope are usually used for ERCP in below 2 distal gastrectomy patient. The success rates of selective cannulation was 95%, very high. But the adverse event rate, such as bowel perforation risk, is relatively high. In patients with wrong-Y anastomosis, standard ERCP is practically impossible because the papilla cannot be reached, while enteroscopy-assisted ERCP may be performed but has a low success rate. Pancreatic duodenectomy consists of removal of the pancreas head, duodenum, proximal jejunum, distal CBD, and gallbladder. Reconstruction is done by creation of pancreatical jejunostomy, choledochal or hepatical jejunostomy, and Roux-en-Y reconstruction. Because the afferent rim is very long, standard ERCP is not feasible usually. Traditional alternative in patients with surgically altered anatomy is percutaneous biliary access. More recent alternative to biliary access include enteroscopy-assisted ERCP or US-guided biliary access. Percutaneous cholangioscopy can show bile duct region with a high-quality image like this. Biopsy can be performed on the direct endoscopic image. In this patient, endobiliary RFA for record tumor and subsequent stent insertion can be performed at the same session. You can see the aberrated tumor and the stent by cholangioscope. And various procedures such as stone removal or stricture dilatation also can be performed. However, percutaneous cholangioscopy has disadvantages that it needs external percutaneous tract. The tract maturation time needs more than 2 weeks. Usually multiple procedures are required for percutaneous cholangioscopy. Enteroscopy-assisted ERCP, EERCP, is a labor-intensive procedure with suboptimal technical success rate. The technical success rate is about 60%, and adverse event rate is not low, more than 6%. Recently, US-guided biliary drainage have been used more frequently. As you know, US-guided biliary drainage can be divided into 3 basic approaches: transluminal stenting, antegrade stenting, and rendezvous technique. In patients with surgically altered anatomy, because endoscopic approach to papilla is very difficult in many cases, US-guided rendezvous technique is challenging, is not usually feasible. The US-guided transluminal stenting can be divided into 3 types. In hepatico-duodenostomy, stents are inserted from duodenum to right intrahepatic duct. In choledochal-duodenostomy, stents are inserted from duodenum to the CBD. In hepatico-gastrostomy, stents are inserted from stomach to left intrahepatic duct. Let me show you the hepatico-gastrostomy case in a surgically altered anatomy patient. In this patient, the tumor recurred at the hepatico-jejunostomy site, and a metal stent was inserted. 6 months later, the stent was obstructed, so US-guided hepatico-gastrostomy was performed. Needle puncture was performed at the left B3 duct. Contrast media was injected, and 0 to 5-inch guide wire was inserted in this patient. Tract dilatation was performed with a hurricane balloon, and a fully covered metal stent was inserted. To prevent stent migration, usually long-length stent, more than 9 to 10 centimeter, is usually used. Let me show you the hepatico-duodenostomy procedure. In this patient, bilateral metal stents were already inserted. I'm sorry. bilateral metal stent already inserted at the left intrahepatic duct and right anterior duct, but cholangitis occurred at the right posterior duct. Using EUS from duodenum, dilated right posterior duct was punctured. And guide wire was inserted first at the right posterior duct. After confirmation of right posterior duct puncture, contrast media was injected. Cholangiogram showed dilated duct. After tract dilatation with the hurricane balloon, a metal stent, 6 millimeter and 10 centimeter length stent was inserted. However, in most surgically altered anatomy patients, transduodenal approach is not feasible due to the previous resection of duodenum or extrahepatic bile duct. So usually, hepaticogastrostomy is usually used in surgically altered anatomy patients. Published data for hepaticogastrostomy show overall technical success rate of 87% with overall early adverse event rate of 27%. Adverse events include pneumoperitoneum, periperitonitis, abdominal pain, perforation, cholangitis, bleeding, or liver abscess. But in recent studies, the adverse event rate has decreased a lot as experience increases and technique advances. ERCP is performed through the natural orifice from duodenum, ampulla, and bile duct. It is a closed track, so there is little risk of bile leakage. On the other hand, EUS-guided biliary drainage make a new fistula track between gut lumen and bile duct. So it is not a closed track. It is an open track to the abdominal cavity. So bile leakage into the peritoneum can occur during or after procedure. Especially a stent migration causes serious adverse event. The stent migration can occur because of the movement of liver and stomach due to the respiratory movement and peristalsis of stomach. And shortening of metal stent after stent deployment can cause the stent migration. To prevent stent-related adverse events, several kinds of specially designed tubular metal stents and plastic stent for US-guided biliary drainage have been developed and actively used. In surgically altered anatomy patients, US-guided antegrade stenting can also be performed in addition to transluminal stenting. Transluminal stenting means the stents are inserted between gut lumen and obstructed bile duct. And antegrade stenting means that stents are inserted at the strictest site of the bile duct using EUS-guided puncture of bile duct, guide wire insertion, and stent insertion through the guide wire. Let's look at the antegrade stenting. Using EUS, dilated left intrahepatic duct was punctured and guide wire was inserted. Then FNA needle was changed with a catheter and the guide wire was negotiated into the to insert into the duodenum. After balloon dilatation at the stricture site, a metal stent was inserted at the distal CBD. In US-guided transluminal stenting procedure, conventional tubular stent or specialized stents are usually used. In antegrade stenting and rendezvous technique, conventional biliary tubular metal stent usually used. A recent study compared the outcomes of US-guided antegrade stenting and percutaneous biliary drainage. Technical success rate was very high, about 97%, and clinical success rate also very high, 97% and 93% in PTBD. Adverse event rate of antegrade stenting was just 11%, and that of PTBD was 27%. The adverse event rate of antegrade stenting has decreased a lot compared to the past. Pancreatitis was the most common adverse event in both groups, and drainage tube-related adverse events usually occurred in the PTBD group. Recurrent biliary obstruction rate was not significantly different, about 14% and 10%. Stent patency duration was 130 days in US-guided antegrade stenting and 105 days in PTBD group, but it's not significantly different. Recently, through US-guided hepaticogastrostomy route, various procedures have been tried, such as stone removal, stricture dilatation, and biliary biopsy. This is the case of stone removal through hepaticogastrostomy stent. 1 or 2 months after stent insertion, the spyglass was inserted through the hepaticogastrostomy stent, and cholangioscopy-guided electrohydraulic lithotripsy was performed. Then stone was removed by pushing the balloon catheter to the duodenum. Some authors have proposed a two-stage procedure for benign indication. The first stage is creation of hepaticogastrostomy stent. Then wait for 1 to 4 weeks until the tract is maturated. After tract maturation, antegrade biliary access was tried using a duodenoscope or cholangioscope. Let me show you the maturated hepaticogastrostomy tract. In this patient, the hepaticogastrostomy stent had to be removed 2 weeks after hepaticogastrostomy procedure. But because of the risk of bile leakage after stent removal, so I consult my surgeon, laparoscopic surgery. You can see the hepaticogastrostomy tract, and the tract was dissected. As you can see, fistula tract between the liver and stomach can be made 2 weeks after stent insertion. So we can try endoscopic procedure through this fistula tract, like percutaneous tract. And this is the metal stent previously inserted, long metal stent. And then hepaticogastrostomy tract was dissected completely. And stent, this is the stent insertion site of the stomach. The stent insertion site was sutured. And the opening of liver was coagulated in this patient. So using this hepaticogastrostomy track, various procedures can be performed. In this patient, the hepaticogastrostomy stent was removed 2 months after stent insertion. Using standard duodenoscope, cholangioscopy was obtained. The anastomosis site stricture was detected on cholangioscopy, but it's very tight stricture, so guide wire could not pass the stricture site. So a direct per-oral cholangioscopy through the hepaticogastrostomy, the track, using an ultra-slim endoscope was performed. You can see the stricture site. The guide wire could be passed into the jejunum through the anastomosis site, and the stricture was dilated with an 18 millimeter balloon catheter. This is the case of US-guided drainage for afferent roof syndrome. You can see the dilated afferent rim on CT scan. On EUS from stomach, dilated afferent roof could be observed. After needle puncture, bile juice and pancreatic juice were aspirated. A specially designed, partially covered metal stent was inserted from stomach to the afferent roof. And you can see the decompressed afferent roof after stent insertion. This is the partially covered metal stent. Recently, US-guided transenteric ERCP were reported. The patient had history of Whipple's operation in 10 patients and Roux-en-Y hepatico-jejunostomy in 6 patients. The fistula track was made between the stomach or duodenum to the afferent rim with rams, axial stents, with a diameter of 15 or 20 millimeter. And newly created fistula track allowed integrated passage of standard duodenoscope to the papilla or anastomosis site. So the technical success rate of ERCP was very high, 94%. But I think these procedures are still technically challenging, so further experiences are needed. This is the suggested algorithm for US-guided biliary drainage in surgically altered anatomy patients. On cross-sectional imaging, intrahepatic duct dilatation is very important to decide the treatment method. If intrahepatic duct is dilated, US-guided antegrade stenting can be tried first. If antegrade stenting is unsuccessful, hepaticogastrostomy, transluminal stenting can be tried. If it is unsuccessful, then rendezvous technique can be tried. And finally, if rendezvous technique is unsuccessful, finally transenteric stent can be tried. If intrahepatic duct is not dilated, extrahepatic approach, if possible, can be tried, and rendezvous technique, transenteric ERCP can be tried. But actually, it may be technically challenging. In conclusion, US-guided biliary drainage is a safe and effective, minimally invasive method of biliary drainage in patients with surgically altered anatomy. But several shortcomings still need to be addressed. Thank you for your attention.
Thank you very much, Professor Tae Jung Song, for your interesting and inspiring lecture. Yeah, Dr. Bogi, please.
Okay, thank you, Professor Dadang. Now we enter the question and answer session. I think there is a lot of question already in our list. I will read all the question. Our first question is for all speakers. AUSBD have a better safety profile than ERCP and BTBD. Actually, what is the main complication of AUSBD in your experience, and what can be done if we found there's complication? I think Professor Nantali, you can answer the question first, please.
Am I audible? Okay, good.
Yeah, yes, we can hear.
So the question is about complications of EUSBD, right? EUSBD. In my experience, when I started doing EUSBD or even EUSGBD, obviously bile leak, that's one of the common side effects or complications that I've encountered. Air leak, I don't want to say perforation because it's, we perforated the lumen. So you would see air in the abdomen. So after the procedure, the patient may have a little bit of abdominal discomfort, abdominal distension. When you do an X-ray, you see some pneumoperitoneum. So that's one of the things that I've seen. The other thing would be more like a technical issues during the procedure. For example, stent deployment. Sometimes it goes in too deep. Sometimes it doesn't go in a good position. So basically, what we can do to prevent or to manage these complications is that for bile leak, Professor Song had already mentioned that fully cover metallic stent or even lamps that would help preventing bile leak very well. For perforation or for air leak or for stent migration, you can address that issue by putting a double pigtail stent inside the metallic stent after you deploy it. In terms of the technical issues like difficulty with the stent deployment, I like to do, like when I do HBS, when I do hepaticogastrostomy or choledochoduodenostomy, now I like to open the stent inside the scope, and once the stent is fully open, then you push the stent out. I think that's a good way to avoid a lot of technical issues during the stent deployment. Other than that, delay complications like infections, recurrent cholangitis, I think you're going to have to deal with going back in and try to clean up the track of the stents.
Okay, thank you, Professor Nantali. And Professor Song, what about you? You're also performing in a condition of altered anatomy. What do you think is the most common complication and how you prevent the complication?
I agree with Dr. Nantali. The most serious and common adverse event is bile leakage and biloma. So prevent the bile leakage, I prefer fully covered metal stents, and I prefer long stent, more than 10 centimeter. And usually some authors suggest that the rings of the stent in the stomach have to be more than 4 centimeter to prevent migration. And we need special stent to prevent stent migration, especially inward stent migration, means the bile leakage and stomach perforation. So it's very serious complication. And I have not experienced that complication, but if the stent is migrated into the peritoneum, we consult to the surgeon, where sometimes we can overcome that, puncture the stent in the peritoneum by EUS-FNA and do the repeat the EUS-guided drainage procedure through the migrated stent. But it is not easy. So bile leakage and prevent stent migration is most important tip. And I think the bleeding is another problem during the procedure, especially during the hepaticogastrostomy. There may be bleeding because of the hepatic artery and portal vein is very close to the bile duct. So during EUS-guided HGS, to prevent bleeding, I prepared the cold dilatation using the hurricane balloon or booge rather than the cystotome or needle life. Thank you.
Okay, thank you, Professor.
Dr.
And
Bogi?
now for Dr. Ahmad Fauzi.
Dr. Bogi?
I think other than pancreatobiliary malignancy and malignant stricture, does AUSBD have a roles in other disease of a pancreatobiliary tract? Maybe a benign stricture or another thing. Do you have anything about experience about that, Dr. Ahmad Fauzi?
Ya udah, jawab aja. Singkat aja. Ya. Dr. Bogi, can you repeat the question?
Sorry. Other than the malignancy or malignant stricture, is there any other roles of AUSBD in the disease of a pancreatobiliary tract?
Yeah.
Can you hear my voice, Dr. Fauzi?
Yeah, yeah.
There are some actually AUSBD in now is still used in especially in malignant biliary stricture, but I think there are some potential application for AUSBD in the benign situation. What in our experience is sometimes AUSBD is very helpful if we have a patient with even get complication after operation. And I think as Professor Tai Jun Song said that some altered anatomy or damage of the biliary injury.
I think Prof. Dadang, is there anything to...
Thank you, Dr. Bogi. I think the last question I would like to address to Professor Nantali. Regarding to your experiences in Indonesia, especially, the availability of metallic stents is limited maybe in most centers, and in the procedure of IUSBD, we sometimes, or maybe mostly, use plastic stent rather than metallic stent. So, what is your opinion regarding to the complication between both modalities? It is lower complication if we use metallic stent compared to plastic stent?
Yeah, thanks, Professor Dadang. Based on the reported complications in terms of the comparisons between double pigtail plastic stent versus metallic stents, including both fully covered tubular stents and LAMs. In the EUS guided gallbladder drainage, with the plastic stents, you see a little bit higher complication rates in terms of bile leak compared to the metallic stents. And the reason being that with the plastic, obviously the bile gets leaked easier, and Professor Song had also mentioned that as well earlier. So, but if we have a limitation, like here too, in Thailand, metallic stents are more expensive than plastic. But due to the higher rate of bile leak complications, I think that if you have an opportunity to do a metallic stent, I think that would be preferential. But you can also get by with using plastic stents. I think that if it's just small leak, doesn't cause any peritonitis, I think we can treat that conservatively with antibiotics, make sure that you treat them properly. I think that plastic stents is still has its role in the biliary drainage procedure, EUS guided.
Yeah. Thank you. And then the last question to Professor Song. Regarding the complication of all IUSBD procedure, is there any tips for us to minimize the risk of complication?
The most important is Nantali already mentioned. The stent deployment is usually done in the working channel of the scope. So during the procedure, usually see the EUS view, and the stent deployment was performed in the working channel of the scope. Then push the stent very carefully to the gut rumen. Is most important thing. When in the past we see the stent deployment by endoscopic view, but in that position we can lose the scope position. So sometimes we lost the guide wire and the bile leakage, and we have to do the procedure from the beginning. So one of the most important thing is the stent deployment in the working channel. And number two is I prepare the covered metal stent to prevent the bile leakage. And number three is the cold dilatation rather than the hot system, especially for the hepatico-gastro or hepatico-duodenostomy to prevent bleeding. And they use the long length stent to prevent stent migration, especially inward migration.
Yeah. Thank you. Wonderful. Wonderful answer. Wonderful tips for us. So I think, Dr. Bogi, we have to close this session. We know that there are so many questions arising from the audience, but we have to close it because of the limitation of the time. Please let me extend my sincere thanks to Professor Nantali, Professor Tae Jung Son for your great support to this IDDW. And we hope in the future you can still share your expertise in the next scientific event in our country. Thank you so much, Dr. Fauzi, Dr. Professor Nantali, and Professor Song, and also Dr. Bogi from Malang chairing this session. Thank you so much.
Thank you.
Thank you so much.
Thank you, Mr.
To all
Nantali.
speakers and moderators, we will have a photo session.
Thank you.
So to all speakers and moderators, could you look forward, because we will have a picture taken. So I will count in 1, 2, 3. Capture. Okay, once again, thank you very much for all the speakers and moderators. We will continue the program. For the next lecture,
No sound.
Professor
No sound.
Hello.
Organizing committee, no sound.
So next lecture will be moderated by Professor Marcellus Simadibrata, MD, PhD, from the Division of Gastroenterology, Department of Internal Medicine, Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo Hospital. To Professor Marcel, the time is yours.
Thank you, Dr. Saskia. Good morning, everyone. My name is Marcellus Simadibrata. Good morning, Professor Dongwan Seu. Today, this morning, we will have plenary lecture 3 for 30 minutes with the title Endoscopic Ablative Therapy for Solid Pancreatobiliary Malignancy. The speaker will be Professor Dongwan Seu. His current position is Chairman of Department of Gastroenterology, University of Ulsan Medical College, Asan Medical Center, the largest teaching hospital in South Korea. He's now also the director of the Digestive Endoscopy Center and one of the organizing in WEO. Please, the time is yours, Professor Dongwan Seu. Please give the speak and the lecture.
Thank you, Professor Marcellus. It's my real pleasure to join this wonderful meeting. I joined ERCP US teaching session on Friday, and this is the main lecture session for me. My special thanks goes to Professor Tadang Makfung giving me this wonderful opportunity. The title assigned to me is Endoscopic Ablative Therapy for Solid Pancreatic Malignancy. These are the areas I'm going to cover during next 30 minutes. Endoscopic ablation also includes ERCP guided biliary RFA, but because of the time limit, I just want to focus on these two areas. Firstly, US guided ethanol injection for solid pancreatic tumor. This is the first case. This is 99-year-old male patient showing recurrent attacks of hypoglycemia. The patient was referred to emergency room because of recurrent hypoglycemic attack. At the time of hypoglycemia, they checked C-peptide and blood insulin level, and it was elevated. It's not normal response, so there is strong suspicion for the presence of insulinoma in this case. But when they checked, endocrinologist checked the CT scan, but there was no identifiable mass in the pancreas. So this patient was referred to me to do US examination. And this is US image. I checked pancreas body and tail, but there was no mass in the body and tail. In the head of the pancreas, as you see here, there is hypoechoic lesion. This is head area. This is hypoechoic lesion in the head of the pancreas. So it was about 1 cm size, small mass, but showing prominent symptom, recurrent attacks of hypoglycemia. We did contrast enhanced US to check whether this lesion shows typical neuroendocrine type contrast enhancement pattern. For neuroendocrine tumor, when we inject contrast, it usually shows very strong arterial enhancement. As you see here, after contrast injection, 15 minutes later, we can see strong arterial enhancement. This finding is consistent with neuroendocrine tumor, including insulinoma. So we suspected this lesion is actually the culprit lesion causing recurrent syncope. But the next question is, how can we treat this case? This is 99-year-old gentleman, almost 100-year-old man. Usual treatment would be operation, but I don't think it is the right decision to do operation in this case. The lesion is in the head. Minimal operation would be PPPD. I think this is too risky for this very old man. And chemotherapy may not be adequate treatment. And observation is not possible because the patient shows recurrent collapse. So we decided to do US-guided ethanol injection on this case. This is EUS view, and this is the needle track. This is hypoechoic area. I already injected small amount of ethanol into the bottom half of the hypoechoic mass. Now I am injecting another 2 millimeter of ethanol into the upper half of the lesion. And then we checked, we followed the contrast enhanced EUS. Left side is before treatment, and the right side is 3 days after treatment. You can compare, same area. This is before treatment, and this is after treatment. If you see before treatment image, after contrast injection, we can see clearly very strong arterial enhancement on this part here. But on the other hand, after treatment, we cannot see any contrast enhancement on this part. So based on this finding, we thought this lesion was effectively ablated, and the patient was discharged. And thereafter, the patient never had hypoglycemic attack. So I think EUS actually gave a lot of benefit for this almost 100-year-old gentleman with a recurrent hypoglycemic attack. And this is another case, a 50-year-old female patient showing pancreatic solid pseudopapillary neoplasm in the head. If you see this MR image, there is clear mass here. So we did the EUS-guided ethanol injection therapy, and this is 2 days after therapy, and this is 4 months after therapy. You can identify the size decrease progressively, and this is 8 months after therapy. So it can palliate the lesion very effectively. And this is Taiwan live case 2012. We can, on this CT scan, we can see contrast enhancing small mass in the body of the pancreas here. So we did the ethanol injection, and after ethanol injection, the Taiwan team took CT scan. As you see here, there is a low attenuation changes after treatment. And then this is 6 months after they followed CT scan. We cannot identify any neuroendocrine tumor on this CT scan. So if you use ethanol wisely on the EUS guidance, we can ablate a small solid pancreatic tumor like insulinoma, and there has been a sporadic case report on this. What are the indications of ethanol injection? Probably benign small tumors like insulinoma or neuroendocrine tumor or solid pseudopapillary neoplasm. But there are some issues of ethanol injection. We may assume that if we inject ethanol through the 19 gauge or 22 gauge needle or 25 gauge needle, we may assume that injected ethanol can spread out evenly, spherically in the tumor. But it's not true. If there is any loose tissue plane, then the ethanol leaks through that plane and go outside of the lesion. This is a pig pancreas experiment. So if there is any tissue inhomogeneity, then it's going to be difficult to inject evenly into three-dimensional structure. So I one time thought we use this kind of FNA needle for ethanol injection. One day I thought probably it would be better to use this CPN needle. This is CPN needle. And when we inject contrast, then the contrast can go several different directions, and it can easily cover the mass three-dimensionally. So I used that needle for this head neuroendocrine tumor, but at the time of the injection, we cannot see the ethanol going through different directions. EUS plane just gets one plane. So it's going to be difficult to identify. And after that, the patient developed severe pancreatitis. So after this case, I abandoned the CPN needle. I want to check the ethanol injection on the EUS view during whole procedure. So there are issues. Method of injection of ethanol is not standardized yet. We don't know still the adequate amount of agent. Some people suggest that we'll calculate the volume and the same amount of ethanol is good, but I'm not sure whether this approach is good enough. We need to do more study on this. and there can be some remnant viable tumor. So we need to develop other methods also. And the next topic is US-guided RFA for tumors. RFA is very popular for hepatic tumors. Percutaneous RFA has been done for a long period of time by interventional radiologists. It is composed of RFA electrode and generator. This is electrode, this is generator. When you apply the power, then from the tip of electrode, RF voltage difference can be made, and it can oscillate according to the frequency of RF pulse. Then the oscillation can create the tissue ionic oscillatory movement, and it can be converted into local heat near the electrode. This is the mechanism of tissue ablation of RFA. Luckily, we had a Korean company. They already have the skills of making RFA device and experience and the facility. So we started to do collaboration with the StarMed company and started the in vivo study first. So with just rough electrode design, we tested 30 watts, 50 watts, 80 watts, different power setting, and also 60-minute ablation, 12-minute ablation. And then we checked the volume of ablation and the cross-sectional area of ablation. And also we tested 5mm electrode, 10mm, and 2 cm electrode, and checked the volumetric data. This was actually basic the data set before making in vivo RFA device. And then we moved to porcine pancreas ablation. This is porcine pancreas, and at this time of experiment, we used the 18-gauge needle. It's very thick electrode. We used this needle on the USB, and this is porcine pancreas. After needle insertion, when you apply the power, then we can see echogenic bubble formation at this part. You can see the bubble formation. This means this area is ablating now. After ablation, we did autopsy, and we can identify about 2 cm size spherical shape ablation area. When he did the histologic examination, the necrotic area clearly demarcated from normal pancreas by fibrous wall like this. So we reported this result in GI 2012. After that, we designed the human experiment. But during the experiment, you also experienced some of possible complications. One is perinephric fibrosis. The other case was perigastric adhesion or gastric burn. So we learned that it is very important to do very cautiously RFA, not to create a lot of complication around the RFA area. And then we thought about human RFA. This is schematic video. How can we do pancreatic tumor RFA? We can use EUS view. And then on the EUS view, you can identify the mass or tumor inside the pancreas. And then if it is identified by EUS view, then we can use electrode like this and start ablation, one deeper part first, and then remove the electrode to the superficial part, and then change the needle direction to cover unablated area. And if we repeat this, then we can create the whole area ablation. This was the concept. But starting human clinical trial was quite difficult because of the ILB issues. We submitted the protocol for advanced pancreatic cancer, but the ILB actually asked a lot of revisions and raised a lot of questions. So there has been a lot of back and forth revision and resubmission, revision, resubmission. But finally, we got the approval. But this is the ILB approved inclusion criteria. Histologically confirmed pancreatic cancer, and it should be advanced and unresectable pancreatic cancer. Even though it is unresectable, we cannot apply RFA directly. Chemotherapy should be done first. If the chemotherapy fails, then that's the time we can enroll the patients to our study. So we were able to enroll this case only at the last moment of the pancreatic cancer. But anyway, we were able to start human trial. This is the first case, one of the case, a 60-year-old male patient, and showing locally advanced borderline resectable pancreatic cancer here. So we did neoadjuvant therapy and also metal stent guided SBRT. After therapy, we can see marked size decrease. So we sent this patient to surgery, but when the surgeon opened the abdomen, there was undetected omental seeding. So they did ONC, and the patient was transferred to oncology department, and the oncologist did second-line therapy using FOLFOX regimen. But even after second-line therapy, the disease showed progression. So this patient was referred to our study protocol. So we decided to do EOS-guided RFA therapy. And this is at the time of RFA therapy. This whole area is tumor, the large tumor, and this is electrode. And we inserted 18 gauge electrode. At this period of time, the electrode was very thick, 18 gauge, and stiff. But we were able to insert the electrode into the deeper part of the pancreatic tumor, and we started the ablation. The power setting was 50 watts, and the one-side ablation just 10 seconds. We used continuous mode, and we did 8 different side ablation. After that, we checked CT scan 1 day later. We can see necrotic area here. And then 1 month later, there is some cavity formation here and here. And 2 months later, this is left side is 1 day later, and this is 2 months later. We can see a lot of tumor mass is disappeared on this part, but there is some cavity formation here. So we were able to see that we can create a large volume reduction, even for advanced pancreatic cancer. So we reported this result in GIE 2000. Also GIE, and our conclusion was EOS-guided RFA could be technically feasible and a safe option for patients with unresectable pancreatic cancer. But this is not the all. What I mean is we just tested initial technical feasibility and safety. It's not the type of study to see the long-term survival and survival benefit. So this is just pilot study. But when we go to the unresectable pancreatic cancer like this case, the tumor mass is already abducted to very critical structures like IVC or SMA, SMV, or celiac artery. So we cannot ablate the whole tumor by RFA alone. Then we changed our target to benign pancreatic tumor. This was one of the case, a neuroendocrine tumor case. This patient was MEN, and the patient received multiple operations, including pancreatectomy and ependymoma, syringomyelia operation, parasite operation. And at the resection margin, there is another neuroendocrine tumor. The patient refused any more surgery. So we decided to do RFA, and this was at the time of RFA, and the electrode was inserted into deeper part and the right side of the lesion first, and the one side ablation, and retract the needle to the superficial side, and then change the needle direction to another part, and then create ablation and ablation. And this is 1 month after ablation, we can see necrotic area. And this is 9 months after, we can see marked size decrease. Macroscopically, we don't know histological complete resolution, but at least CT-based or MR-based image shows very good response. This is another case, 69-year-old pancreatic neuroendocrine tumor case. Initially, the lesion was detected, but initially we decided to follow, and 4 years later, the lesion became large, a little bit larger than the initial CT. So the patients were worried about, became anxious, and refused surgery. So we decided to do EOS-guided RFA, and this is at the time of RFA. And we can identify hypoechoing mass here, and the electrode is inserted. inside the tumor, and we started RFA activated RFA generator with a 50 watts voltage, and the one side ablation is generally 10 seconds. After one side ablation, we can change the direction, angle, and the target unablated area. And after one plane ablation, we remove the electrode and try to find out different plane and try to create ablation. The procedure was repeated to sufficiently cover the whole tumor. And then at the time of ablation by beam mode image, it looks like most of the area are ablated because ablation, RFA ablation can create echogenic bubble and it can spread out. So by beam mode image, it looks like almost all the tumor was ablated, but when they do contrast enhanced EUS, sometimes there are viable tissue. This is several days later, we did contrast enhanced EUS, and this area is ablated, but this area, there is still viable tumor vessel. So we started to do ablation on this unablated area. So second line EUS guided RFA was performed, and then the lesion was mostly disappeared. When he did 10 patients with NET or SPN insulinoma RFA, 70% of the patients showed complete response morphologically based on CT or MR. We don't know histologic CR, and the 3 patients shows incomplete response. This is one of the case, SPN case confirmed by EUS guided FND, and the patient refused surgery, young patients. The minimum surgery was PPPD, single unmarried female patient refused surgery. So we did EUS guided RFA on this lesion. And then 6 months later, the lesion showed size decrease here. And 1 year later, more decrease. And 18 months later, little more decrease. So we can palliate the lesion effectively. And we reported this result in endoscopy 2018. If you look at other data, there has been case reports from 2016. And also if we go to the PubMed literature search, there are slowly more researches are done on this part. We can apply RFA for pancreatic lesion also. This is adrenal tumor showing typical cushingoid feature, buffalo hump, moon face, and the laboratory finding shows unsuppressible cortisol level increase, and the CT scan shows the left adrenal mass here. So the patient refused surgery. We decided to do RFA. This is left adrenal gland on the EUS view. Left kidney is here. Left adrenal gland is very close, just outside of the stomach wall. So it can be an easier target for the EUS guidance. And then we also, after one time ablation, we did the EUS guided contrast enhanced EUS. And then we tried to find out unablated area on this right side contrast enhanced EUS view. We can see ablated area showing non-enhancement at all, but this area, there is still enhancement. So based on this finding, we did contrast enhanced EUS guided RFA of this lesion. And then we can see marked cortisol decrease and urine cortisol and the serum cortisol decrease. So it can be used for various tumors. But there are some technical issues, unsolved problems. One is device. This is PubMed EUS guided RFA probe. There is another type of RFA, EUS guided RFA probe. It is Habib probe. This one is a 19 gauge. Nowadays, it is 19 gauge electrodes. This one is 1 French, very thin electrode. So this one, the disadvantage is stiffness. But this one can go anywhere inside the needle. So Chinese group use this Habib probe to ablate a cystic tumor and also neuroendocrine tumor, and they reported very good results. But this lesion, this STAR-made electrodes cannot go through this kind of angle. This is the limitation of this type of needle, but this needle can go in. But the problem is this needle is just one branch. It's not steep enough. When the electrode was exposed from the needle tip, it easily bend because the patient respirates and there is aortic pulsation. So does not show a straight line anymore once it is exposed. So it is the limitation. And also the ablation volume, RFA STAR-made needle can create ellipsoid spherical ablation, but this Habib probe can create just thread-like thin linear ablation. So ablation volume is quite limited for Habib probe. And another issue is complication. This is small neuroendocrine tumor about 1 cm, and we did not pay full attention at the time of the MP RFA. The lesion was very close to the main pancreatic duct. We carefully tried to do RFA on this 1 cm lesion, but after the procedure, the patient developed pancreatitis. So we need to pay attention to the main pancreatic duct. If you ablate the main pancreatic duct, there can be severe pancreatitis or pancreatic stricture and sequelae. And this is surgical series when surgeons actually did intraoperative RFA, but when they did not pay attention, full attention for the complication, they created serious complications like severe necrotizing pancreatitis, life-threatening hemorrhagic complications. And also, if you see this Chinese report, the mortality rate was up to 25%. Not at the time of ablation. After the ablation, the patients can develop coagulation injury of the main portal vein, and massive GI hemorrhage was the cause of death. So we need to be very careful. These are possible potential complications: pancreatitis, MPD stricture, operation, bleeding. And remember, pancreas is very close to vital organs like SMV, SMA, celiac artery, duodenal jejunal wall, and IVC. So when we are doing RFA, we need to remember these facts. Lastly, I want to mention about combination therapy. When the pancreatic cancer is unresectable, it is already abutting or infiltrated into critical arterial structures or venous structures. So we cannot ablate the whole tumor. If you do RFA, then near the electrode, this area is high heat is generated area. So most of the cells can be dead by local heat. But this area also, there is temperature increase. So heat-induced damage or changes of the tissue characteristics can happen around this area. We can use these characteristics wisely. So some radiologists actually did this type of experiment, RFA, thermal ablation area, and at the time of RFA, they injected the chemotherapeutic agent, doxorubicin, liposomal doxorubicin, and the RF ablation effect and the chemotherapy effect can be increased. These two therapy can act synergistically. By doing RFA, we can ablate this inside the tumor by thermal ablation, but outside, because the tumor vessel is disrupted, when you inject contrast chemo agent, then the chemo agent local delivery can be increased. So the necrosis area becomes large. Left side is RFA alone, right side is RFA plus chemo. We can see a larger volume is affected by this type of therapy. So we adopted this concept for human pancreatic cancer. We conducted a pilot study and we applied for locally advanced unresectable pancreatic cancer. At the time of RFA, we also injected gemcitabine and cisplatin chemotherapy, and we continued this RFA in the chemotherapy, and sometimes we added SBRT, And then we've analyzed the results. 1 year survival was 71%, 4%, 71.4%, and 2 year survival was 56%, and the median survival was 750 days, more than 2 years. It is unresectable advanced pancreatic cancer, not metastatic. I think this result, median survival more than 2 years, is, I think, quite encouraging. So we need to do more study on this. EUS-guided RFPG can target other areas, hepatic tumors, adrenal tumors, or retroperitoneal mass and renal mass. When it goes to the retroperitoneal or renal mass, when we do percutaneous approach, there is a long distance to travel. But when you go inside the stomach, then it is very close distance. This is my final conclusion slide. Endoscopic ablative therapy is continuously evolving, and refinement are actually needed. But when we use this technique wisely, and it can be very effective in selected group of patients with acceptable level of post-procedural complication. But further studies are required to increase the efficacy and avoid complication. Thank you very much for your kind attention.
Thank you, Professor Dong Wan Seu, for the good lecture and very interesting lecture. Because of plenary, there will be no discussion, so we will have to stop this session. And thank you very much, Professor Dong Wan Seu.
Thank you very much for giving me this opportunity. I enjoyed very much.
To Prof. Marcel.
Thank you. We will give the time to the Dr. Saskia.
Okay. Thank you to Prof. Marcel and Professor Dong Wan Seu. To all professors, we will take photos. So if you may look into the camera, and we will take a picture in 1, 2, 3. Capture. Okay. Thank you very much to all of the speakers.
Thank you.
To all of the professors for a very nice lecture. Ladies and gentlemen, now we will continue our next program in Symposium 6 with the topic of challenges and treatment modality in the management of IDD, sponsored by Takeda. For this symposium, it will be moderated by Professor Marcellus Simadibrata, MD, PhD, from Division of Gastroenterology, Department of Internal Medicine, Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo. To Professor Marcellus Simadibrata, the time is yours.
Yeah. Thank you, Dr. Saskia. This morning we will have Symposium 6 with the topic challenges and treatment modality in the management of inflammatory bowel disease. And for the speaker, there will be Professor Murdani Abdullah, MD, PhD, FSCG, FSGE, with the topic current situations of IBD in Southeast Asian population. And then after that, there will be Professor Dadang Makmun, MD, PhD, FSCG, will speak about the value of gut-selective biologic agent in Crohn's disease management. And the third speaker will be Prof. Mangestu Adi, MD, with the topic ensuring rapid and sustained efficacy in ulcerative colitis with gut-selective biologic agent. So we will have the first speaker, Professor Murdani Abdullah. Please, the time is yours to give the lecture. Professor Murdani. Professor Murdani. Professor Murdani.
Yes. Prof. Marcel, can you hear me?
Yeah. Yes, I can hear you. Professor Murdani.
Okay. Yeah. Sorry, I can. Yeah. Well, thank you, Professor Marcel, This is a great honor for me to talk under the chairman of Professor Marcel Simadibrata. And I would like to thank Professor Dadak and Dr. Ahmad Fauzi for inviting me to this wonderful meeting. My task today is to talk on the IBD situation in East Asia region. So my outline would be epidemiologic trend of IBD in this region and risk factors contributing to IBD, diagnostic approach and management of IBD in Southeast Asia. Well, may I start with epidemiologic trend of inflammatory bowel disease in Southeast Asia. This is a progression toward industrialization that increase the incidence of IBD. And we can see that socioeconomic progression and changing of lifestyle all are resulted in increasing IBD in Southeast Asia region. And our data show that the incidence and prevalence rates of IBD in various Southeast Asia countries showed that Indonesia, Malaysia, and Bangkok have a similar incidence of IBD. And unfortunately, the age of peak incidence for UC is 30 years old, and the peak incidence for CD is 20s, or all these are young and productive age. If you talk about risk factors contributing to IBD, you can see here that abnormal immune response react to antigenic stimulation from gut microbiota. All are influenced by environmental factors, and genetic susceptibility result in developing an IBD in our region, even UC or CD. What about genetic studies? Genetic studies show that Asians have less IBD susceptible genes compared to Westerns, which include NOD2, interleukin 23R, and ATG16LI. However, this weak correlation with CD in Japan, Korea, and Chinese Han patient. However, another single nucleotide polymorphism on TNF SF15 have been found to be strongly associated with Asian Crohn's disease. This finding is not found in a Western CD patient. So I think we need more studies on Asian population. Those are lifestyle changes that may play an important role in IBD, including smoking, Western lifestyle, discontinued breastfeeding, enteric infections, appendectomy, and air pollution. All factors is a risk for IBD. What about dietary? Dietary factors affecting the risk of ulcerative colitis in large case control study in China. We can see here that alcohol, spicy food, and sugar consumption have some effect on IBD. Alcohol might not cause IBD, but cause relapse in existing IBD. Some studies show that alcohol has a pro-inflammatory effect and interfere gut absorption. Chinese study showed correlation between alcohol and risk of IBD. However, a nested case control study from prospective cohort of healthy individuals at enrollment showed no association with IBD. So, recommendation. So, our recommendation is that IBD patients should avoid moderate to heavy amount of alcohol intake. Let's move to diagnostic approach of IBD in Southeast Asia. There are different phenotype and evolution of IBD in Southeast Asia. Most common is ileocolonic Crohn disease. Crohn disease as risk factor for developing colorectal cancer. You can see here in Southeast Asia seems to be lower risk than Western. And concerning the risk of colectomy in IBD, again, in Southeast Asia, there is a lower risk compared to Western country. So it might be a lack of data or cultural differences. And I think we need long-term prospective studies of IBD in Asia. I think another important issue is infectious disease that mimicking IBD is a challenge for diagnosis. Infectious disease are still common in Southeast Asia country that mimicking IBD. And for example, intestinal tuberculosis is still quite common in Southeast Asia. And it is differentiating between CD is quite challenging. Both have a similar predilection for small bowel, causing chronic inflammation, granulomatous inflammation, and similar unspecific symptoms. So I think we need to exclude infectious disease before diagnosing IBD. If you look at a clinical manifestation as a tool to differentiate between intestinal tuberculosis and Crohn disease, there are some difference in symptoms of both disease, but there are also some symptoms found in both disease. And in this case, we can see that clinical manifestations alone cannot be used for diagnosis. What about endoscopic features? Can we differentiate between intestinal tuberculosis and Crohn disease? For Crohn disease, we know that there are longitudinal ulcers, aphthous ulcers, cobblestoning, and anorectal. So I think a model from Lee can demonstrate a correct diagnosis in 87 patients with a positive predictive value 95% for CD and 89% for intestinal tuberculosis. Well, endoscopic features of intestinal tuberculosis and Crohn disease, this from the latest meta-analysis, year 2017. Crohn disease used to be rectosigmoid involvement, longitudinal ulcer, aphthous ulcer, cobblestone appearance, and luminal stricture, mucosal breach, and skip lesion. So I think endoscopic examination can still lead to dilemma for diagnosis because there are some similar signs from endoscopic examination. You can see here endoscopic presentation of abdominal tuberculosis and CD, very, very similar and not that easy to differentiate both disease. What about biopsy? Biopsy approach for intestinal TB and IBD, it is, you can see that 50 to 80% primary features to differentiate CD from intestinal tuberculosis, but only very few caseation of granulomatous and acid-fast bacilli staining to be found in tuberculosis, intestinal tuberculosis. And you can see that diagnosis accuracy for intestinal TB relatively low, even using biopsy. So we can see that biopsy is still not sufficient for differentiating between CD and intestinal tuberculosis. So I think we still need anti-tuberculosis to confirm the diagnosis. Let's move to management of IBD in Southeast Asia. Anti-TNF seem to be effective to manage IBD case. anti-tumor necrosis factor therapy has become the leading therapy for refractory IBD or intolerance to conventional therapy. But it is high cost with long-term and culture in our region where young adults still dependent on parents. So management approach should be adjusted according to financial and cultural context in this case. There are some consideration for the use of anti-10F therapy. We should keep in mind the possibility of opportunistic infection and malignancy that become a major risk for the using of anti-10F therapy. In this case, anti-TNF therapy screening should be necessary before using any anti-TNF therapy, such as latent TB. We need to screen TB and herpes zoster, hepatitis B, and etc. Sometimes prophylaxis use could be helpful. Then we need close monitoring. So if we consider to use anti-TNF therapy, thorough preparation is pivotal to maximize therapeutic effect and minimize side effects. Well, there are some unmet need for a new treatment option. We can see that primary failure, secondary failure, and intolerance, and dose escalation is a concern when we are using anti-10F. And we see that conventional, even anti-10F therapy still have some this opportunity. So, and for anti-TNF alpha therapy, there are some associated with gradual loss of response over time. So it's another problem. And another issue is immunogenicity of anti-TNF alpha therapy that may contribute to loss of response over time. And another issue is anti-TNF alpha therapy also has been associated with increased risk of infection in patients with IBD. So we need alternative beside conventional therapy, immunosuppressant, exclusive enteral nutrition, thalidomide. So I think anti-integrin should be we keep in mind, and I think this issue will be elaborated furthermore by the next speaker. What about the IBD in pandemic COVID situation? I think we have already got guidelines from APG, Asia Pacific. I think Professor Marcel included in this great team that has published Asia Pacific Association of Gastroenterology Inflammatory Working Party Guidance on IBD management during the COVID-19 pandemic. And some of the guideline statement, there are 4 patients who are considering new combination therapy, for example, theoporine and infliximab, settling for monotherapy biological agent for the initial period during the pandemic may be considered in view of increased immunosuppression with combination therapy. And inpatient in-home initiation of biological agent is considered vedolizumab and ustekinumab may be better alternative given their less systemic immunosuppressive activity. These newer agents seem to be less likely to develop immunogenicity and less reliant on immunomodulatory agent co-therapy. Vedo and ustekinumab may also be preferred in high risk in elderly individuals. Well, I think for us, doctors working in Indonesia, we have our Indonesia local consensus update in IBD management year 2019. And for active Crohn disease after complete diagnosis, if they are moderate to severe, and after having induction therapy, we can consider azathioprine or infliximab. And if the response is negative, we can move to vedolizumab or ustekinumab. Yeah, I need to point out this video because our session sponsored by Fido. Well, for active ulcerative colitis, also there are some places for Fido in case failure with steroid therapy. Well, colleague, I would like to summarize my talk that IBD is now observed in Southeast Asia with the progress of industrialization. IBD is targeting young productive age in Southeast Asia, and genetic stability and environmental factors play a role in the development of IBD, although still require more studies. Diagnosing can be challenging in Southeast Asia, especially where infectious disease is still common and mimic IBD. With different socioeconomic background in various Southeast Asia, management for IBD should be carefully adjusted to increase benefit and risk ratio. Thank you for your attention.
Thank you, Professor Murdani Abdullah, for your good lecture. Maybe the discussion will be at the end of the all the speakers giving the lecture. So we continue to the second speaker will be Professor Dadang Makmun, MD PhD FCG, with the topic value of gut selective biologic agent in Crohn's disease management. Professor Dadang is the chairman of Internal Medicine, University of Indonesia, and Cipto Mangunkusumo Hospital, Department of Internal Medicine. Please, Professor Dadang, the time is yours for 25 minutes.
Thank you, Professor Marcel, for chairing this important session. My talk with the topic of the value of gut selective biologic agent in the treatment of Crohn's disease. Can we move to the next slide, please? No. Sudah. Okay. This is the outline of my speak, and I think it's already mentioned by Professor Murdani previously that inflammatory disease is a chronic inflammatory of the GI tract comprising two different disease entities, Crohn's disease and ulcerative colitis. And there are some pivotal factors in the pathomechanism of IBD, including genetic susceptibility, environmental exposure, and dysregulated intestinal immunity response to the gut microbiome. Regarding to the management of IBD, the management should be based on the type of IBD, UC or Crohn's disease. And the second, depend on the disease location, in the distal, in the proximal, or the disease that confine into all segments of the colon, or maybe to the GI tract. And also should be based on the severity of the disease, the presence of comorbidities and complication, individual symptomatic response, and the tolerance of the patient to the medical intervention, and of course, to the patient access to diagnostic and treatment modalities. Of course, it is different between one each other, and the past disease course and duration with the number of relapses in a year. And what is the goal of the treatment of IBD? The first goal is to improve and to maintain the patient's general well-being. This will optimize the quality of life of the patient. The second goal is to treat the acute disease. It means to eliminate the symptom and to minimize the side effect and long-term adverse effects, and to reduce the intestinal inflammation and, if possible, to heal the mucosa. And the third is to maintain corticosteroid-free remission. It means to decrease the frequency and the severity of recurrences and reliance on corticosteroid treatment. And the next is to prevent such complication, to prevent hospitalization if possible, and finally, to prevent surgical intervention. And the last goal of the treatment of IBD is to maintain good nutritional status of all patients with inflammatory bowel disease. If we look at this slide, it clearly shows that in 1950s, the goal of the treatment of IBD is to be no deaths of IBD patient. And mostly, the treatment is based on surgical intervention. And then in 1970s, the goal of the IBD treatment is no surgery, but the modality of the treatment mainly based on steroid use. In 1990s, the goal of treatment is no steroid in the management of IBD patient, and then the most common modality is come from the immunomodulator, including azathioprine. But it changed in the earlier 2000. The goal of the treatment of IBD is to make no lesion. So it means mucosal lesion, and the most important treatment of modalities is the use of anti-TNF-alpha, especially on that time is infliximab. And since 2013, the goal is the same. The goal of the treatment is the same, is to make no lesion among patients with IBD. And the most important treatment of modalities is the availability of vedolizumab, one of the anti-integrin among treatment modalities with biologic agent. This is the Mayo score for endoscopic severity of disease among patients with IBD. We can see here from score no to mild, moderate, until severe. And then among patients with Crohn's disease, to make the grade of severity is we use what we call is Crohn's disease activity index, or CDAI, based on the clinical or laboratory variable, including the number of liquid or soft stool each day for the 7 days in a week. And then the second is there any abdominal pain? Grading from 0 to 3 based on the severity. And then about the general well-being of the patient. Is there any complication? The use of diphenoxylate or opiate for management of diarrhea. And maybe there is an abdominal pain, abdominal mass, and absolute deviation of hematocrit from 47% in men and 42% in women. And the last is the percentage of deviation from standard weight. This is a score of Crohn's disease activity index, or CDAI. This slide shows us the modalities available for the IBD management. The first is diet and lifestyle modification. It should include low residual diet to decrease the frequency of bowel movement. The second is high residue diet for constipation predominant symptom, especially in ulcerative colitis, ulcerative proctitis, and to cessate the smoking or smoking cessation, and stress reduction and better stress management. And the second is pharmacological modalities. The oldest one is the use of aminosalicylate or 5-ASA or mesalazine. and then corticosteroid and immunomodulators, including thiopurines and methotrexate, and the last is biologic agent. There are three kinds of biologic agent now available in Indonesia. The older one is infliximab, then adalimumab. Both are anti-TNF. And the last one, I think already available since this year, is vedolizumab, one of the anti-integrin, who we have already known that's more effective and more safe to be used in the management of inflammatory bowel disease. Sometimes in such patients, we also use antibiotics. Prebiotics still controversial, and symptomatic therapy and some supplement. There are two approaches in the management of IBD. The first is step-up approach. What is step-up approach? This is the standard or conventional treatment of IBD with progressive intensification of therapies with increasing severity of the disease. And the strategy should be start with topical steroid, 5-ASA, or antibiotic in mild flares of Crohn's disease. But then the therapy should be escalated into the systemic steroid with budesonide in the mild to moderate flares and to immunosuppressant, including azathioprine or mercaptopurin or methotrexate, or finally to biological agent in a more severe disease. And the second is the top-down approach. This approach should be initiated with the combination between biologic and immunosuppressant agent or immunomodulators as the first-line therapy, given to all patients right after the diagnosis of Crohn's disease. Then de-escalate to 5-ASA, systemic steroid or topical steroid. And this approach aims to avoid such complications and to improve the quality of life by early induction and of the remission, and to achieve the mucosal healing during the treatment. If we look at this picture, it shows that in the left side is the step-up strategy. Step-up strategy recommended for mild to moderate patient, and then among patients with low risk of complication, and especially in elderly patients, it means above 65 years old. And the top-down strategy of the right side is recommended for moderate to high severity, recommended to patients with high-risk complication, patients with high risk of post-operative recurrences, and younger patients. It means below 65 years old. There are some advantages and disadvantages with the top-down treatment strategy. The first is advantages. This top-down strategy treatment could modify the disease or disease modifying, could induce the mucosal healing more frequently compared to step-up approach, and induce long-term remission, and can lower the rate of endoscopy recurrences, can improve the quality of life, and finally, and it is important, to prevent complication, including perforation or maybe obstruction. But of course, there are some disadvantages in the top-down approach. Patient might be overtreated because the majority of patients may not require this initial intensive treatment. And the second disadvantage is increasing risk of malignancy, maybe in such a biologic agent, and increasing the risk of infection, especially with the use of infliximab. And of course, using biologic can cause a high cost, and which most of them is not covered by medical health insurance, in especially in our country. This picture shows us about the comparison between step-up and top-down. Regarding to the patient of immunosuppression and number of days of steroid treatment, it means in the term of adverse event, there is no difference. But if you look at the last picture, the last table, it showed that CDAI less than 150 higher in patient receiving a top-down approach of the treatment. This is the overview of disease status and drug therapy. If you look at the mild grade, moderate, severe, and maybe among patients with corticosteroid resistant or dependent, a little bit different. But again, in the mild cases, usually we propose to use the 5-ASA or maybe steroid, oral steroid, and then in the severe one, biologic strongly recommended. Yeah. This is changes the concept in inflammatory bowel disease management. Two kind of concept. The first is old concept. In old concept, in the left one, IBD is a disease with intermittent flare. But new concept show that IBD is progressive in a substantial proportion of patients. In the old concept, we have to treat all patients with the same way. But in the new concept, the treatment approach is individualized according to the severity and the prognosis of the patient. In the old concept, the treatment is to treat the targeting clinical remission and response. But in the new concept, we should treat to targeting more objective outcomes. For example, to achieve the mucosal healing. And in the old concept, reactive management, intermittent monitoring, but in the new concept, proactive management with a very tight monitoring. Of course, we should initiate with early intervention, then to target, and finally individualized approach with a tight monitoring. This is the current strategies for the management of inflammatory bowel disease. If we look at the nature of the disease, if we do not treat the patient of IBD earlier, the nature of the disease is progressing from the diagnosis, early disease, then stricture formation, maybe fistula or abscess, and finally require surgical intervention. But again, finally, stricture develop. But if we can treat the patient earlier with the proper modality, especially in the availability of immunomodulator or maybe with the biologic treatment, we can modify the nature of the disease. After diagnosis, and finally, we can manage the disease well until we can achieve all of the targeted treatment, including mucosal healing. So consider the patient, what is the treatment goals, and then it may differ in early versus late disease. If you look at this, symptomatic remission may not be achievable in the late stage disease. The second is mucosal healing as the treatment goal may be difficult to achieve in the late patients and diagnosed late in disease course and who have already experienced a disease complication. So the treatment goals is to make no symptom, so it means non-inflammatory symptom. The second is no disease progression, no complication, and no disability. And finally, to get the normal quality of life. This is about the use of disease-modifying therapy, or DMAT, including immunomodulator and biologic. DMAT refers to therapeutic or biologic, and drug can modify the disease course. What we see at this picture. This is the predictors of poor outcome in Crohn's disease. Patients at high risk of complication, including younger patients, young age at the presentation, The second, among patients with extensive anatomical involvement, among patients with deep ulceration, or patients with ileal involvement, patients with perianal or severe rectal disease, patients with penetrating or stenosing behavior, patients with the smoking habit, and finally, patients with upper gastrointestinal involvement. And who should receive early intensive therapy? This is the risk stratification if necessary. The first is among patients with ileal disease location, younger age, patient with a smoking habit, patient with endoscopic severity with penetrating complication, patient with serologic reactivity to macrobial antigen with the complicated behavior, and again, patient with the mutation in some genes. This is very complicated. If you look at this recommendation from American Gastroenterology Association, AGA, recommendation from AGA, clinical care veteran among patients with inflammatory bowel disease. The first is we have to assess the inflammatory status. We have to assess the symptom and sign. We have to perform clinical laboratory testing. We have to select imaging modalities if indicated. We have to perform endoscopy procedure. We have to identify the symptoms with or without inflammatory markers and perform CT enterography or MRI. And the second is we have to assess comorbidities and disease and therapy-related complications such as infection, stricture, symptoms related to prior surgery, adverse reaction, abdominal abscesses or impression, and again, we have to find out is there any perianal abscess or fistula. And the last is we have to identify the patient level of risk. There are three kinds of level of risk. The first is low risk, including age in initial diagnosis, more than 30 years old, patient with superficial ulcer, patient with limited anatomic involvement, and patient with no perianal and no suprarectal disease, and then no stricturing or penetrating behavior. And patient with moderate and high risk factor, if the age of the earlier diagnosis is less than 30 years, it means younger age, patient with deep ulcer, patient with extensive anatomic involvement, patient with perianal or severe rectal disease, and patient with prior surgical resection, stricturing, and maybe patient with penetrating behavior. This is the identification of patient level of risk in the management of IBD, recommended by American Gastroenterological Association. The question is arise, do conventional and anti-TNF therapies meet the goals of chronic treatment? This is the answer, yeah. Of course, clinical remission, we can achieve therapeutic clinical remission, we can achieve clinical and mucosal remission, but maybe we could not reduce the surgical risk, maybe we could not reduce the disability, and maybe we could not reduce the damage in using anti-TNF alpha therapy. Why the answer is like that? Because of there is the possibility of gradual loss of response among patients using anti-TNF alpha over the time. If you look at this, in the first 3 months, compared to the last 24 months, there is a decrease of the loss of response over time among patients using anti-TNF alpha. Again, anti-TNF alpha therapy has been associated with the increased infection among patients with IBD. If you look at this, among patients with used thiopurine monotherapy, the risk is lower compared to patients using anti-TNF alpha monotherapy, but higher among patients with the combination between anti-TNF alpha and thiopurine. So, there is a poor correlation between symptoms and mucosal inflammation in the Crohn's disease. By the time of clinical symptoms develop during relapses, and irreversible bowel damage might have developed during the treatment. Finally, maybe the goal of the treatment of Crohn's disease is to have the transmural healing, not only mucosal healing. The last part of my talk is about the vedolizumab, now available in Indonesia in the name of Entyvio. I think this will be the most important treatment modalities among patients with inflammatory bowel disease. Vedolizumab is a humanized gut-selective IgG1 monoclonal antibody, binds to alpha-4 beta-7 integrin expressed on the surface of the lymphocyte, and the dose of vedolizumab for the induction is 300 milligrams intravenously at the week 0, repeated on the 2nd week, the 6th week, and follow every 8 weeks. This is the dose of vedolizumab administration among patients with inflammatory bowel disease. This is what we call is the gut-selective biologic agent. This is the study conducted by Kovilov et al. The effectiveness and safety of vedolizumab in anti-TNF alpha naive among patients with without history of using anti-TNF alpha with IBD, a multi-center retrospective European study. This study concluded that vedolizumab is similarly effective in anti-TNF alpha naive Crohn's disease and ulcerative colitis. The efficacy is higher than reported in anti-TNF experienced patient and is comparable to that of anti-TNF biologic in this population. This study show about the effectivity of vedolizumab compared to anti-TNF in Crohn's disease management. This study conducted by Dulai et al. In this study showed that vedolizumab more effective than anti-TNF alpha in the treatment of Crohn's disease in the term of steroid-free remission, mucosal healing, and clinical remission. These are the most important target achievement in the treatment of IBD. The first is clinical remission, the second is steroid-free remission, and the third is mucosal healing. And finally, transmural healing could be achieved in the use of vedolizumab. Again, this is the study, we call this the Versify study. The objective study is to evaluate endoscopic remission in assessed by ileocolonoscopy among patients with vedolizumab treatment. And this shows that among anti-TNF alpha naive and among patients with anti-TNF alpha failure, this shows about the clinical response among patients with vedolizumab. This is the study conducted by Figan et al. The rapid response to vedolizumab therapy in biologic naive patients with inflammatory bowel disease. This study concluded that vedolizumab significantly improved patient-reported symptoms of UC-NCD as early as week 2 of treatment, continuing through the first 6 weeks, and especially when given as the first line of biologic therapy. How about the symptom of improvement among patients using vedolizumab in the treatment of IBD? Abdominal pain and loss of stool frequency significantly reduced among patients with vedolizumab, especially in TNF alpha naive using vedolizumab treatment. And this is the meta-analysis study showing about the rate of mucosal healing. In the left side is among patients with ulcerative colitis, and the right side is among patients with Crohn's disease treating with vedolizumab. This is the lower rates of serious infection and serious adverse effect among patients with vedolizumab versus patients with anti-TNF in combined UC and CD patient. It has clearly shown that among patients with vedolizumab, serious infection is lower, 0.1% compared to 10.1% among patients with anti-TNF alpha. And again, about serious adverse event also lower in the group of vedolizumab compared to anti-TNF alpha. How about safety of biologic agent? If you look at this slide, it shows that anti-TNF alpha has the risk of infection, the risk of pneumonia, the risk of lymphoma, the risk of melanoma, the risk of lupus-like reaction, and increasing the demyelinating disease and increased infusion and skin reaction during the treatment. On the other hand, in the vedolizumab group, no increased risk of overall infection, no increase of malignancy, and only slight increase in nasopharyngitis, CMV, and CDI. And the experts rank the safety among biologic agents as the treatment modality of the IBD patient. This is the proposed safety pyramid of IBD medication. These pyramid positions reflect the author's view, interpretation of available data, and clinical practice. So the most safe among biologic agents is vedolizumab, then ustekinumab, then anti-TNF, monotherapy, then theophylline, and the last is steroid. And also in the risk of tuberculosis, vedolizumab has the lower risk of tuberculosis compared to anti-TNF alpha. So, ladies and gentlemen, all participants, let me conclude my talk. The first is the management of IBD should be based on disease characteristic to be separated between ulcerative colitis and Crohn's disease, should be based on individual response to medical intervention, should be based on the modalities availability, and based on patient past disease characteristic. The treatment goal of IBD is to improve and to maintain patient general well-being, to induce corticosteroid-free remission and mucosa healing, and to prevent complication, to prevent hospitalization, and finally, to prevent surgical intervention. And recently, the development of biologic agent has changed the concept in IBD management. The goal of the treat-to-target approach is more objective, including mucosal healing and change the nature of the disease. The traditional step-up therapy approach may have better risk-benefit and cost-effective ratio in the short term. But the new top-down therapy is more effective to maintain remission, to decrease the rate of relapses, to reduce the administration of corticosteroid, to prevent occurrence of complication, and to minimize operation in the long term. And finally, vedolizumab, who now already available in Indonesia, has shown good efficacy in moderate to severe IBD patients, especially in naive biologic patients. Vedolizumab also showed better safety profile than the previous biologic agent. It means infliximab and available adalimumab and all anti-TNF alpha. And thus, this should be considered as the first-line biologic therapy in the management of inflammatory bowel disease. And the society, because in Indonesia already established the consensus, the management of IBD 2019. We hope this consensus could be disseminated to all doctors all around the country and will be the guidelines in the management of IBD patient. Thank you very much for your attention.
Lecture. Thank you, Professor Dadang, for the good lecture. So I will proceed to the last speaker, Dr. Pangestu Adi, with the topic ensuring rapid and sustained efficacy in ulcerative colitis with gut-selective biologic engine. Please, Dr. Pangestu, the time is yours. 25 minutes.
Thank you.
Please, Dr. Pangestu.
Thank you very much, Marcel. Okay.
Bukan nggak coba ini ditarik.
Okay. Thank you very much, Professor. The next topic about ulcerative colitis therapy with biologic agent. The primary goals of therapy for patients with UC there are inducing remission, maintaining remission, minimize risk of relapse, focus healing. The dream is to get histological healing in UC. Then restoring and maintaining nutrition, maintaining patient quality of life, and at the same time to prevent and treat complications of the disease and to avoid short-term and long-term toxicities of therapy and avoid surgery. This is the following. The following is the history of IBD since it first reported as terminal colitis, as terminal ileitis by Dr. Borrell Kroon in 1972. Until the last 19th century, this is the conventional therapy of IBD. After that, a new era of IBD treatment since infliximab as biologic agent was used in IBD. But until now, the results of treatment have not been completely fulfilled. New drugs are being developed, such as vedolizumab, to further enhance the result of the therapy. This is the factor that need to be considered before giving therapy to UC patient. Now, the first is the distribution of the disease, distant or extensive. The second is the severity of the disease, namely mild, moderate, or severe, and the previous treatment history, response, side effect, treatment, and compliance. The desired treatment goal in UC patient is complete remission, defined as durable symptomatic and endoscopic remission without corticosteroid therapy. The distribution of UC at presentation was mostly proctitis, 46%, then pancolitis, and the third is left-sided colitis, 17%. In determining the severity of UC, the most widely used classification is the Thurlap and Witts classification, divided into mild, moderate, and severe by assessing how many stools per day, whether there is blood or not, fever or not, tachycardia or not, and anemia or not, and how much is the ESR period. On endoscopic examination, we will see continuous colonic mucosal inflammation. Based on Mayo classification, the score is 0 if normal. If only erythema and lost normal vascular pattern, the score is 1. Score of 2, friability and erosion. Score C if there is bleeding and ulceration. Mayo score is a disease activity instrument that combines clinical and endoscopic parameters. Mayo score based on stool frequency, degree of rectal bleeding, endoscopic finding, and physician overall assessment. Clinical remission of total Mayo score 2 or less, and no individual subscore more than 1 is categorized as clinical remission. Clinical response, if the score decrease from baseline total score 3 or more, and a decrease in the rectal bleeding subscore 1 or more. Mucosal healing, if endoscopy subscore 0 or 1. Partial Mayo score, if endoscopy is not included. Remission if score 1 or 0. If score 2 and 4, disease activity is mild. Score 5 to 6, moderate. And severe if the score 7 to 9. Risk factor for more severe disease scores in UC is patient with if the age patient is less than 40, colitis is extensive, we find deep ulcer, patient need early steroid treatment, history of frequent hospitalization, elevated inflammatory markers, CRP and ESR, and infection with Clostridium difficile and cytomegalovirus, and low serum albumin. Principal treatment for patients with UC, 5-ESA is considered the standard in treating mild to moderate UC. Patients with adequate response to optimize 5-ESA should be changed to budesonide, multimetric, or oral prednisone. To induce remission in acute severe disease, IV corticosteroid remain the first line therapy. So far, with the progress that has been achieved on UC treatment, the result is still not perfect. This is the result of US survey on patients with UC, and gastroenterologists found that approximately 59% on treatment, patients on treatment report that their quality of life is low. The progress of the disease is still ongoing. The disease is still progressing over time. For example, proctitis patient after median follow-up reported by Swiss IBD cohort study on proctitis patient after median follow-up 9 years, 15.6% are progressed to pancolitis. This is an indication of biologic therapy on UC. Biologic therapy should be indicated in corticosteroid refractory disease, UC with corticosteroid dependent disease, and disease that it's refractory to or intolerant to immunomodulator. Steroid refractory disease definition is patient not responding to corticosteroid therapy with 0.75 to 1 milligram per kilogram body weight of oral prednisolone equivalent within 4 weeks, or intravenous corticosteroid for at least 1 week after infectious complication, Clostridium difficile and cytomegalovirus has been excluded. Definition of steroid-dependent UC, that is UC that initially respond to oral corticosteroid but fail to taper below the equivalent of prednisolone 10 mg per day within 3 months, or the patient relapse within 3 months after steroid discontinuation. Immunomodulator refractory UC definition is patient having active disease or relapse despite the use of AZA 2 to 0.5 maximum 3 mg per kilogram per day, or 6 MP 1 to 1.5 mg per kilogram body weight per day for at least 3 months, and the dosage has been optimized based on 6 theogenin level in the blood. AGA and AGA guideline. In AGA guideline 2020 and ACG guideline 2019, the role of biologic therapy is established for induction and maintenance of remission in moderate to severe disease and in acute severe UC. Early treatment top-down strategy which biologic agent should be considered in patients who have factors associated with high colectomy risk or worse prognosis, as like patient younger age and worse prognosis in the this one, age less than 40, extensive colitis, deep ulcer, early steroid treatment, history of hospitalization, frequent elevated inflammatory markers, and so on. Biologic agents are indicated for patients with UC for moderate to severe UC. The drug available in Indonesia, anti-TNF agent, infliximab and adalimumab, and anti-integrin agent, vedolizumab. Only 3 drugs in Indonesia for biologic agent in Indonesia. In ICCU statement of 27 number 12Y, anti-TNF or vedolizumab may be used as first-line biological therapy. Evidence level 2, vedolizumab is effective in patients failing anti-TNF, with evidence level 2 also in patients responding to vedolizumab. Maintenance therapy with vedolizumab is appropriate. This is a Gemini 1 trial, vedolizumab as induction and maintenance therapy for UC. The result was that clinical remission of mucosal healing and steroid-free remission in the vedolizumab group was significantly higher than placebo. And there is no adverse the adverse event is similar with placebo, and any serious infection in placebo 20.9%, and in vedolizumab group 1.9%. The Gemini 1 trial is then continued to Gemini LTS trial, abbreviation of long-term safety trial of vedolizumab. The observed percentage of clinical remission remain about 60% at week 152. This is a comparative trial vedolizumab versus infliximab. The result is vedolizumab was similar with infliximab among the TNF blocker naive patient, but among the TNF blocker experienced patient, response rate vedolizumab is better than infliximab. Due to sample size, the ERA did not refer statistical significance. In varsity clinical trial, comparing vedolizumab and adalimumab for moderate to severe UC, the result vedolizumab was better than adalimumab, but the steroid-free remission was statistically not significant. It's the same. And incidence rate of infection and serious infection is the same. It's similar between vedolizumab and adalimumab. Comparative efficacy vedolizumab and adalimumab in ulcerative colitis patient previously treated with infliximab. Therapeutic failure rate on total infliximab failure not significant, but therapeutic failure rate at week 52 among infliximab secondary failure patient, vedolizumab is better, statistically significant. As a conclusion, vedolizumab may be the therapy of choice in this UC patient who show secondary failure to infliximab. This is a integrated safety summary up to 5 years on treatment on IBD patient, 2060 participation from 6 clinical studies, no increased risk of any infection and serious infection associated with vedolizumab comparing with placebo, and no PML reported. This is a progressive multifocal electroencephalopathy, the serious complication with anti-integrin. Pre-treatment screening for biologic agent during the COVID-19 pandemic is the same as the pre-pandemic screening plus COVID-19 PCR test, including test for COVID-19 antibody. As summary, biologic agent is indicated for UC patient with steroid refractory, steroid dependent, immunomodulator refractory or intolerant. Array therapy with a biologic agent should be considered in UC patients who have factors associated with high colectomy risk or worse prognosis. In UC patients with naive TNF blocker, the efficacy of vedolizumab is similar with infliximab. Vedolizumab was superior to adalimumab with respect of clinical remission and endoscopic improvement, but not serologic clinical remission. Vedolizumab can be used as therapy of choice in UC patient with secondary infliximab. Thank you very much for your time.
Thank you very much, Dr. Pangestwadi, for the lectures, good lectures. So we come to the discussion. There are a lot of questions to the speakers. So for Prof. Murdani, there is one question from Prof. Murdani. Does environmental factor like low hygiene, poor sanitation, poor socioeconomic status, living in rural area have a role in the occurrence of IBD in Southeast Asia? That's one of the audience asked this question. Prof.
Yes,
Murdani?
Prof. Marcel. Thank you, Prof. Marcel. I think this is a very interesting issues because previously we believe that IBD most likely occur among Western countries with a good environment and good hygiene. But recently we observe the incidence of IBD increasing in our region. The role of infection should be considered one of the triggers of relapsing, or maybe one of the precursor of IBD in the region. Maybe it might change our opinion about the pathophysiology of IBD. But overall, I think low socioeconomic and low environmental situation should be preventive factors, I think. Maybe Prof. Marcel have some
I agree with Prof. Murdani. Yeah. So maybe we have to do a research about these environmental factors. So is there any role in the occurrence of IBD in Indonesia or maybe Southeast Asia? But all of the factors that include in the occurrence of IBD is the Western style. Usually the Western style has a role in the occurrence of IBD. But for the Southeast Asia, maybe we have to do the another study about that. Yeah. Thank you, Prof. Murdani. Okay. So there will be another question for Professor Dadang. Professor Dadang, there is a question from the audience. Ask you, how do we choose the best approach, step up or top down for patients with IBD? That's from the audience. Thank you, Prof. Dadang.
Thank you, Prof. Marcel. So again, I would like to remain that in the management of IBD, we should consider about the type of IBD, UC or CD. The second, disease location. For example, distal of colon, proximal of colon, and involving ileocecal valve, or maybe the entire of the colon. The third is severity. The fourth is there any comorbidities? The tolerance to medical intervention. And the most important is the patient access to the modalities of the treatment. As we know that in this situation, we propose step-up approach to all patients with IBD with the mild to moderate severity. And the second, to all patients with IBD with low risk of complication, and to elderly patient, it means patient above 65 years old. So we recommend for step up. But once again, if the disease involving ileocecal valve, or maybe with the stenotic condition, we could not change this approach to give the top-down approach with the use of biologic or maybe in combination with immunomodulators. On the other hand, on the top-down therapy, we recommend to be used to all patients with IBD in moderate to high severity. And second, to IBD patients with high risk of complication, and among patients with the age below 65 years old, or it means younger patient, and among patients with ileocolonic location. So those patients should be recommended to have top-down strategy approach in the treatment of IBD. Thank you, Professor.
So for Dr. Pangestu Adi, there is one question from the audience, maybe also for the other speakers. What's the clinical laboratory profile must be monitored during the course of vedolizumab treatment? And what are the common side effects that can be expected if you give the vedolizumab? Maybe Dr. Pangestu can answer this question.
Okay. We will open.
Yes. The clinical laboratory profile must be monitored during the course of vedolizumab, and the common side effects that can be expected. Dr. Pangestu?
Yes.
Can you hear?
Yes.
Can you hear?
Yes. I want to open my PowerPoint.
Oh, PowerPoint. Please, the organizing committee, can you open the PowerPoint slide share?
This is advertisement that should be aware. Vedolizumab especially infection or inflammation like upper respiratory infection and any infection. Especially serious infection in patient with sedilizumab.
So what's the laboratory examination? Do you want to check for the patients?
Like
What kind of what kind of laboratory examination?
uh, routine blood count and liver function, renal function. This in the first treatment. This one suggestive screening before treatment by all patient with diabetic agent treatment.
Okay, thank you very much for the answers. So because of the time, I want to ask the last questions for all the speakers. What kind of treatment is the best in the pandemic now, the pandemic time, in this COVID-19 time? What is the best treatment for IBD? Maybe Prof. Murdani, Prof. Dadang, and Dr. Pangestu can answer what kind of treatment is the best for IBD patients in pandemic time today. Prof. Murdani?
Thank you, Prof. Marcel. If the patient under maintenance using previous drug as sorry, Prof. Marcel.
Okay.
Yeah. I think if the patient under maintenance using any other previous regimen, we need to continue such regimen. But when we want to start the induction therapy for the new diagnosed patient, I think if we need biologic agent, FEDO much safer in this situation compared to any anti-TNF regimen. Yeah. Terima kasih, Prof.
Thank you. Prof. Dadang, what's the best treatment for IBD patient in this COVID pandemic time?
Yeah, thank you, Prof. Marcel. I think refer to Professor Murdani's explanation that there are two kind of patient. The first is the patient in the maintenance therapy for IBD, and the second is patient with the initial treatment for remission induction. If the patient during treatment, I do agree with Professor Murdani that there was among 3 lines of modality. First line including steroid and mesalazine, the second line immunomodulator, and the third line is biologic agent. For the first line, I think we have to stop. We have to postpone the use of steroid, but not for mesalazine. And the second, some report recommend to postpone the use of immunomodulator also. But for the third line, I do agree with Prof. Murdani that vedolizumab safer than others. So we can continue. But if the patient is just initiated for induction of remission, we have to make sure that the first is no infection, including what Dr. Pangestu Adi informed us, tuberculosis, and many more markers we have to examine before. And again, steroid should be avoided, but mesalazine is safe, and the second also immunomodulator, and the third vedolizumab among biologic agent is safer than other, including infliximab and adalimumab. I think that's my answer, Prof. Marcel.
Yeah, this Professor.
Yeah. Yes.
Hello, hello. We don't have. Hello, hello.
Best treatment in COVID time for
Okay.
IDD patients.
Okay, okay.
Uh,
Prof. Marcel,
Marcel,
steroid treatment should be stopped and tapered, and tapered, and mesalamine 5 SA should be continued. And in patient with biologic agent, during treatment with biologic agent, it's no problem to be continued. But if patient have positive COVID, should be postponed after patient recovered. No problem with biologic agent.
biologic agent.
If
If
we can choose, the best is
the best is
vedolizumab.
vedolizumab.
Thank you very much.
Okay, okay, thank you very much. Because of the time, we have to stop this session. Thank you very much for the lecture and discussion to Professor Dr. Murdani Abdullah, Professor Dr. Dadang Makmun, and Dr. Pangestu Adi for good lecture and discussion. Thank you also for the participation and then for the participants for this active participation. Now we give back the time to the Master of Ceremony, Dr. Saskia.
Thank you to all professors
Saskia?
and yes, thank you to all professors, to all speakers and moderators. So we will have a brief photo session. So if you may please look into the camera to all speakers and moderators, we will take a picture. So we will count in 1, 2, 3. Capture. To Dr. Pangestu, you may look into the camera, please. Yeah, okay. I will count again in 1, 2, 3. Capture. Okay, thank you very much once again to all the speakers and moderators for a very nice session. We would also like to thank you to our sponsor, Takeda, for contributing in this session. Ladies and gentlemen, now we will continue our program. For the next lecture, in plenary lecture 4, there will be a topic about gastrointestinal manifestation in COVID-19. In this lecture, it will be moderated by Dr. Ahmad Fauzi, MD, Division of Gastroenterology, Department of Internal Medicine, Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo National General Hospital. Without further ado, I would like to invite Dr. Ahmad Fauzi to moderate this session.
Thank you, Dr. Saskia, for this opportunity, and to all the participants, thank you for follow this IDDW meeting, and we will come to another session with plenary lectures about with the topic of gastrointestinal manifestation in COVID-19, and will be presented by Professor Dr. Dadang Makmun, FACG. Professor Dadang Makmun, as we know, is head of Department of Internal Medicine in Cipto Mangunkusumo Hospital, and until now as President of Indonesian Society of Gastroenterology. So, Professor Dadang, thank you for your lecture that will become. Time and place is yours. Thank you.
Thank you, Dr. Ahmad Fauzi, for planning this session. So once again, I have to stand here in the podium to deliver a talk about the GI manifestation in COVID-19 patient. This is the outline of the speech. And ladies and gentlemen, all participants, if we have already known that the novel coronavirus disease, COVID-19, which is caused by a severe acute respiratory syndrome coronavirus, or SARS-CoV-2, nowadays causing a global pandemic. And most patients typically present with fever and respiratory symptoms. But nevertheless, some patients also have gastrointestinal manifestation, such as diarrhea, vomiting, and maybe with abdominal pain. And some studies show that SARS-CoV-2 RNA could be detected in anal or rectal swab and stool specimens. And this finding lead to the potential pathophysiological aspect, including the viral receptor expression in the gastrointestinal tract. And finally, this situation has an important implication to the disease management, to the disease transmission, and finally to the infection control. This is the latest situation about COVID-19 global pandemic worldwide. Yesterday, I think October 17, there were more than 39 billion confirmed cases all around the world, which more than 1,100,000 deaths. And if you look at this data in Indonesia today, the prevalence of confirmed case is 353,000 patients, with the mortality more than 12,000 patients. But besides the symptoms of respiratory tract, such as coughing, fever, and many other respiratory syndrome, some COVID-19 patients present of gastrointestinal symptoms. This is the first case of GI symptom among patients with COVID-19 reported by Song et al. He reported about a patient who was detected confirmed for COVID-19 on last January, with the 4-day history of diarrhea and low grade of fever. And the PCR test taken from the swab specimen positive for COVID-19. And this patient reported persistent diarrhea, no fever, no cough, no dyspnea, and no chest pain at all. And this report about the familial cluster of pneumonia associated with the COVID-19, this is reported by Wu Chan et al. He reported a family with 6 family members, father, mother, and 4 children. Among them, 5 family members presented with fever, upper or lower respiratory tract symptoms, or diarrhea, or combination. But the last family member, the youngest children, with asymptomatic and had a radiological ground glass lung opacity. All of them are positive to COVID-19 PCR examination taken from the swab specimen. Again, a case report by Fu et al. He reported a patient with 68 years old with the paroxysmal vomiting for 7 days, fever for 1 day. Then finally the doctor suggested him to have a COVID-19 and proceed with the chest CT scan examination, and the result showed pneumonia in the bilateral lungs and the ground glass opacities, or GGO, in the right lung. And patient had also vomiting symptom admission without diarrhea, without cough, without dyspnea, and without chest pain. patient confirmed to COVID-19. This patient is the firstly reported from the United States. A 35 years old man on January 19 presented to a clinic with a 4-day history of coughing and subjective fever. And then the PCR tests were carried out and the result was positive. But in this patient, if we look at the nature of the disease, the first symptoms is coughing. Then in the third day, the patient complaining of fatigue, and then in the 4 days, the patient complaining of nausea, vomiting, and finally in the 6th day, patient complaining of diarrhea and abdominal discomfort. And this is the chest X-ray examination in this patient, and actually did not show any significant abnormality from the X-ray examination. But laboratory results on hospitalization within the 3rd day and the 5th day reflected the leukopenia, mild thrombocytopenia, and elevated levels of creatine kinase. And the patient developed to the hepatic function measures, including ILT and AST increased. And finally, the patient also was examined from the stool examination for PCR of COVID-19 or SARS-CoV-2. Then, in this patient, in the 7th day of hospitalization, the positive result was reflected by stool examination for COVID-19. This slide shows us about comparison between patient with COVID-19 with GI symptoms and patient COVID-19 without GI symptoms. If we look at the left side, all patients with GI symptoms has higher fever and presented with the symptom including fatigue, shortness of breath, and maybe headache higher than patient with COVID-19 and without GI symptoms. And again, if we look at the liver function test, among patients with GI symptoms, the rate of increased AST but not ELT was significantly higher compared to COVID-19 patients without gastrointestinal symptoms. But regarding to the chest to X-ray examination, it is shown that among patients with GI symptoms, the rate of unilateral pneumonia, lower than in those without GI symptoms. So it is not similar with liver function test among patients with GI symptoms. This table shows us about the comparison of patients with COVID-19 without GI symptom and patients with COVID-19 with GI symptom. Most of patients with COVID-19 and has GI symptoms showed a serious complication, including acute respiratory distress syndrome, liver injury, and most of them required to be admitted to the intensive care unit, compared to all patients with COVID-19 without gastrointestinal symptom. And again, among patients with COVID-19, sometimes required an urgent endoscopy examination, including bleeding and many more indication for endoscopy examination. But among of them, in endoscopy examination, then biopsy sample was taken. The SARS-CoV-2 could be detected from stomach, duodenum, until the rectum, but only detected in duodenum and could not be detected in other GS specimen in non-severe fashion. So the finding of endoscopy examination with biopsy for evaluation of SARS-CoV-2 is different between patient with severe disease and patient non-severe disease with COVID-19. Because of this finding, the proportion of positive fecal cases did not show significant difference between two groups, suggesting the presence of SARS-CoV-2 RNA in feces does not necessarily indicate more severe GI symptom. On the right side, the number of patients with elevated ALT and AST were significantly higher among patients with digestive symptom than those patients without digestive symptom. But therefore, those patients with GI symptom were more likely to suffer liver injury. Although the mean EST and ELT and ST were in the normal range. And this is the GI symptom, common GI symptom represented among patients with COVID-19, including diarrhea, anorexia, nausea, and maybe hepatic function impairment, including elevated bilirubin level. If you look at this table, pie diagram, it shows that the frequency of patients with digestive and respiratory symptom is the highest, and then patient with respiratory symptom without GI symptom, and then patient without GI symptom and without also respiratory symptom, and the last, patient with GI symptom without respiratory symptom, with the red one. So this is the proportion of COVID-19 patient with or without digestive symptoms. In this report, it's come from our hospital in Jakarta, but it's still unpublished. The report from Dr. Rabinu Rangga Pribadi et al., a study involving more than 100 patients, more than 100 COVID-19 patients. This study showed that almost 20% of patients had the GI symptom. Yeah. And then all patients with GI symptom were admitted to the inpatient unit. And the GI symptom may not affect the severity of the disease. And this is the most common GI symptom among patients with COVID-19 who were admitted in our hospital. The first is nausea, and the second vomiting, then anorexia, diarrhea, and the last is abdominal discomfort. What is the potential pathomechanism of COVID-19 and GI tract? SARS-CoV-2 is similar to all SARS-CoV and can invade the human body by binding to the human angiotensin converting enzyme 2 or ACE2 receptor. So this SARS-CoV-2 indirectly or directly damaged the GI symptoms through an inflammatory response. The chain reaction of inflammatory response of inflammatory factors and viremia may injure the digestive symptoms. The intestinal flora is colonized in the human intestine, and the intestinal flora plays a variety of important physiological roles in the body. And the virus itself may cause disorders of the intestinal flora, which finally could result in the digestive symptom. And the intestine is the largest immune organ in the body. Changes in the composition and function of the digestive tract flora will affect the respiratory tract through the common mucosal immune system, and vice versa. Respiratory tract flora disorders also can affect the digestive tract through the immune regulation. This effect called as the gut-lung axis. And this is the last part of my talk. Ladies and gentlemen, all participants, let me conclude my talk. The first is patients with COVID-19 are prone to digestive symptoms, and nearly half report a digestive symptom in addition to fever or respiratory symptom on presentation to the hospital. In rare instances, patient can even present with digestive symptom in the absence of respiratory symptom. And compared with COVID-19 patient without GI symptom, those patients with GI symptom have a longer time from onset to the admission and evidence of more laboratory derangements, including prolonged coagulation time and higher liver enzyme tests. The clinician, of course, must bear in mind that digestive symptoms such as diarrhea may be one among the presenting features of COVID-19, and in some cases, they may arise before the respiratory tract symptom, and on a rare occasion, it is the only presenting symptom of COVID-19. So, the clinician should raise their index of suspicion when at-risk patients, such as those exposed to COVID-19, present with fever and digestive symptoms even in the absence of respiratory symptoms. And finally, the knowledge might help with earlier identification of COVID-19, the faster time to the treatment, the earlier quarantine of the patient, and will lower exposure to bystanders. So thank you very much for the attention.
Thank you very much, Professor Dadang, for the excellent and comprehensive lecture about GI manifestation in COVID-19. Please give big applause to this lecture from Professor Dadang. And I think for this plenary lecture, there is no question. So thank you very much, Professor Dadang, and I will give this to MC, Dr. Saskia. Thank you.
Okay. Thank you, Prof. Dadang and Dr. Fauzi. We would like to have a picture of both of you. So you may please look forward into the camera because we will take a picture. I will count in 1, 2, 3, capture. Okay. Once again, thank you very much for doctors and professors. Ladies and gentlemen, now we will have a break time. During this time, you can visit our virtual exhibition at our IDDW 2020 Virtual Congress platform. So please come back again at 1:15 and enjoy the Explorer, and I will see you soon. Thank you.
Menyikapi pandemi COVID-19 serta tingginya risiko penularan SARS-CoV-2 di lingkungan rumah sakit, berikut ini adalah hal-hal yang perlu diperhatikan. Untuk memutus rantai penularan antara lingkungan rumah sakit dengan luar rumah sakit, gunakan baju khusus saat bekerja di rumah sakit. Cuci tangan sesering mungkin dengan sabun dan air mengalir atau hand sanitizer yang banyak tersedia di semua tempat pelayanan. Lakukan 6 langkah cuci tangan meliputi telapak tangan, punggung tangan, sela-sela jari, buku-buku jari, ibu jari, dan ujung kuku. Setelahnya, bilas dengan air mengalir. Seluruh gerakan mencuci tangan dilakukan selama 60 detik. Tutup keran dengan siku dan keringkan tangan dengan kertas tisu. Gunakan alat pelindung diri sesuai standar yang telah ditetapkan atau sesuai dengan yang telah disediakan. Perlindungan difokuskan pada bagian leher ke atas. Pembagian zona dalam penggunaan alat pelindung diri merujuk pada standar penggunaan alat pelindung diri RSCM dalam menghadapi wabah COVID-19. Gunakan alat pelindung diri level 1 bagi petugas yang bekerja di zona hijau atau area pelayanan umum. Gunakan alat pelindung diri level 2 bagi petugas yang bekerja di zona kuning atau area pelayanan umum di mana dapat ditemukan pasien dalam pengawasan. Gunakan alat pelindung diri level 3 bagi petugas yang bekerja di zona merah atau area pelayanan pasien dalam pengawasan dan pasien yang terkonfirmasi COVID-19. Jika alat pelindung diri sudah selesai digunakan, letakkan pada tempat khusus pembuangan limbah medis. Jangan menggunakan atau meletakkan alat pelindung diri di ruang kerja non-pelayanan. Perhatikan interaksi antar tenaga kesehatan, baik di tempat pelayanan pasien maupun di tempat-tempat lain di lingkungan rumah sakit. Selalu menjaga jarak dan tidak melakukan kontak bila tidak diperlukan. Hindari berkumpul dalam jumlah banyak dan saling berbicara dalam satu ruangan. Bersihkan telepon genggam, laptop, alat tulis, dan benda pribadi lainnya dengan cairan disinfektan sesering mungkin. Hindari penumpukan barang dan berseraknya kertas di atas meja. Cuci tangan sebelum makan dan gunakan peralatan makan pribadi. Hindari makan bersama-sama dalam jarak yang berdekatan. Selalu membawa dan menggunakan peralatan ibadah pribadi. Perhatikan risiko penularan di rumah atau di tempat tinggal lainnya. Perhatikan juga risiko penularan di perjalanan dari dan ke rumah sakit, terutama jika menggunakan transportasi umum. Jangan membawa banyak barang dari rumah ke rumah sakit atau sebaliknya. Dianjurkan untuk mandi sebelum meninggalkan rumah sakit atau segera setelah tiba di rumah. Rendam dan cuci pakaian kerja dengan cairan yang dapat membunuh virus. Terima kasih telah menonton video ini. Semoga bermanfaat dan tetap sehat.
Entyvio is a monoclonal antibody that has been developed for the treatment of moderately to severely active ulcerative colitis and Crohn's disease, two common forms of inflammatory bowel disease or IBD. IBD is associated with altered functions of the immune system. As part of the body's adaptive immune response, lymphocytes are imprinted for migration to areas of inflammation in specific tissues. Entyvio targets a discrete subset of imprinted T cells that preferentially migrate to the GI tract. The accumulation of such immune cells within this tissue contributes to inflammation that is characteristic of ulcerative colitis and Crohn's disease. As part of a process called lymphocyte trafficking, a small number of T cells are known to express the alpha-4 beta-7 integrin, which binds to the mucosal addressin cell adhesion molecule 1, or MAdCAM1. The binding of alpha-4 beta-7 to MAdCAM1 causes cells to enter the inflamed tissue from the vasculature. This interaction primarily occurs at the vascular endothelium in the lamina propria intestinal submucosa and gut-associated lymphoid tissue, the main sites of MAdCAM1 expression. Entyvio works by binding to the alpha-4 beta-7 integrin, preventing its interaction with its ligand MADCAM1. It selectively inhibits the adhesion of T cells to the endothelial surface of blood vessels within the gastrointestinal tract. As a result, Entyvio selectively restricts T cell recruitment from the vasculature into the tissue, reducing inflammation within the gastrointestinal tract associated with ulcerative colitis and Crohn's disease.
As a dynamic enterprise with annual sales turnover of over 1 trillion rupiah, PT Meiji Indonesia spread its wings of expansion, where one expansion leads to the next. Horizontally, we are racing ahead to fulfill both domestic and overseas market with certified quality API even more competitively. Vertically, we are taking new steps to stretch our portfolio beyond pharmaceutical products into cosmetics, food supplements, hospital health supplies, and medical devices sectors. To support our strategic moves and initiative, we have also accomplished our strategic expansions of our plant and its facilities. Our modern warehouse to safeguard the quality of our products, and our new head office to ensure the long life journey serve the country and the world. After spanning over than 4 decades, currently PT Meiji Indonesia has the largest penicillin injection facilities in Indonesia and the largest penicillin API manufacturer in Southeast Asia. Our consistent development and expansion, about which we have always been proud of, is much attributed to the well-planning and execution of the company's strategic direction. Inspired by the need of quality medicine, we bring a vision to gear up with high-quality products to the highest satisfaction of our customers. We bring more to life all over the world and human health improvement. It's an ongoing challenge to render our best of everything we do. It's what we were brought up to be. In the spirit of the company's vision, we are dedicated to carry 3-dimensional purposes to bring PT Meiji Indonesia as a clean, green, and trusted company. A clean company that develops organization where excellence thrives is fostered through constant efforts to reach for creativity and innovation in an atmosphere which encourages sense of urgency through market and partner orientation. A green company where we work whilst taking steps to save environment by improving our customer, employees, and communities' lives through our actions and choices in socially and environmentally responsible ways, and conduct our operation in a way that benefits society and the environment. A trusted company where we strive to continue to move forward to improve the quality of people's lives and the health of patients who need our medicines the most. Today, our factory is fully operated by a highly dedicated professional team which runs under 2 separated production lines of beta-lactam and non-beta-lactam products, supported by modern technology, facilities, and infrastructure. We apply tight validated production method and tight quality control in each production step to ensure high-quality medicines in compliance with the Japanese CGMP standards. In line with our purpose to bring PT Meiji Indonesia as a green company, our plan operates under eco-friendly processes and environment to produce eco-friendly products. Therefore, it is our ultimate goal to eliminate pollutions and save the earth. Being the largest penicillin injection manufacturer in Indonesia, we are also committed to maintaining our quality products and supplies by building up our own active pharmaceutical ingredients primary plants. Through these practices, PT Meiji Indonesia has gained its trust to supply both domestic and international market within Meiji Group and other pharmaceutical companies as well. In the spirit of such commitment, we shall move forward in quest of excellence whereby the quality of our human resources shall continuously upgraded. Hence, we have been substantially exercising a series of educational and training programs through our esteemed Meiji Book, Compliance Guidance, and other corporate training programs that everyone has to adhere to, that promote best people in their working place. Moreover, driven by our vision, total customer satisfaction is always our prime priority. We value our relationship with medical professions as our invaluable partner, with whom we work together and to whom we owe much of our success. As a reflection of our mission, we are also committed to pursuing sustainable development and contribution to empower the society and the surrounding communities through our numerous CSR programs. Finally, providing best service is our passion. Walking life's journey with you is our commitment. Our greatest satisfaction is your good health.
welcome to the virtual Indonesian Digestive this week and the virtual AUS ERCP Workshop 2020.
menyikapi pandemi COVID-19 serta tingginya risiko penularan SARS-CoV-2 di lingkungan rumah sakit, berikut ini adalah hal-hal yang perlu diperhatikan. Untuk memutus rantai penularan antara lingkungan rumah sakit dengan luar rumah sakit, gunakan baju khusus saat bekerja di rumah sakit. Cuci tangan sesering mungkin dengan sabun dan air mengalir atau hand sanitizer yang banyak tersedia di semua tempat pelayanan. Lakukan 6 langkah cuci tangan meliputi telapak tangan, punggung tangan, sela-sela jari, buku-buku jari, ibu jari, dan ujung kuku. Setelahnya, bilas dengan air mengalir. Seluruh gerakan mencuci tangan dilakukan selama 60 detik. Tutup keran dengan siku dan keringkan tangan dengan kertas tisu. Gunakan alat pelindung diri sesuai standar yang telah ditetapkan atau sesuai dengan yang telah disediakan. Perlindungan difokuskan pada bagian leher ke atas. Pembagian zona dalam penggunaan alat pelindung diri merujuk pada standar penggunaan alat pelindung diri RSCM dalam menghadapi wabah COVID-19. Gunakan alat pelindung diri level 1 bagi petugas yang bekerja di zona hijau atau area pelayanan umum. Gunakan alat pelindung diri level 2 bagi petugas yang bekerja di zona kuning atau area pelayanan umum di mana dapat ditemukan pasien dalam pengawasan. Gunakan alat pelindung diri level 3 bagi petugas yang bekerja di zona merah atau area pelayanan pasien dalam pengawasan dan pasien yang terkonfirmasi COVID-19. Jika alat pelindung diri sudah selesai digunakan, letakkan pada tempat khusus pembuangan limbah medis. Jangan menggunakan atau meletakkan alat pelindung diri di ruang kerja non-pelayanan. Perhatikan interaksi antar tenaga kesehatan, baik di tempat pelayanan pasien maupun di tempat-tempat lain di lingkungan rumah sakit. Selalu menjaga jarak dan tidak melakukan kontak bila tidak diperlukan. Hindari berkumpul dalam jumlah banyak dan saling berbicara dalam satu ruangan. Bersihkan telepon genggam, laptop, alat tulis, dan benda pribadi lainnya dengan cairan disinfektan sesering mungkin. Hindari penumpukan barang dan berseraknya kertas di atas meja. Cuci tangan sebelum makan dan gunakan peralatan makan pribadi. Hindari makan bersama-sama dalam jarak yang berdekatan. Selalu membawa dan menggunakan peralatan ibadah pribadi. Perhatikan risiko penularan di rumah atau di tempat tinggal lainnya. Perhatikan juga risiko penularan di perjalanan dari dan ke rumah sakit, terutama jika menggunakan transportasi umum. Jangan membawa banyak barang dari rumah ke rumah sakit atau sebaliknya. Dianjurkan untuk mandi sebelum meninggalkan rumah sakit atau segera setelah tiba di rumah. Rendam dan cuci pakaian kerja dengan cairan yang dapat membunuh virus. Terima kasih telah menonton video ini. Semoga bermanfaat dan tetap sehat.
Entyvio is a monoclonal antibody that has been developed for the treatment of moderately to severely active ulcerative colitis and Crohn's disease, two common forms of inflammatory bowel disease or IBD. IBD is associated with altered functions of the immune system. As part of the body's adaptive immune response, lymphocytes are imprinted for migration to areas of inflammation in specific tissues. Entyvio targets a discrete subset of imprinted T cells that preferentially migrate to the GI tract. The accumulation of such immune cells within this tissue contributes to inflammation that is characteristic of ulcerative colitis and Crohn's disease. As part of a process called lymphocyte trafficking, a small number of T cells are known to express the alpha-4 beta-7 integrin, which binds to the mucosal addressin cell adhesion molecule 1, or MAdCAM1. The binding of alpha-4 beta-7 to MAdCAM1 causes cells to enter the inflamed tissue from the vasculature. This interaction primarily occurs at the vascular endothelium in the lamina propria intestinal submucosa and gut-associated lymphoid tissue, the main sites of MAdCAM1 expression. Entivio works by binding to the alpha 4
Assalamualaikum, Kak
beta
Fuad.
7 integrin,
Salam.
preventing its
Kabar.
interaction with its
Iya,
ligand
dah siap,
and
Mau bahasa Inggris atau mau
it
lagi?
selectively inhibits
Aku lihat sepanjang hari ini bahasa Inggris semua orang.
surface of blood vessels within the
Udah siap lah,
gastrointestinal
bahasa Inggris aja Kak ya.
Oke.
As a result, Entivio selectively restricts T-cell recruitment from the
Ini pakai golop kemarin, ya.
Panjang kurang pendek ini. Anu enggak Jawanya ini.
Iya ini, kalau bahasa Inggris kan ngomongnya agak lambat. Ya mungkin agak lewat-lewat waktu dikit, jangan diinterupsi ya, tambah gugup.
Itu waktunya berapa menit ya, Ji?
25.
Imam mana Imam? Halo Imam.
Tadi telepon Imam ada tadi. Lagi sholat kali ya, udah sholat?
Udah, kan di Palembang jam 12 kurang 10 udah. Agak kok.
Yo.
Tempat dulu.
Aku lihat pagi-pagi inian udah di lapangan golf. Cepat nih subuhnya.
As a dynamic enterprise, annual sales turnover of over 1 trillion rupiah.
Kami 5 berapa
PT
sekarang?
Meiji
5 lewat
Indonesia
6.
spread its wings of expansion.
Oh iya, kamu lebih ke barat
One
ya.
expansion leads to the next.
Miring kan?
Horizontally,
Miring.
we are racing ahead to
Marcel
fulfill
tuh.
both domestic
Selamat sore,
and
Dok.
overseas market
Prof.
with certified quality
Selamat
API
sore.
even more competitively.
Mana Prof Marcel? Prof,
Vertically, we are taking new steps to stretch our portfolio beyond pharmaceutical products into
Kita bahasa
cosmetics,
Inggris.
food supplements, hospital health supplies, and medical devices sectors.
Emang mau bahasa Inggris
To
bahasa
support our
Indonesia boleh,
strategic
bahasa
moves
Inggris
and initiative, we
boleh.
have also
Cuman itu
accomplished
peserta
our
kita
strategic
ada yang bahasa
expansion
Inggris nggak?
of our
Peserta
plants and its
dari
facilities.
luar kota, luar negeri nggak?
Our modern warehouse safeguard the quality of our
Ada
products.
ya? Oh, ya itu. Takutnya itu
Our
karena
new
ada
head
peserta dari
office
luar
to ensure the long life journey serve the
negeri
country
Inggris ya?
and the world.
Luar negeri ya? Itu dari luar negeri makanya. Ya udah kita in English aja. Inggris Indonesia nggak apa-apa.
After spanning over than 4 decades, currently PT Meiji Indonesia has the largest penicillin injection facilities in Indonesia and the largest penicillin API manufacturer in Southeast Asia. Our consistent development and expansion, of which we have always been proud of, is much
So we have to
attributed
speak in
to the
English.
well planning and execution of the company's strategic direction.
Belajar Prof.
Selamat siang Prof. Marcel. Siang Prof. Marcel.
Selamat siang.
Dengan Dr. Imam dari
Selamat
Palembang.
siang Dr. Imam.
dari Palembang. Kabar
Ya.
Prof. Kabar Prof.
Baik, gimana? Bagaimana di Palembang?
Ya, jauh ini
COVID-nya banyak turun.
Inspired by the need of quality medicine, we bring a vision to gear up with high-quality products with the highest satisfaction
Jakarta yang
of
paling
our
tinggi ini
customers.
COVID-nya.
We bring more to life all over the world and human health improvement.
Dr. Fauzi, apa kabar
It's
Dr.
an
Fauzi?
ongoing challenge to
Baik,
render
Mas
our
Imam.
best of everything we do. It's what we were brought up to be.
Ya.
In the spirit of the company's vision, we
Di
are
rumah sakit
dedicated
nih.
to carry three-dimensional purpose
Di rumah
to bring PT Meiji
Iya, di rumah-
Indonesia as a clean, green, and trusted company. A clean company that develops organization where excellence thrives is fostered through constant efforts to reach for creativity and innovation in an atmosphere which encourages sense of urgency through market and partner orientation. A green company where we work whilst taking steps to save environment by improving our customer, employees, and communities' lives through our actions and choices in socially and environmentally responsible ways, and conduct our operation in a way that benefits society and the environment. A trusted company where we strive to continue to move forward to improve the quality of people's lives and the health of patients who need our medicines the most. Today, our factory is fully operated by a highly dedicated professional team which runs under two separated production lines of beta-lactam and non-beta-lactam products, supported by modern technology, facilities, and infrastructure. We apply tight validated production method and tight quality control in each production step to ensure high-quality medicines in compliance with the Japanese CGMP standards. In line with our purpose to bring PT Meiji Indonesia as a green company, our plan operates under eco-friendly processes and environment to produce eco-friendly products. Therefore, it is our ultimate goal to eliminate pollutions and save the earth. Being the largest penicillin injection manufacturer in Indonesia, we are also committed to maintaining our quality products and supplies by building up our own active pharmaceutical ingredients primary plants. Through these practices, PT Meiji Indonesia has gained its trust to supply both domestic and international market within Meiji Group and other pharmaceutical companies as well. In the spirit of such commitment, we shall move forward in quest of excellence whereby the quality of our human resources shall continuously upgraded. Hence, we have been substantially exercising a series of educational and training programs through our esteemed Meiji Book, compliance guidance, and other corporate training programs that everyone has to adhere to, that promote best people in their working place. Moreover, driven by our vision, total customer satisfaction is always our prime priority. We value our relationship with medical professions as our invaluable partner, with whom we work together and to whom we owe much of our success. As a reflection of our mission, we are also committed to pursuing sustainable development and contribution to empower the society and the surrounding communities through our numerous CSR programs. Finally, providing best service is our passion. Walking life's journey with you is our commitment. Our greatest satisfaction is your good health.
Good afternoon, ladies and gentlemen. Welcome back to the virtual Indonesian Digestive Disease Week 2020. Ladies and gentlemen, now we will continue our program. The next agenda is Symposium 7 with the topic Probiotics in GI Disease. For this symposium, it will be moderated by Dr. Dr. Fuad Bakri from Division of Gastroenterology and Hepatology, Department of Internal Medicine, Faculty of Medicine, Universitas Sriwijaya Muhammad Hussein General Hospital, and Dr. Imam Supriyanto, MD, from Division of Gastroenterology and Hepatology, Department of Internal Medicine, Faculty of Medicine, Universitas Sriwijaya. To Dr. Fuad Bakri and Dr. Imam Supriyanto, the time is yours.
Okay, thank you, MC. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Good afternoon, ladies and gentlemen, to all the professors, to esteemed doctors, to all consultant gastroenterologists, and all participants to join us in this afternoon. First of all, I would like to thank the organizing committee, special Professor Dr. Dadang Makmun, for entrusting me to be a moderator in the symposium number 7 in this afternoon. Beside me, we have Dr. Imam and me, Dr. Fuad, to be a moderator. Thank you, Dr. Prof. Dadang Makmun. The title, our symposium number 7 in this afternoon is the probiotic in the GI diseases. And we have 3 speakers in this afternoon. The first is Dr. Fauzi Yusuf, Professor Ari Pariasam, and Professor Marcel Majrata. Okay, no wasting time, we start our meeting, symposium number 7. Please, Dr. Iman, invite the speaker to begin the listen for this afternoon. Please, Dr. Iman.
Okay, thank you, Dr. Fuad. Assalamualaikum warahmatullahi wabarakatuh. Maybe for the first, I would like to say thank to organizing committee that already invited me, and also Dr. Fuad Bakri to be moderator in the symposium today. In this symposium, in this session, we have 3 speakers with 3 topics. The first speaker is Dr. Fauzi Yusuf, SPPD KGH, who will talk about the role of gut microbiota in gastrointestinal disease. And the second speaker is Prof. Ari Farial Sham, SPPD KGH, who will talk about the role of probiotic in management of upper GI disease. What is the evidence? And the last speaker is Professor Dr. Marcel Simadibrata, SPPD KGH PhD, who will talk the management of lower gastrointestinal disease. Does probiotic play a role? To shorten the time, maybe I would like to invite the first speaker, Dr. Fauzi, SPPD KGH, who will talk about the role of gut microbiota in gastrointestinal disease. To Dr. Fauzi Yusuf, please. The time is yours. You have 25 minutes for your presentation, Dr. Fauzi.
Assalamualaikum warahmatullahi wabarakatuh. Thank you for the moderator, Dr. Fuad, my teacher, and Dr. Irman, my colleague. And I think it's great to me to join this meeting as a speaker. And thank you for the organizing committee for inviting me to join the wonderful meeting in pandemic era. My topic is the role of gut microbiota in gastrointestinal disease. For introduction, human microbiomes is the collection of microorganisms that live in peaceful coexistence with their host, has been referred to as the microbiota. And the microbiome is the gene they encode is known as the microbiome. The human gut metagenome has at least 100 times as many genes as us. There are 10 to 100 trillion microbes in our GI tract, most in the distal gut, and more than 90% in adults, divide into two pillars, Bacteroidetes and Firmicutes. This picture shows us about the microbiota along our gut, from the stomach, small intestine, and large intestine. Most of microbiota located in the large intestine or colon. About type of human microbiota. Each individual actually has a unique microbial, become is a fingerprint as each individual. Human microbiota divide into the virus, prokaryote, eukaryote. And this picture show us about the expert or the researcher show that the gut microbiota weight can reach up to 1 to kilograms weight, and most and the microbiota located in the gastrointestinal tract, especially in the distal gut. What about the composition of gut microbiota? The gut microbiota has 7 bacterial pillars: Firmicutes, Actinobacteria, Bacteroidetes, Proteobacteria, Cyanobacteria, Fusobacteria, and Ferromicrobiota. And the majority of the GI tract population are representative of only 2 pillars, Firmicutes and Bacteroidetes. This picture shows us about the gut microbiota in development and the disease. If we have the normal or physiology, we call that a term with the symbiosis. And if we have a disease or altered gut microbiota, we call a dysbiosis. The important thing from the researchers, cause of the altered gut microbiota is from the consumption antibiotic, diet, drug, disease, injury, sometimes and from the surgery, and also because we become of the patient have a stress. From pathophysiology, many researchers say that there is a involved immune system for the disease, involved the hormone, bile acid, short chain fatty acid. This is the important thing because this is related to microbiota and biogenic immune and xenometabolite. This diagram shows us about the gut microbiota in development and the disease. There are many factors affecting the microbiome, from the genetic, birth routes, geography, hygiene, stress, and the important thing, diet and nutrition, also a drug we consumption. And if we are in the normal, microbiome is still in stability, in eubiosis. If we are in the disease, that means the microbiota is in dysbiosis. So the researchers state about the microbe we acquire at birth affect our heart and throughout our life. And there is a statement, we are born 99% human, but we die in 90% microbial. This is a picture about the microbiota, dietary food, and short-chain fatty acid. Fat of ingested dietary food component is very important. From the small intestine, large intestine, and pass through the feces. The interesting one is the short-chain fatty acid is become one important metabolites due to the disease. And what about the gut microbiota related to GI disease? The main key feature of human intestinal microbiota long aging and in relation to disease. And we have the microbiota from birth to the all is become influence of many factors. And this diagram show about the diversity and function of the microbiota. Is balancing is mean good, and the heart is still there. And if there is not balancing and become dysbiosis, many disease is become due to microbiota. There is many research from the author about the microbiota can influence the disease, such as EBD, EBS, and colic disease, colorectal cancer, and Clostridium difficile infection. Maybe it is become talk by the expert after my presentation by Prof. Ari and Prof. Marcel Simadibrata. The concept that bacterial infection actually is lead to cancer was first proposed in the late 19th century, following the pioneering work of Robert Koch and Louis Pasteur. And nowadays, commonly investigated many virus and bacteria can be make the cancer type like breast cancer, cervical cancer, gastric cancer, colorectal, prostate, and so on. And many research there is do about the effect and disease state related gut microbiota, obesity, inflammatory bowel disease, colon cancer, atopy, and mental health disorder. And for our topic, many research is do about the how come microbiota influence the inflammatory bowel disease, and how come microbiota influence the colon cancer. There are several predisposing diet, increased fat intake, decreased butyrate omega-3 fatty acid, and antioxidant. And for colon cancer, the expert is assumed that about the decreased vegetable intake, protein intake, and so on. But what is the show in microbiome change? They state that about the IBD and colorectal cancer maybe changes the diversity of Clostridium, Bacteroidetes, Proteobacteria, Firmicutes, Clostridium, and Lactobacillus. And we have some study microbiota and short chain fatty acid in Aceh. There are our study of microbiota that we published in journal. The first microbiota composition had hit shock protein 70 and caspase 3 expression as marker for colorectal cancer. Yeah. And the second, low butyric acid associated with constipation in especially in geriatric patient. And we study about the short chain fatty acid and related to colorectal cancer patient and how impact of probiotic therapy on butyric acid level in IBD patient. And the last, butyric acid as a potential marker for diversity of gut microbiota in colorectal cancer patient. Our first research, the microbiota composition is published in Acta Medica Indonesiana, the Indonesian Journal of Medicine. There is suggested the disappearance of bifidobacterium as one of indicator detection for colorectal cancer. Another study about the level of short chain fatty acid in colorectal cancer, the result is the dominant band from bifidobacterium group vanished in all or lost in subject with colorectal cancer. And we found different spectrum of bifidobacterium in colorectal cancer subject if we compare to the non-colorectal subject. And for conclusion, short chain fatty acid concentration also appear to be lower in a group with the colorectal cancer patient. This is the paper who published one month ago, still new, about the low butyric acid is associated with constipation in geriatric. We divide patient into the two groups, the patient with constipation and no constipation in geriatric. That figures show that the fecal short chain fatty acid level between constipation and non-constipation is appear different, and we exempted about the propionic acid and valeric acid, another short chain fatty acid. And the study showed that the lower level of fecal butyric acid are associated with the increased incidence of constipation in geriatric. From the literature, it's probably because butyric acid mediate anti-inflammatory effect and increasing the contractility of colonic smooth muscle and regulation of intestinal neurotransmission. And another paper about butyric acid, we try to look at how butyric acid can be the potential marker for diversity of gut microbiota in colorectal cancer. And we found that there is a specificity of the butyric acid is good and can be a potential marker for diversity gut microbiota. I think that's maybe need the more large sample to do this research to make the conclusion established about this research. And the last is we have the paper about the impact of probiotic therapy of butyric acid in IBD. This is the pre-experimental case control study with pre and post-intervention assessment. Design was used, and a patient received 2-week probiotic, and 10 control patients received placebo for the same period. The conclusion of this study is the study suggests that the level of butyric acid was increased significantly in IBD patients if we compare to control group on probiotic therapy. I think it is need future research should continue to explore the effect of therapy with larger sample. And last but not least, last year, the American Journal of Gastroenterology published the special issue about the gut microbiome. There are still interesting about the gut microbiome, and that issue they talk about the how gut microbiota can cause the cancer, and how can we detect cancer with the diversity of microbiota, and how can we treatment the cancer based on microbiota. And the issue too about the efficacy of fecal microbiota transplantation in EBS, and the last, the gut microbiome in IBD. I think this issue will be talked with the two experts, Prof. Marcel and Prof. Ari Parlialsam. For conclusion, we have challenges today. Diet is a key issue when it comes to preserve gastrointestinal health, because by eating and digesting, we feed also our gut microbiota and thus influence its diversity and composition microbiota in our body. I think that's all. Thank you for attention. Wassalamualaikum warahmatullahi wabarakatuh.
Okay, thank you, Dr. Fauzi Yusuf, for your nice and informative presentation. And then we would like to invite the second speaker, Professor Dr. Ari Farial SPPD KGH, who will talk about the role of probiotic in the management of upper gastrointestinal disease. What is the evidence? Please, Prof. Ari Farialsam, the time is yours. We know now is Prof. Ari is Dean of Medical Faculty in University of Indonesia, and beside that, he also a chairman of PGI organization. Okay, Prof. Ari, ready?
Yes. Thank you, Dr. Imam, and also Dr. Fuad Bakri, and also organizing committee to invite me to talk in the important symposium this afternoon. And also thank you, Professor Marcel, Professor Dadang, and also Dr. Fauzi. I think Dr. Fauzi have shared the good information about microbiota and the role of probiotics. So here I will talk about the role of probiotics in management of upper GI disease and some update of from these topics. Okay. Yeah, so I'm going to talk about what is a gut microbiota. I think I just stress some word here because Dr. Fauzi have explained about this topic. And I will talk about the role of gut microbiota in maintaining GI health, and also what do the experts concern about the gut microbiota. And there is some evidence, the use of probiotics in GI diseases. And last, conclusion and recommendations. Okay, yes, the Dr. Fauji mentioned about this, what is the gut microbiota? I think we are agree that the microbial population present in many parts of our human body. And therefore, gut microbiota is a microbial population present in the human gut, intestine, upper GI tract as well. Lederberg, 2001, mentioned that actually we not to be confused with microbiome, because microbiome is different with the microbiota. If we talk about microbiome, it refers to the total number of microorganisms and their genetic materials, which also defined as the ecological community on commensal, symbiotic, and pathogenic microorganisms that share human body species. Space. So here, in these pictures, I want to show you that in our GI tract, start from mouth, pharynx, and also respiratory system, there is some bacteria, Streptococcus, Neisseria, Candida, and in the GI tract, in stomach, there is Helicobacter, Phellonella, Bacilli, Lactobacillus. And again, from stomach, go to duodenum, jejunum, ileum, and colon. We can see here many kind of bacteria live in our body. And also in our skin, we can see here that there is some bacteria here, and from urogenital tract as well. And so from these pictures, we can see that all part of body there is a bacteria. It depends. It is what we call that the probiotics. This is a good one or a bad one. Yeah, from these pictures, we can see that actually for bacteria which live in upper GI tract, we call that as aerobic organisms. But bacteria live in lower GI tract, most of them anaerobic organisms. And we can see here what is the prominent bacterial populations in stomach, our duodenum, jejunum, ileum, and colon. You can see here what kind of bacteria live in our GI tract. Okay. Okay, so now the informations that there is so many types of bacteria live in our body. Now, what is the role of gut microbiota in maintaining GI health? I think this is good information for us. So, so there is some mechanism of actions. First, about the immunomodulations. Yeah, mean that they will increase the number of IgE secreting cells in the intestinal mucosa, and also what we call that the facilitate transfer of antigens to the submucosal lymphocyte, ensuring a more immediate immune reaction. And another mechanism of actions of microbiota is antibacterial actions to productions of antibacterial substance and action against common pathogen. In the directly, you know that like Clostridium difficile, this is one bacteria that can attack our body if our patients get antibiotics for long time, like sometimes around 2 weeks is enough. The patients, what we call that, suffer with antibiotic associated diarrhea due to the Clostridium difficile. This is a microbiotic, so we call microbiota can act to against this common Clostridium difficile. And also the competitive exclusion, compete with adhesion of pathogens to intestinal mucosa, and colonization of the intestine with the beneficial bacteria. You know that when bacteria live in the colon, they will produce short chain fatty acid. This is the one that the important of gut microbiota to maintain our GI. Yes, this is so from these pictures we can see how that the microbiota work. Something like this, like compete with the pathogen. Okay, and then how that the microbiota works to increase our immune response that the professor that Dr. Fauzi have mentioned before. And here the other things that in normal, I mean in the host health conditions, what we call that they have normal microbiota. So something like this, that the lactobacillus can direct exclusion and competitions with the pathogens. And also I mentioned that they will produce the lactic acid bacteriosin and also inhibition to inhibit pathogens. And but in the abnormal microbiota, so there is no actions of microbiota who will attack the pathogens or will inhibit the pathogens. So what we call that in this situation, this patient suffer or what we call the condition is with this dysbiosis. So this is so if our patient have dysbiosis, we can see that there is abnormal microbiota inside their GI tract. Yes, this is another way that how when the pathogen came, our probiotics start to attack, but they will give a sign to a microbiota, a commensal bacterium, and then to what we call that to immunomodulations. Yes, and then but sometimes the pathogens will directly to go to inside our intestine to make something wrong to our intestine. This is good pictures to show us how that the microbiota work inside our GI tract. Yeah, next, you know, there's many microbiotic in our market as well. So what is the criteria of ideal probiotics use? The organism must be fully identified. First, we know the genus, species, and also strain. This is the important things. And no pathogenic effect, and no toxicity, and not associated with disease or resistant gene. Of course, these probiotics must be viable and stable. Sometimes some probiotics we must keep in refrigerators to keep in temperature 2 until 8 Celsius or something like that. And then the important things, the probiotics resistant to bile acid and digestive enzyme. And then they can mass adhere to mucosal surface and colonize the intestine. And stable during processing and storage, I mentioned that. And must have sufficient number of viable cells. This is the important, because you know that the numbers is the important when they will work to affect for our GI tract. And yes, must undergo, there is in vivo and in vitro trials to prove any attributed probiotics effect and also documented clinical benefits. I think so we must be careful if you have information, get information that these probiotics will work. So you must see what in vivo and in vitro trials of this strain. And then maybe if there is any information about the clinical trials using this strain. Again, don't forget, not only species, but also we must to know what is the strain of our probiotics. Yes, so first we will, this is another benefit of probiotics, or especially in upper GI for our stomach, for Helicobacter pylori. And mastic 4, I think this is important consensus. So we always use this as our reference. For patients with pylori that we will give triple or quadruple antibiotic therapy, there will be antibiotic side effect. So in these conditions, probiotic will reduce the antibiotic side effect of because of a triple and quadruple antibiotic therapy. So this is mentioned in Maastricht 4 management of Helicobacter pylori infection. This is our study. I mean that the Miftah is a PI of the study, and Dr. Miftah now is a vice rector of University of Erlangen, working together with Professor Yamaoka from Oita University. We want to know about the gastric microbiota inside Indonesian population. So from our biopsy, we can see that if patients with the pylori, so dominance of is their stomach, leave the Helicobacter. And if we see this more detail about what is the compositions, so patients with the Helicobacter pylori, the dominant is Helicobacter pylori. So this is the information. But another things, we know that actually beside pylori, there is another family, another bacteria live in our body, in our stomach, because this is from Indonesian's population. Okay, and here is also the species of the study. You can go to this paper if you want to know more detail about our study here and published in the Helicobacter. I think this is the prestigious journals talk about the Helicobacter. Okay, this is another another study mentioned about the role of probiotics, especially for Helicobacter pylori eradications. So in this study, they used the sequential therapy and the Lactobacillus reuteri supplementation. And the result of this study, reuteri supplementations could reduce the frequency and the intensity of antibiotic-associated side effect. So this is these informations, yeah, to in line that with Maastricht consensus, because they mentioned that this study look for about the supplementations of Rituri can reduce the frequency and also the intensity of antibiotic-associated side effect. Okay, yes, this is from our, Asians, Helicobacter pylori management in Asian, that the I am Professor Ajis Rani, contribute to this consensus. And this consensus, we mentioned that so in this consensus, we mentioned that actually, again, that the probiotic can help to reduce the side effect. And then we have some data, and then published in these articles, that the probiotics, supplementation of probiotics for eradications of Helicobacter pylori, and also what we call that increase the eradication rate of Helicobacter pylori eradication. Yes, this is the informations how that the Lactobacillus Rituri work. Okay, first from that they will produce vitamin, and then they will produce Riturin that have antimicrobial works like lactic acid. Okay, and then they will be enhanced colonization, and also enhance adherence against infections, and also produce histamine that highly flame dependent and dependent on H2R and anti-inflammatory. So this strain can work to attack or to prevent infection, and also work to neuromodulations, and also work to immunomodulations, and then really work as a good microbiota in our GI tract. There is another study from Oggetti from Italy about the impact of Lactobacillus Rituri supplementations on as an anti-Helicobacter pylori levofloxacin-based second-line therapy. Remember that if you want to use levofloxacin just for second-line treatment, don't use the levofloxacin. It's the first-line treatment for Helicobacter pylori. So, like in this study from Professor Oggetti. So they included 45 patients positive for Helicobacter infections, and received triple antibiotic therapy based on esomeprazole 20 milligrams. Yeah, sometimes we use 40 milligrams BID. And they use levofloxacin 5% BID and amoxicillin 1 gram BID. In this study, they only use for 7 days, plus Lactobacillus Rituri BID for 14 days, and then during eradication treatment and 1 week thereafter. So altogether for 14 days. And 40 patients received the same triple therapy, but without probiotics. So I think this is a good research, double-blind. You can see that the one group without supplementation, then another group with supplementation. Okay, so from this result pictures, we can see that with Rituri, they can get good eradication rate, 80%, but without Rituri, only 60%. So from the study, we can see that the eradication rate increase if we give Lactobacillus to our patients during and after eradication based on this study. Okay, how about the side effect like nausea here and also diarrhea? Yeah, we can see that without treatment and pre-treatment, so with the nausea decrease, and also we can see here that the diarrhea is in only small number patients with the diarrhea if we give supplementation of Ritari compare with the group without Ritari. Okay, this is another study from, yes, I think this is from Italy again, to see that the Lactobacillus strain combinations of in Helicobacter pylori infections, randomized, double-blind, and placebo-controlled study. Okay, again here to see that the 100 patients, 50 supplemented by Ritari before, during, and standard triple therapy, and then 50 placebo. Okay, without supplementation. Okay, and the main endpoint of this study is reductions of infection load and symptoms. Okay. Okay, so here we can see that the the UBT day 0 to day 80 about the Helicobacter pylori load. So we can see here and supplementations. Okay. Supplementations that reduce bacterial load of Helicobacter pylori and decrease the related symptoms from these pictures. Yeah, compare with the placebo. Again, so this is a benefit to give combinations, eradications, therapy with supplementations of these probiotics. Okay, again, to give you informations about what is the GSRS change and also overall eradications and with and without. So we can see here. And this is another information that the Ritari is advantageous in the treatment of Helicobacter pylori as the supplementations eradicate the pathogens without causing the common side effect associated with antibiotic therapy.
Excuse me, the remaining time is 5 minutes more.
Okay, thank you. So this is some information to mention about the role of the lactobacillus and then why that the lactobacillus can work well in our patients, especially for against the Helicobacter pylori. Yes, thank you, moderators, participants. This is conclusions and some recommendations. Microbiota has important role that I mentioned in maintaining gastrointestinal tract health, and clinical use and trial with probiotics are increasing much in this decade. Clinicians might address this is a new trend of the management for GI diseases. Beware about the strain-specific effect. This is the important things because many probiotics offer to clinicians about the effect and stuff. So you must be careful to read about the paper mention about evidence base of these probiotics. The Lactobacillus and Bifidobacterium are two genera of microflora and probiotic which have been investigated extensively. Further clinical trials are warranted to prove its bacteria's efficacy when used as adjunctive probiotic therapy for particular disease. So I think we must know that there's evidence-based medicine or not in this using this product. So from this, maybe we can make a new consensus about how that we can treat or combine probiotics with other GI, other treatment to other GI disease. Again, thank you for your attention and Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Prof. Maria, for your presentation relate the role of probiotic in the management of upper gastrointestinal. You have already seen that there is so strong evidence that of the important role of probiotic in the treatment of upper gastrointestinal tract. And then we will invite the last speaker to be present by Marcel Simadibra tadi. Prof. Marcel will talk about the management of lower gastrointestinal disease, thus probiotic role. To Prof. Marcel, please, time is yours.
Thank you, Dr. Imam and Dr. Fuad Bakri as the moderator of this symposium. Thank you for the organizing committee and also the sponsor of this symposium. I have a topic, management of lower GI diseases. Does probiotics play a role? As you know that, as already mentioned by Dr. Fauzi and also Prof. Arif Arialsam, that probiotics has a good benefit and a good role in the health of the gut and the health of the GI gastrointestinal tract. So also in the lower GI, the probiotics also has a good role in maintaining the health of lower GI tract. So this is my outline. So as you know that human gut microbiota have profound effects in the development and maintenance of body system, like for the metabolism, to normalize the immune regulation, and for the normalize the neurologic function. And many studies showed that probiotics can prevent and treat lower GI diseases. This is the probiotics in the market. You can find in the mall or in the market. You can buy probiotic in the mode of yogurt. Yeah. This is definition of probiotics by the WGO. It's defined that probiotic is the live microorganism that when administered in adequate amount confer a good health benefit on the host. And that's the difference with prebiotic. Prebiotic is the food for the probiotics. And sometimes in the market, in the medicine and in the market, we combine the probiotics and prebiotic and we call it symbiotics. Yeah. This is the classification of probiotic in Indonesia and the world. We have two kinds of probiotics, medicinal supplement and food yogurt. So we have live probiotics. And the medicinal supplement consists of single probiotics, yeah, the usually single or multiple bacteria, or we have also combination probiotics. And according to the live or diet bacteria, we have the live and tendernized probiotics. Like lacto-adi, dilac, it is tendernized probiotics. And also we have probiotics made by yeast, like Saccharomyces boulardii or Bacillus clausii. Yeah. And this is the effect of probiotic in the gut that's already been mentioned by Dr. Fauzi and Prof. Ari, to stabilization of intestinal mucosal barrier, enhancement of immune defense, increased level secretory immunoglobulin A, and the others. So it will normalize and stabilizing the health of the gut. And the WTO already announced the effect of probiotic and prebiotic in the world. So by guideline by the World Gastroenterology Organization in 2017. And one of the disease that can be treated by the probiotic is antibiotic-associated diarrhea. Like we can have yogurt, contains Lactobacillus casei, also Lactobacillus acidiphilus, Lactobacillus rhamnosus, Saccharomyces boulardii, Lactobacillus reuteri, and other probiotic bifidobacterium, it can be used for treating the antibiotic-associated diarrhea. This is for the meta-analysis study showed that probiotics have benefit to treat or to prevent the antibiotic-associated diarrhea. And also, the WGO also announced that probiotic has a benefit in treating the functional constipation. We have Bifidobacterium, Lactobacillus reuteri, lactulose, and other treatment to treat this functional constipation. This is studied by our specialized Agustinus Taulin, consultant gastroenterology, and make a double-blind randomized control trial on chronic functional constipation by using the Lactobacillus reuteri for 4 weeks. Yeah, and this is a method. So there were 40 patients with chronic functional constipation and were treated by Lactobacillus reuteri 2 times 1 tablet per day, and we checked the Agascan constipation scoring system before and after treatment for weeks. Yeah, and this is Agascan, and this is the aim of the 4 weeks intake Lactobacillus reuteri using 2 times 1 tablet per day for 4 weeks, and the result is that there was a change of the defecation frequency, and there is also already the change of efficacy, difficulty of defecation. Yeah, and also there were changes of the feeling incomplete evacuation after treatment with Lactobacillus reuteri, and change of abdominal pain. So there is improvement of about the symptom of abdominal pain after giving the Lactobacillus reuteri in patient with constipation. Also, there were changing of minutes in lavatory per attempt and changes of type of assistance for constipation. Also, there is change of unsuccessful attempts of evacuation per 24 hours, and there were change of duration of constipation. So the conclusion of the study, there were improvement in defecation pattern in chronic functional constipation, increased number of Lactobacillus reuteri phases in chronic functional constipation patients, and reduction of the pH of the stool in chronic functional constipation. Probiotic Lactobacillus reuteri could be as long-term treatment option for patients with functional constipation, and patients with chronic functional constipation benefit by the treatment by Lactobacillus reuteri treatment. And the safety, there were no side effect of Lactobacillus reuteri admission in this study. So also there is a study about probiotics in irritable bowel syndrome. We have a lot of studies, and one of the from Michelin in European Journal of Gastroenterology and Hepatology, they reported that there is improvement of abdominal pain and symptoms if the patient were treated by the probiotics compared to the placebo. So this is also the a lot of studies that showed that there is benefit of the probiotics in irritable bowel syndrome, like using the Bifidobacterium bifidum, Lactobacillus plantarum, Escherichia coli, Lactobacillus rhamnosus, and also Saccharomyces boulardii. Treating the IBS, there were improvement of the symptoms by using these probiotics. And from the meta-analysis, we showed that there is improvement of the symptoms of irritable bowel syndrome if we use the probiotics compared to placebo for abdominal pain. Also improvement for the symptom of distension and bloating if we use the probiotic compared to the placebo, and also improvement of bowel habit dissatisfaction if we use the probiotics compared to placebo. How is the effect of probiotics on acute diarrhea in adults? Yeah,
So this is a study from Shornikova, 1997, and et al. Showed that there is improvement of the symptoms and also the diarrhea by using the lactobacillus cereus after treatment. So there is good result of giving supplementation lactobacillus cereus in gastroenteritis, acute gastroenteritis rotavirus. Yeah. Also, we in Cipto Mangunkusumo and other hospitals in Jakarta showed there is improvement and shortening of the duration of the diarrhea if we use supplementation of Lactobacillus rhamnosus and Lactobacillus acidophilus. Besides, we use the fluid, oral fluid, in acute diarrhea in adult patients. So we do this study in 2007 and until 2010, and then there is a shortening of the duration of diarrhea if compared to placebo, but the frequency and the stool is not different. Yeah, and then, so the supplementation of probiotics, Lactobacillus acidophilus and rhamnosus, showed there is a significant faster recovery from the diarrhea. And also there is a from the study of Cochrane infectious disease group trial by Allen and et al. Showed that there is improvement of diarrhea, acute infectious diarrhea, if we give probiotics for treating this diarrhea, acute infectious diarrhea. This is the plot of the meta-analysis of the probiotics in acute infectious diarrhea. So there is the diarrhea is improved better and also faster than placebo. So there is improvement in probiotics group if compared to placebo. So in conclusion of the study, that the use alongside rehydration therapy, probiotics appear to be safe and have clear beneficial effects in shortening the duration and reducing stool frequency in acute infectious diarrhea. However, more research is needed to guide the use of particular probiotic regimens in specific patient groups. And how is the use of probiotics in chronic inflammatory bowel disease? So in this disease, the use of probiotics is still controversial. Yeah. In ulcerative colitis, there is benefit. The probiotics can maintain the remission in ulcerative colitis patient. And also in another study by Kato, there is the benefit of using bifidobacterial fermented fill product in ulcerative colitis if compared to placebo. Yeah. But in Crohn's disease, there is still controversial. There is some studies showed that there is no effect of the probiotics in maintaining or in the treatment of Crohn's disease. And the study, Guslandi showed that Saccharomyces can be benefit for this Crohn's disease, but another study from Fujifa showed that no significant effect of probiotic treatments in the treatment of Crohn's disease and the remission of Crohn's disease. Also in Plantera, Lactobacillus disease is not so benefit, do not have benefit and to reduce the Crohn's disease and to treat the Crohn's disease. Yeah. And how about the effect of probiotic in diarrhea associated with chemotherapy? So many studies showed that there is improvement of the diarrhea associated with chemotherapy with the supplementation of probiotics. Yeah. So ladies and gentlemen, that we conclude that probiotics play a role in the lower GI diseases, and probiotics have many beneficial effects for the gastrointestinal tract. So, but maybe we must need a lot of studies to conclude this one. Thank you very much for your attention. We give back to the moderator. Thank you, Dr. Imam.
Okay, thank you for and continue to the natural, some question from for the
Okay.
Question from Muhammad Firhab. Question for the recommended dietary for the maintaining microbiota. Please, Dr. Fauzi, can you answer?
Dr. Fuad, voice and maybe Dr. Imam can help Dr. Fuad to speak about the
Suaranya pecah. Suaranya pecah.
Ya.
Kedengaran. Ada yang seperti
Maybe Dr. Fuad can repeat the question.
Maybe there is a question addressed to Dr. Fauzi. The question is, was it recommended dietary composition for maintaining healthy microbiota? You can hear the question?
I can check clearly, but I still to the microbiota is if the mention about the material about the and if the gut microbiota is good, the composition is good, and he can maintain the focus of gut and can produce such as immune and immune too can maintain the healthy of gut to protect from the disease. I think that's all. I hope that can answer the question because the question not clear. I can head. Dr. Imam and Dr. Fuad.
Okay, Dr. Fauzi, thank you for your explanation about relate with the question. And we have other question addressed to Prof. Ari. The question is, does probiotic have a benefit for other upper GI disease other than H. pylori related disease? Maybe this question addressed for Prof. Arif Faryal.
Yeah, thank you, Dr. Imam. So I think this is a good, important question from one of our participants. Yes, until now, the evidence based on the mention about the role of probiotics for Helicobacter pylori. And then actually another study want to know about that it will be effective to reduce acid like in a GERD patient, but the result of the study not significant. So I think we cannot. I mean, so from this study that the probiotics cannot effective if we use it for GERD patient. But yeah, until now the information just only for Helicobacter pylori, because you know that they will be compete, and also they will be produce something that can inhibit the pathogens. So this is my answer to this question, Dr. Imam.
Okay, Prof. Ali. Maybe for upper GI disease, the probiotic cannot use for all condition, especially for GERD. Like that, Prof. Ari?
Yeah, that's right. That's right. Yes.
Okay. Maybe Dr. Fuad, is there any question from the participation? From the participants?
Okay, Dr. Imam. Maybe next question for the speaker. Yeah. What are the probiotic strain available in Indonesia? Maybe all speakers.
Okay. What kind of probiotics? We have, as I already mentioned from my slides, that we have the medicinal probiotics and we have the market yogurt. So we can have yogurt in the mall, in the market. We have two kinds of probiotics, medicinal supplement probiotics and yogurt probiotics. So the medicinal supplement we have by Rilus, by the Kalbe, we have Interlac, Lactobacillus reuteri by Interbat, we have Lacidofil by Dexa. We have a lot of probiotics, medicinal probiotics. But in the market we have food yogurt. We have Activia, but now it's not available in the market. We have Greek yogurt, we have Bulgaricus yogurt, we have American yogurt. We have a lot of yogurt in the market, so you can find a lot of probiotics in the market. I think. Thank you for that.
Okay, thank you. From me maybe, yeah. When we need really probiotic for our condition, some condition maybe we must take a probiotic. Maybe for all speaker. Please, Dr. Prof. Ari, maybe.
Yeah. So yeah. So I think regarding the question for everybody, for every speakers, that Professor Marcel have answered the question. So I think there is some probiotics in our market. Some only probiotics, some combination probiotic prebiotic or something like that. And regarding the question about first we can use the probiotics for immune modulations. I mean, that's only for for health. And then you can get probiotics inside your food, like in yogurt and something like that the Professor Marcel mentioned. And the second things, actually, it depends the evidence. I mean, like this is the evidence of using these probiotics for some disease. So in our daily practice, actually, we can use these probiotics for some disease. Yeah, like to improve or to prevent antibiotic-associated diarrhea. For example, that if patients with abscess, something like that, so sometimes the NT doctors will give the medicine will give antibiotics for minimally 2 weeks, something like that. So I think in this place we can use combine for the probiotics and the other things to treat, like Prof. Marcel mentioned, the probiotic can work for IBD cases or something like that. So it depends. It depends what is your aim to give probiotic for your patient, just for to prevent or to treat or as a supplementations with the standard treatment for some disease. This is my answer, Professor Dr. Fuad.
Okay, maybe Dr. Fauzi, maybe.
Yes. Thank you, Dr. Fuad. I think related with the question, don't forget we have a kind of prebiotic. Prebiotic is the food for the microbiota, and we know the Indonesia rich of prebiotic, such as fruit like banana and garlic and another fruit like the vegetables and corn. Yeah, that kind of prebiotic can help the work of microbiota composition in stable in our gut. That's Dr. Fuad.
Okay. Maybe Dr. Marcel, maybe maybe some different pre-po and symbiotic. What do you call? When we take from the pre, when we go symbiotic.
Oh, sorry, I cannot hear you, Dr. Fuad. I cannot hear you.
Okay. You mentioned there are prebiotic, probiotic, and symbiotic.
Yes.
When choice.
Yeah. Okay. Thank you for the questions, Dr. Fuad. So we usually if there is dysbiosis, we use the probiotics. But if the patient, besides of dysbiosis, the patient has constipation, we can use the probiotics combination, probiotics and prebiotics. So the patient can benefit from the prebiotics because prebiotics consist of fiber. So the patient, the constipation will improve by the giving of the prebiotics. But we do not know what's the evidence about giving the prebiotics plus probiotics compared to only probiotics. So I think depends on the strain of the probiotics. If we give probiotics like Lactobacillus reuteri, it's improved the constipation. We did not need the use of prebiotics as much as the other probiotics. But we can use another prebiotics like fruits and vegetables. So do not use the prebiotics, the commercial prebiotics. Yeah. So we use only the probiotics, and then we combine with fruits and vegetables, and a lot of water for the fluids and water. I think that, Dr. Fuad.
Thank you. Dr. Imam,
I still have one thing maybe for all speaker maybe. We know that in our country there's several probiotics have already available in market, and most of the probiotic use lactobacillus and maybe bifidobacterium species. My question is, why the probiotic chose this species as a live microorganism? Maybe I need the explanation, maybe from Prof. Ari or Prof. Marcel or Dr. Fauzi.
Yeah. I want to answer the question first. I think, it depends. I mean, it depends the evidence base of these probiotics.
So as far as I know, that this species is, from this species is many data that mention that for some disease using this lactobacillus and bifidobacterium, something like that. So so it depends. So it depends the study abroad, yeah. And I think Professor Marcel have experience using some of probiotics, especially for acute diarrhea, Professor Marcel, and it works, something like that. So yeah, this is there's many lactobacillus and bifidobacterium in our market, because this is based on evidence-based using this bacteria.
Okay, thank you, Prof. Ari, for your explanation. Maybe we still have one question from the participant to all speaker. Maybe the question is, what are the potential side effects of probiotic? This question is addressed to all speakers.
Yeah.
What are the potential side effects of probiotic?
Okay.
Okay, can I answer that?
Yeah, okay.
Yeah. Okay. From the studies, there are no serious effect of the probiotics, but we have to be. There is a precaution if we use the probiotics. Don't use too much, and don't use in patient with depression of immune system, like we have cancer patient, or we have low immune system like HIV. We have to be careful if we use that one. And also we have to use the probiotics according to the literature, to the study. What is the effect and what is the side effect complication if we use too much. So we have to know about the study, yeah. But every study showed that there is no serious effect of the probiotics. Thank you.
Thank you for your explanation, Prof. Marcel. And Dr. Fuad.
Okay,
Is there
I
any
think
question?
it's time. Maybe,
Okay.
For time, maybe there are no question anymore. I think we have to close, Imam. Imam.
Okay. Okay, because there is a limited time limitation, we have to close the discussion today, and we would like to say thanks to all speaker and also to all participants, and don't forget to give applause for our speaker today.
Okay, thank you, Prof. Marcel, Dr. Fauzi.
Thank you.
Ari.
Thank you.
Very much.
Thank you.
Thank you, Dr.
Thank you to all speakers and moderators. So we will have a photo session to all of the speakers and moderators. You may look forward into the camera because we will take a picture. Okay, I will count in 1, 2, 3, capture. Okay, once again, thank you very much to all of the speakers and moderators for a very nice session. Ladies and gentlemen, now we will continue our last program of this day. Next agenda is Symposium 8 with the topic Improving Quality in Colonoscopy, the Role of PEG, What's New, sponsored by Meiji. For this symposium, it will be moderated by Dr. Kaka Renaldi, the head of Division of Gastroenterology, Department of Internal Medicine, Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo Hospital. To Dr. Kaka Renaldi, please, the time is yours.
Thank you, MC Dr. Saskia.
Thank you.
Assalamualaikum warahmatullahi wabarakatuh. I hope even this is the last meeting of today, the participants still eagerly to hear this topic because I think this is very important topics because colonoscopy must have a very good bowl preparation so we can get a very good result, especially for the patient. And for the first speaker, we will have Professor Murdani Abdullah, who will talk about adenoma detection rate and how to increase. Without further ado, please, Professor Murdani Abdullah, the time is yours. Hello, Professor Murdani. I know it's a little bit early for maybe Professor Murdani. Maybe the committee can contact Professor Murdani. Professor Murdani. Yeah, we know that Professor Murdani is very actively do research about colon cancer and also in inflammatory bowel disease. He's now the chief of the IMERI in the term of research in IMERI. Okay, Professor Murdani. Hello, Professor Murdani. Okay, Dr. Saskia. Hello. Okay, Professor Murdani, thank you so much.
Sorry.
Okay, yeah, I think we are a little bit ahead of our schedule. It's okay, Professor Murdani. Okay, yeah. Without further ado, please, the time is yours, Professor Murdani.
Oke, terima kasih Dr. Kaka. Thank you, Dr. Kaka. Sorry. May I share my screen? Okay. Yep. Can you see my screen?
Yes, yes, of course, very clearly, Professor Murdani.
Okay. Well, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Thank you, Dr. Kaka, and good afternoon, all colleagues. My test today a little bit tough because I have to talk on some instrument that scarcely available in our unit, but I've tried to find any literature available to review all the paper on the topic. My topic today is adenoma detection rates, how to increase. Well, the outline of my talk will be introduction, and there are some strategy to increase the adenoma detection rate. There is what we call high quality bowel preparation, spending enough time, technique and technologies, and then conclusion. Well, I think I'll start with the fact that colorectal cancer is the second most common cancer diagnosed among male subjects in Indonesia. Colonoscopy is recognized as the most effective method for the diagnosis of adenomas, and endoscopic resection of this lesion would prevent a colorectal cancer. The adenoma detection rate, ADR, is considered an important quality indicator for colonoscopy. What we define as adenoma detection rate is the proportion of patient aged 50 years or more or undergoing screening colonoscopy in which at least one adenomatous polyp is found. The minimum ADR target for CRC screening is 25%, 20% for women, and 30% for men. And low ADRs are closely related to the occurrence of interval cancer. Interval cancer appear between two colonoscopy for screening, mostly in right colon segment, and there are some study showed that 10-fold increased risk if adenoma detection rate less than 20%. In other side, there are what we call adenoma miss rates or AMR. AMR have been suggested in tandem studies as a surrogate indicator of quality. AMR can provide additional information on standard colonoscopy that is not available from ADR. And previous tandem studies have shown that adenoma miss rates are higher on the right side of the colon. And colonoscopy so far is more effective for left-sided colon compared with right-sided colon cancer. And primary prevention strategies for early detection is to will reduce the rise in incidence and adenoma detection rates can decrease the risk of CRC. There are reports to say that 1% increase in ADR will decrease 3% in risk of colorectal cancer. But there are still very few gastroenterologists, including me, use ADR as specific quality measurements. And ADR between endoscopies varies quite widely. And the problem is how to improve our ADR performance. Those are some strategies could be considered, such as achieving a high quality bowel preparation, spending enough time mostly during withdrawal colonoscopy, and improve the technique of colonoscopy, and most importantly, I think technology, endoscopic technology. Let me try to review one by one. Firstly, high quality bowel preparation. We can use some scale to validate our bowel preparation quality rating scale during colonoscopy. We recognize there are Aronchik scale, Boston bowel prep scale, the Hartfield cleansing scale, the Chicago bowel preparation scale. There are some instrument, but the one we have used in our center is Aronchik bowel preparation. We can see whether the preparation good, fair, poor, or inadequate due to modified Aronchik bowel preparation scale. What about the correlation between bowel preparation and the adenoma detection rate in screening colonoscopy? Does it important? Let's see the study by Park reported that he could not find any correlation between high quality bowel preparation and PDR, polyp detection rate, ADR, and advanced ADR. But for cecal intubation, it seemed to be poor bowel preparation will take more time for a cecal intubation time. So this study conclude that the adenoma detection rates was unrelated to the quality of bowel preparation for screening colonoscopy. But some other factors such as older age, obesity, and smoking were independent risk factors for adenoma detection. The second strategy is spending enough time. The goal is to ensure that the endoscopists have adequate time and energy to spend examining each patient's colon for polyp. We need to check our withdrawal times, record the times the cecum is reached, and the time the colonoscopy is completed in the endoscopy's software system. I think all we are using the good endoscopic software system, so it can be easy for us to record the cycle intubation and the time when we finish the colonoscopy. This is what we call withdrawal time. Increasing time spent examining the colon for polyps will improve adenoma detection rates. Second, we need to increase the colonoscopy performance by adjusting daily case schedule, examining endoscopist fatigue levels throughout the day, examine your sedation practice during colonoscopy, ensure the patient are adequately and safely sedated. I think we have recognized that a minimum 6 minutes withdrawal time positively influence the adenoma detection rate. Additional position changes during withdrawal may increase visualization. However, prescribed withdrawal position changes may not enhance the ADR when the baseline exceeds the recommendation standard. Despite endoscopies withdrawing slowly with dynamic position changes, miss rates in the right colon remain unacceptably high. Thus, technological advances have been sought to improve adenoma detection. Routine examination of the right colon in the retroflex position, I think a good technique, even though it's a bit increase the complication, mostly the risk for a perforation because of retroflex position of the scope. And another strategy is to go back forward to the cecum to find out any polyp missing in the right side colon. And we need to achieve a cecal intubation, and some other techniques is water-aided colonoscopy, both water immersion or water exchange. And in this case, teamwork, both endoscopists and support staff, very important. The standard wide-angle, high-definition endoscopes combined with widescreen, high-definition monitors is important for improving color contrast compared with surrounding colonic mucosa and improving visualization of areas behind colonic folds. This article to show the impact of link color imaging on colorectal adenoma detection. The paper conclude that it showed that LCI, link color imaging, increased the detection of colorectal adenoma during colonoscopy. We can see here, sorry, I cannot show you. figure number 1, figure A, is from white light colonoscopy. It is very hard to find any lesion in this during using white light endoscopy. But figure C, we can see clearly. Sorry, I cannot show you, but there you can see. I cannot point out the lesion. There are, you can see clearly there are some small lesion in the figure C using LCI, and you can magnify the lesion. There's a flat lesion which can be clearly showed by LCI and hardly find using only white light endoscopy. And these are also some deep press lesion. Figure are figure from white light colonoscopy, but you can see clearly figure D, there are some deep press lesion there. So technology can help us to find out, to detect the adenoma. Another technology is full spectrum endoscope. Full spectrum endoscope, I think, has been demonstrated the last couple of years during our IDDW. This study a new generation full spectrum endoscopy versus standard forward viewing colonoscopy. This is a multi-center randomized tandem colonoscopy trial by Kudo. You can see figure A is from white light endoscopy, front viewing colonoscopy, but figure B is from fuse, and you can see clearly on the right side there are polyp there. So both endoscopy actually can find this polyp. And this study very interesting because they found that fuse is superior to standard front viewing colonoscopy regarding both adenoma miss rate, and additionally EMR is both significantly lower with fuse than standard colonoscopy for lesion 5 mm in size and in the ascending colon. So yeah, so using fuse, we hope that missing adenoma missing rate will be lower. These are some other technologies in the colonoscopy and technologies. This one is third eye retroflex colonoscopy. Figure B showing fuse, and this one endocarp. This study about misadenoma with behind fold visualizing colonoscopy technologies compare with standard colonoscopy. It is a pool analysis of 3 randomized back-to-back tandem colonoscopy studies. We can see here that using those instrument will increase the adenoma detection rate. In conclusion, this study saying that behind fold visualizing colonoscopy reduce miss rate for 1 to 9 mm adenomas in the entire colon, whereas no advantages was found for more than 10 millimeter and advanced adenomas. So those instruments will be good for a small polyp. Another study, new technologies improve adenoma detection rate, adenoma miss rate, and polyp detection rate. This is a systematic review and meta-analysis.
In this study, we can see clearly that newer endoscopic technologies are an effective option to improve adenoma detection rate and polyp detection rate and decrease adenoma miss rate, in particularly with mechanical new technology, but there are no difference in operability and safety. Well, those are, however, these technologies will create more cost for colonoscopy. In this slide, we can see that using cap, endocuff, endoring, GIs will increase the cost for colonoscopy. Those are some other instrument, what we call endorings. Is single-use scope attachment consisting of 2 layers of flexible, soft circular silicone rings placed on a cylindrical cuff. Statistically, a significant lower adenoma miss rate compared to conventional colonoscopy. 10% versus 48% is very significant statistically. Well, I will conclude my talk. Colorectal carcinoma is still a major world problem because it has high incidence and high mortality. Colonoscopy has been established as the gold standard for screening of colorectal cancer. Adenoma detection rate can decrease the risk of CRC, and improving the ADR performance can be done by achieving high quality bowel preparation, spending enough time, improve your endoscopic technique, and using some technologies to help to improve adenoma detection rate. Many of these endoscopes and devices show promise improving adenoma detection rate, but future research will be required in this case. Thank you for your attention. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Professor Murdani, for very exciting presentation, because I think adenoma detection rate is very crucial, especially for the beginner, because this is the basic for us, and most important for patient, so we can detect the earlier the possible for colon cancer. Now we forward to the second speaker. That will be Dr. Bradley Jimmy Waleleng. He is not from Belanda, but he's from Manado, because his name like foreigner, but he is still Indonesian from Manado. He's very well known because of the head of gastroenterologist and hepatology division from Manado. Without further ado, Dr. Bradley Jimmy Waleleng will bring the topic about achieving the best bowel preparation for colonoscopy and the role of PEG. Yeah, the time is yours, Dr. Bradley.
Thank you, Mr. Chairman, Dr. Kaka. Good afternoon for everyone, and thank you for organizing committee to invite me for this meeting. My topic this afternoon, achieving the best bowel preparation for colonoscopy, the role of PG. This is my outline. As we know, colorectal cancer is one of the most prevalent malignancy in the world, and routine screening using colonoscopy has contributed to the significant decrease in both colorectal cancer incidence and mortality. So, colonoscopy is principal investigation for colorectal cancer, and colonoscopy is the gold standard in detecting and preventing CRC with high sensitivity, 90%, and specificity, 91%. And for diagnostic colonoscopy, depend bowel cleansing, because diagnostic accuracy and therapeutic safety depend the quality of bowel cleansing. As we know, for adequate bowel cleansing is essential before we perform colonoscopy. This is the ideal bowel preparation. Is effective clear the colon of stool and provide maximal visualization of mucosa and preserve the gross and microscopic integrity of the colon, easily administered, well tolerated, and safe. If bowel preparation inadequate, can cause miss lesion pathology abnormality and the need for repeated procedure and increased procedure-related complication. So, can cause shorter colonoscopy surveillance interval, longer hospital stay, and increased healthcare costs. This is a recommendation from American Society Gastrointestinal Endoscopy. Recommend that for cecal intubation or colonoscopy, rate must above 90%. And then for the colonoscopy screening, they recommend above 95%. However, some patients still fail to complete the colonoscopy, maybe average 30%, because maybe no good the bowel preparation. For evaluation bowel preparation, adequate bowel cleansing should allow for the detecting significant colorectal lesion higher than 5 mm. Several major endoscopic society recommend that colonoscopy report should include assessment the quality the bowel preparation. Terms as excellent, good, fair, and poor, not standardized for definition. These several bowel preparation scale, like Boston, Ottawa, Aronchik, Airfield, Chicago, just mentioned Prof. Mudani. But I want to focus Boston bowel preparation scale. This recommend as the scale of choice in clinical practice to assess is the the area colon usually divided 3, right side, transverse, and left colon. This scale have a threshold optimal. Its total score more than or the same 6, and each segment the point more than 2 per segment. This is if you use Boston bowel preparation scale, this score range 0 to 3. All the colon divide 3, right side, transverse section, and left side. And you can see this 0.3, if entire mucosa of colon segment seen well, and 0 unprepared colon segment with mucosa not seen because solid stool cannot be clear. So the total score optimal more than 6 or the same. This is Aaron-Chick scale. Aaron-Chick scale, I think Dr. Manadi already discussed before, but Aaron-Chick scale only qualitative, only qualitative, because that this scale, there is no count the quality of bowel scale, only qualitative like excellent, good, fair, poor, and inadequate, like this picture. Another bowel preference scale, Ottawa. This Ottawa can count excellent 0.1, good until 4, and then count description like this. Add with the fluid quantity rating, small, moderate, large. You can see the point, score 0 to 2 point. This Ottawa bowel preference scale, you can see you can add lower segment, transverse, and rectal. The point is 0 until 4, and then you can add with the fluid in the entire mucosa. And the score, you can add A and B, and then the score minimum 0 for excellent and maximum 14 for inadequate. But this scale, there is no threshold, inadequate or adequate provided. As we know, for the best bowel preparation, usually depend on diet, preparation agent, dosing and timing, and adjunctive drug. Because before the procedure we perform, usually the patient we advise to prepare like a diet. So before the maybe 1 and 2 day before the procedure, usually for patient we advise to low residue diet with a clear liquid diet, so a better tolerance. For the former is preserve optimal cleansing quality. Low residue diets generally consist of carbohydrates, protein, and certain cooked fruit, vegetables which are easily digested. And low residue guidelines exclude complex grain, seeds, nuts, and indigestible. This is a preparation agent, traditional, we know. Isoosmotic agent, typically PEG, containing preparation, cleans the lumen through cathartic effect, result from a volume lavage, large volume. Hyperosmotic include magnesium citrate, sodium phosphate, and then maybe sodium picosulfate magnesium citrate. Hypoosmotic agent, PEG 3350 powder, of the counter laxative use for constipation. A new preparation like a Lenpic, Lenfu, colonic hydrotherapy, usually combined from several laxative. This my focus to polyethylene glycol or PEG. PEG is the most commonly administered preparation, and many variety of PEG based formulation are available. Traditional in our country, only traditional PEG. PEG is isoosmotic, preferred in patient less likely to tolerate fluid shift, like renal failure, hepatic failure, or cardiac failure. So, PEG safe and well tolerated. But common adverse event because of large volume can cause nausea, abdominal pain, and some bloating. This is several study to compare use PAG and another laxative. They conclude PG is better than other laxative. This is systemic review, meta-analysis, sodium picosulfate magnesium citrate versus polyethylene glycol for colonoscopy preparation. Vaginal bowel cleanliness, effectiveness. They found that in the rest 21 study, 76.3 in patient in the sodium picosulfate magnesium citrate group had satisfactory preparation compared 79.7 for PG. There is no significant difference between two agents, but effect direction show a trend in favor of PAG. This is a systemic review and meta-analysis, sodium picosulfate, magnesium citrate versus polyethylene glycol, PG, for adenoma detection rate. The result on polyp detection rate, no significant difference was found between the two agents. No significant difference except with the regard adenoma detection rate. Nonetheless, both of the forest plots show the trend in favor in PAG. This is a randomized clinical prospective trial compare split dose picosulfate and magnesium citrate versus polyethylene glycol for colonoscopy preparation. They found PG is superior. PG more adequate preparation, better than sodium picosulfate. How about the dosing? European Society Gastrointestinal Endoscopy recommend the use of high volume or low volume PG based on regimen as well that non-PG based agent that have been clinical validated for bowel preparation, because depend the condition patient. Like high volume PG, 4 liter PG, this is the conventional versus low volume PG plus adjuvant like 2 liter PG plus ascorbic acid, PG plus citrate, or 1 liter PG plus ascorbat, or 2 liter PG plus bisacodyl. This is the study to compare high volume of polyethylene glycol, PG, compare with the low volume of PG plus adjuvant. You can see here, 2 liter PG plus ascorbat, 2 liter PG plus citrate, ascorbat, and 2 liter PG plus bisacodyl. The result from this study, high volume of PG is the gold standard for efficacy, but low volume of PG provide comparable cleansing high volume PG, low volume PG formulation insufficient in all patient population. This means some patient like cardiac failure, hepatic failure, or renal failure usually cannot tolerate with the high volume. So maybe we can choose low volume for the patient like liver failure or hepatic failure. But if the patient like history of the constipation, I think we can use high volume polyethylene glycol. What about the timing? The most recent multi-center guidelines advocate to use split dose bowel preparation. European Society Gastrointestinal Endoscopy recommend for patient undergoing afternoon colonoscopy the same day bowel preparation as acceptable alternative to split dose. And the colonoscopy should be start within 5 hours from the last dose bowel preparation. Because more than 5 hours, maybe entire the colon, maybe the surface not good. So to complete at least 2 hours before the beginning of the procedure. This several study compare split dose PG with conventional 4 liter PG. You can see split dose PG is more superior than non-split dose PG. This is an article, study bowel preparation with split dose polyethylene glycol before colonoscopy, meta-analysis, and randomized control trial. The result, you can see here, split dose favors compare that full dose. This bowel preparation with split dose polyethylene glycol before colonoscopy. You can see the result favor split dose. Forest plot demonstrating a significant decrease number of bowel preparation discontinuation with split dose PG before the colonoscopy. You can see here some center use adjunctive drug for the best viewing in endoscopy. They adjunct such as stimulant, prokinetic, and antifoaming have been evaluated to improve the quality of adherence to bowel preparation and adherence. There are discrepancies over their use between American and European society. The American society does not recommend use adjuvant, whereas European society state that simethicone may improve colonic mucosa visibility. And Mr. Chairman, this conclusion, colonoscopy remains the mainstay in colorectal cancer screening, diagnosis, and surveillance. However, effectiveness is adequate bowel preparation. Incomplete or inadequate bowel preparation can have significant detrimental direct and indirect implication. And PG regimen has still the most common use for preparation. Recommendation regarding dose timing, volume continue evolve to optimize patient satisfactory and successful bowel cleanse. Thank you.
Thank you, Dr. Bradley Jimmy Waleleng, for a very excitement presentation. I think there's a discrepancy between Jakarta and Manado, because Prof. Murdani using Arancik, and in Manado you use Boston, right? Okay, we will have so many questions, but we will answer after all the speakers already present their presentation. Now we will move to the third speaker. We have a very beautiful, I think it's the most beautiful speaker of this session. She is Dr. Fardah Akil from Ujung Pandang. She is the head of gastroenterology and hepatology division from Ujung Pandang. She will bring the topic about the bowel preparation in special population, which one is effective and safe. Without further ado, Dr. Fardah, the time is yours.
Okay, thank you, Dr. Takaka, as a chairman in this meeting. I would like to thank you for organizing committee and sponsor for today meeting too. I will share my presentation. Okay, today I would like to talk about the bowl preparation in special population. Which one is effective and safe? As already mentioned from Prof. Mudani and Dr. Jimmy, the quality measure for adequate colonoscopy are affected by bowl preparation. In the right box, we can see there is an indicator for adequate colonoscopy, adenoma detection rate, and cecal intubation rate actually can affect by bowl preparation itself. And we can find about 10 to 40% of colonoscopy inadequate bowel preparation can still occur. This is generally colonoscopy preparation tend to be disliked and poorly tolerated. This is a barrier for special population. The taste of formulation, volume required, and patient-specific factor, and lack of standard patient education, this will implicate in inadequate bowl preparation. As we know, there is two types of bowl preparation according to the formulation. There is an isoosmotic agent that we call polyethylene glycol that already mentioned by Dr. Jimmy. This is an inert polymer of ethylene oxide formulated as non-absorber solution. There is a benefit and limitation for this isoosmotic agent, especially in the poor palatability and large volume of fluid consumption. Because of the palatability and need of high volume, there is a semi-new regimen for PEG itself, such as sulfate-free PEG and low-volume PEG for improve the basic of PEG. Second type of bowl preparation is a hyperosmotic agent such as sodium sulfate, sodium phosphate, sodium picosulfate, and magnesium citrate. There is some benefit to and limitation according to this hyperosmotic agent EVAC. And in Europe, generally, they use a combination for hyperosmotic agents such as MTSP and oral sulfate solution that we cannot find in Indonesia. This is a meta-analysis compare the polyethylene glycol and sodium phosphate. From 1980 until 2008, sodium phosphate was the better formula solution in bowel preparation compared to PEG. But in 2006 until now, the study was show that PEG was the more likely have a better efficacy or comparing to sodium phosphate.
Hello, Dr. Farda. We cannot hear your voice.
Koneksi kayaknya.
Koneksi.
Sorry, audience, for the disruption of the connection. Dr. Farda or the committee, maybe could you help Dr. Farda? Dr. Farda, are you already join us again? Dr. Saskia, is there any, what's happening?
Dr. Kaka, we're still trying to connect to Dr. Farda Akil. So in a moment we will connect it again to Dr. Farda.
Thank you.
Dr. Kaka, maybe if there are some questions, maybe we can have a discussion session for a while before we continue to Dr. Farda.
Okay, we have already so many questions for the speakers. First is from Dr. Adwin. The first is for Dr. Adwin Haryo Indrawan Sumartono. Good afternoon, all speakers. I would like to ask Prof. Murdani, from your experience, which colonoscopy technology has the most capability for high adenoma detection rate? And also, how about your experience and evidence of using artificial intelligence technology in colonoscopy to improve ADR? Thank you, Professor.
Yeah. Thank you, Dr. Adwin. I think this is very important issues to be raised in this era. Unfortunately, I'm not sure whether Dr. Kaka in our unit do we do a study to see the adenoma detection rate from our endoscopy unit, but I think it should be more than 25%. Frankly speaking, all we can do in our unit depend on the instrument we have, and I think those are some high-end instrument available, but only for display for a very short time, for 2 months. But in our routine work, we use, I think, quite good equipment from Olympus and from Fuji as well. And I think the most important thing in this case is how we can prepare our time so we have enough time to look keenly the whole colon. So in this case, we can reduce adenoma miss rate and to improve adenoma detection rate. I think we cannot rely on such sophisticated technology that should be very expensive and again not available in our unit. Second, EI. EI, I think recently is very important to determine the type of polyps, because you see that we have several guidelines to classify the polyp. There are some polyp, inflammatory polyp that is safe, not progress to colon cancer, but there are some adenoma. Sometimes it is not easy to differentiate between adematous polyp and inflammatory polyp. Mostly, if we find a polyp in the right colon, mostly a flat polyp, and sometimes it is not easy to determine using white light colonoscopy.
And once we can determine using chromoendoscopy, for example, the endoscopy available in our unit, and the problem is how we can classify this polyp. And in this case, EI should be very, very important. But I'm not sure EI is available now in our unit. But some report from other center, EI very helpful to determine the sort of the type of polyp, and this will be very helpful to determine what action should be done and how long the colonoscopy should be repeated. So I think the information from EI very important in the future. I hope our unit will be set for EI equipment in the future, so we can classify such polyp in a better way in the future. Thank you, Dr.
Yes.
Adwin.
Yes, Professor Murdani, maybe only a few doctors know what is AI. Maybe could you give some information what is artificial intelligence for this colonoscopy?
Yeah, maybe I would like to start with a very simple. When we want to classify the polyp, there are many instrument to classify polyp. Japanese instrument, European instrument, and most of instrument or classification, it could be different and somehow could be very confusing. And some newer newcomer endoscopy should be very difficult to clarify which type of this polyp will be. And in this case, EI very helpful. It means that you can take some picture. For example, you take 5 pictures and you send them to the machine, what we call machine learning, and they will give you an answer that this is the type of this polyp if blah blah blah. And most importantly, the accuracy of this EI work is very wonderful. It said that the accuracy, the sensitivity and specificity of this information from EI could be reached until 98% like that. So it's very conclusive.
Yeah. So to
I
simplify, it's something like Googling, yeah, Professor Murdani.
Yeah, just send them some information, such as a picture of the polyp, and they will give you the answer. What is the type of this polyp?
Yeah, maybe is there any limitation for using artificial intelligence, Professor Murdani? Because AI is not the doctor, because doctor, we learn and we see the patient, but AI, they're just computers. What do you think?
Yes, but they have got a lot of information about the type of polyp from the previous examination. So from machine learning, they can easily determine this polyp, this type A, type B, type C, from previous data, big data.
And even AI can give us suggestion what to do next, right, Professor Murdani?
Yes, because there are some action to be done after we recognize what kind of polyp it is.
Okay, I can see that Dr. Farda already joined us again. Maybe we can continue for the lecture, Dr. Farda.
Okay. Thank you, Dr. Paka. I'm very sorry, there is some problem in my computer. It's restart again. So I will continue my talk. Okay. Thank you, Dr. Kaka. So according to the conclusion of a recent bowl preparation study that PEG electrolyte is still a gold standard for efficacy among standard preparation in bowel. The choice and efficacy of bowel preparation it's may influenced by patient factor and comorbid that we can see in some special population. This is a special patient population from elderly and patients with at risk that have heart failure, renal insufficiency, diabetes, and stage liver disease or electrolyte imbalance, patients who are pregnant, patients in IBD, patient with risk factor for or a history of inadequate preparation and acute lower gastrointestinal bleeding. So the first is in elderly people. As we know that bowel preparation can be seen in 19% of colonoscopy. This is the comparison between the PEG and sodium phosphate. As we seen here, there is some many benefit using PEG in these elderly people. And the recommendation for elderly people, according to the guidelines, America and Europe for a Society of Gastroenterology is recommended for peak in split dose modulation with low volume, and they against the use of sodium phosphate. In at-risk patient, this is we know that actually all cleansing regimen is associated with the risk of dehydration and potential electrolyte imbalance, especially in hyperosmotic preparation. And some patients such as diabetic and person with heart or kidney disease will require modified procedures and certain precaution. And as we know, for this at-risk patient, the bowel preparation should not be in measured fluid shift or electrolyte absorption. This is the first at-risk patient for diabetic patient. Comparing the PEG and sodium phosphate, they have the same poor bowel preparation compared to non-diabetic. This associated with the mean age, duration of diabetes, level of HbA1c and fasting blood glucose level, and late diabetic complication. As we see here that the patient with diabetes often have reduced renal perfusion, and for using the sodium phosphate, this will make a higher risk of phosphate intoxication. As recommended here for diabetic patient, PEG solution still the choice for this population. In patient with renal failure, as we see the comparison about the PEG and sodium phosphate according to the study, there is some limitation for using sodium phosphate in this kind of population. The recommendation for patient with renal failure is PEG is the only recommendation for this condition or this population, and Europe still against the routine of use sodium phosphate for bowel preparation. In patient with heart failure, comparing the PEG and sodium phosphate here, there is some benefit mostly in using PEG according to the study random or meta-analysis. And the recommendation in patient with heart failure here still PEG preparation as a choice for patient with heart failure. And again, Europe Society still against the routine use of sodium phosphate for bowel preparation. In patient with pregnant or lactating patient, there is some benefit for using PEG according to some study compared to sodium phosphate. And colonoscopy, as we know, is appear feasible and relatively safe in pregnancy when strongly indicated. And for recommendation for pregnant and lactating patient, still, if a bowl preparation is strictly recommended, interrupting breastfeeding during and after bowl preparation may be an option, and PEG still the regimen that can be considered in this population. In patients with inflammatory bowel disease, this is a special consideration must be made because of there is a safety and diagnostic issue for patient with IBD, and the adequate agent should be chosen. So according to the study and comparing about the PEG and sodium phosphate, there is a benefit using PEG in this population, and recommendation for patient with IBD still using some PEG-based bowel preparation. And there is some recommendation too for patient with IBD according to the indication. If the indication in patient IBD, we would like to study about the small bowel, especially in patient that we suspect with Crohn's disease. PEG can be used either in the wireless capsule endoscopy and anti-retrograde double balloon enteroscopy or retrograde double balloon enteroscopy. For colonic cancer surveillance, PEG still can be used as a main oral bowel preparation that can improve detection of dysplastic lesion. For therapeutic IBD procedure, that indication for dilatation of benign fibrotic structure or polypoid resection, high volume of oral PEG can be used. This is the second last for recommendation for inadequate bowel preparation. Many patients we can have there is an inadequate bowel preparation as according to the qualification. Consideration should be given for more aggressive preparation to this population. So a large volume enema such as a PEG-based regimen was the one can be used for this inadequate bowel preparation, and some of method can be used such as direct enema or irrigation, or using pump irrigation in patient with inadequate bowel, especially in the right colon. This is a practical approach for suboptimal bowel preparation algorithm that if a patient have a nausea or vomiting with laxative, we can use prokinetic or some of prochlorperazine. And if the patient can tolerate with high volume of laxative, we can use low volume bowel preparation that PEG can be used as one of the choice. And if the patient already have a laxative but still the preparation doesn't optimal, the laxative prescribed can be increased, or there is some modification to using high volume PEG solution in this suboptimal bowel preparation. The recommendation for acute lower gastrointestinal bleeding, as we know that if we make a colonoscopy for patient with acute lower gastrointestinal bleeding as an urgent endoscopy that can be in 6 to 24 hours, facilitate endoscopic visualization, diagnosis, and treatment, and may reduce the risk bowel perforation if there is a good bowel preparation. And Europe still recommended PEG regimen as a bowel preparation. But because of some of the preparation PEG solution of very
Dr. Farda. Hello, Dr. Farda. The committee, please help Dr. Farda to join again. Okay, while waiting to Dr. Farda, we will have a discussion again. Now we have a question from Dr. Jacobus Albertus. He asks Dr. Jimmy, higher incidence of air bubble in proximal colon has reported with PEG. How to reduce colonic air bubble during colonoscopy? Have you suggestion?
Thank you, Dr. Kaka. You can hear me?
Yes.
Okay.
Please, Dr. Jimmy.
I think for decrease bubbles in colon when we perform the colonoscopy, only European Society Gastrointestinal Endoscopy recommend to use simeticon. But in Indonesia, I don't know. Maybe we don't have prepared contain only simeticon, because in Europe and in American, only one third percent patient lead to the bubbles in the colon when perform the colonoscopy. So too many arc about the use simeticon for preventing bubbles in colon when we perform the colonoscopy. But if we have simeticon, I think we can try to use a simeticon, because in several countries different in those simeticon to use for the colonoscopic to prevent air bubbles. I think suggest if we have, maybe you can try, but only simeticon, because simeticon recommend for European Society, but American, they didn't recommend.
Okay, maybe Professor Murdani has any suggestion. I think we don't have any simeticon right now, yeah, Prof. Murdani.
Yeah, Dr. Kaka. Yeah. Yeah. We have ever discussed simeticon in Fornas. Most of the members of Fornas did not agree for simeticon to be distributed in our country. I think many years ago, the simeticon is available, and I think this is very useful for upper GI endoscopy to clean the surface of the mucosa. And I think also very beneficial for endoscopy and colonoscopy as well. I think the society may play a role in this case to push the decision maker to allow simeticon to be
available here.
Provide in our country.
Thank you, Prof. Murdani. Now we will have again Dr. Farda for the third time.
I'm so sorry, Dr. Kaka.
Okay, you may continue again your lecture, please, Dr. Farda.
Yes, thank you. This is the last PowerPoint from me. So this is a table comparison of bowl preparation agent that available in Indonesia. Still, there is a fake electrolyte is non-inferior or superior to low volume PEG or non-PEG regimen here. And the summary for my talk today is endoscopy should choose the bowel preparation wisely in special population to optimize the efficacy and treatment of this patient. And bowel preparation for special population might consider polyethylene glycol for effective and safety colonoscopy. Thank you, Dr. Kaka. I'm sorry, Dr. Prof. Mudani, and sorry, Dr. Jimmy.
Okay, thank you so much, Dr. Farda, for the lecture. Yeah, we have a question for, I think for Dr. Farda. I think it's from Dr. Bogi. Dr. Bogi Pratomo Wibowo from Malang. He asked, is there any specific strategy for the colonoscopy preparation for all patients with heart failure who can not take enough fluid intake? As we know that if you want to use PEG, we have to use minimally 2 liters of water. What do you suggest, Dr. Farda?
Okay, thank you, Dr. Bogi, for the question. This is a good question because we have many patients that came colonoscopy for their disease. So according to the recommendation for patient with heart failure, yes, the preparation for a PEG is one of the choice with a low volume, or we can use a split dose from a standard volume of PEG preparation, but with careful monitoring during and after use. So I think the split dose using standard volume of PEG or 2 liter PEG can be used in this patient, and maybe just suggestion for patient because of there is a heart failure, some laxative can be used as a adjuvant therapy for this heart failure, like laxoberon, for improvement the bowel preparation. Thank you.
So to be more specific, so how many liters of water that you can recommend? I mean, you said that split dose will be okay. So
Yes.
2 liters split 2,
Yes.
so 1 liter and 1 liter.
Yes,
right?
Yes, right, Dr. Kaka. Just maximal 2 liters with split dose 1 liter in the evening, and then in the morning can be used in 1 liter, and about 6 hours before the examination.
So what if the patient had a restriction of water intake, such as like this case, like heart failure, that he can maybe maximally only have 1 liter of water each day. So do you still recommend to use this 1 liter and 1 liter, or is it okay?
If the patient cannot using for a general volume of PEG preparation, maybe we can separate the 1 liter, or as I say, that we can use added some laxative like stool softener to this patient.
So I mean, you still use 1 liter and only 1 liter, or still 2 liter with laxative, or you decrease it only a half of the full dose?
Still in 1 day, for a good preparation, bowel preparation, still we should be use a minimal 2 liter for PEG preparation, and if should be separate, maybe in 1 liter can be separate of 500 cc, about 8 to 10 hours separate, Dr. Kaka, if cannot available more low volume or high volume for this preparation. So 1 liter can be separate to for 500 cc for 6 hours.
But still maximally 2 liter, minimally 2 liter,
Yes,
right?
Yes, because of there is no other study that if we use less than 2 liters, the bowl preparation can be achieved a good achievement. So,
Do you have any other experience for this kind of patient, and what happens after you use 2 liters of water? Are they still safe, or maybe heart attack happens?
So, preparation for heart failure in this patient, I think we must prepare for first about the examination about their heart disease. I use some of echocardiography before patient going to colonoscopy or endoscopy examination for this kind of patient. If the patient didn't have or didn't reach the ejection fraction more than 60%, I choose not to plan the endoscopic examination for this patient. I have a few case that in patient have ejection fraction less than 60%, they will having few hours after the examination or at night, they can have arrhythmia or some heart attack. So we must be very careful for this patient. And I think for the benefit, if really benefit for heart failure patient, maybe we can have examination. But if the endoscopy or colonoscopy doesn't have some of like a benefit weight the safety, I think we should be delay the examination, Dr. Kaka. Thank you.
Okay, maybe Dr. Jimmy, because I think this is very crucial questions, and we have to be very clear about this. Dr. Jimmy, do you have any experience, or maybe you can add some answer, because you also talk about PEG, right? Please.
Thank you, Dr. Kaka. I think I agree with Dr. Farda, because for patient, when we use only like 1 liters, I think achievement for bowel cleansing is no good. So maybe we can use split dose like Dr. Farda, but don't use for the same day. So maybe evening 1 liters and then 1 liters in the morning, because some institution use same days in afternoon procedure. So I think if we monitor patient with the heart rate and respiratory rate and compliance the patient, I think is important. So before we use PEG 2 liters, I think we must evaluate the cardiac performance, like with the echocardiography. In theory, the patient, we must careful if New York Heart Association functional class 4. So if only class 1 and 2, I think it's okay. We use split dose 2 liters.
Even though the ejection fraction is less than 60%, like Dr. Farda said.
Yeah. I think if only less than 60, I think is enough. But if less than like 30 or 40, I think we must postpone until cardiac performance the patients better after the treat from like cardiology or in our internal division. I think important to treat a congestive heart failure, and we postpone the procedure until better cardiac performance. Thank you.
Thank you, Dr. Jimmy. I would like to ask Professor, Dr. Fada, please.
Kaka, I would like to confirm again that ejection fraction is very important in patient with cardiac disease. So, what can if the patient should have endoscopic examination? One of our experience here is it is okay, I think, if the patient have anesthesia, because of there is some of monitoring of their cardiac function or vital sign that we can perform safely the endoscopy. Thank you.
Okay, I would like to ask Professor Modani. I know that you are a very brave endoscopist. So, like in the Dr. Jimmy case, if the ejection fraction only 30%, but no heart attack. I mean, no. The condition of the heart is fine, but the ejection fraction only 30%. And what happened is it's severely bleeding from the lower gastrointestinal tract, and the patient needs to have a colonoscopy. What would you do for the preparation, Professor Modani? Hello, Prof. I think you are still muted, Prof.
Yeah, sorry. Yep. Thank you, Dr. Kaka. I agree with Dr. Jimmy and Dr. Farda concerning this issue. I think we need to be very, very careful if we want to administer high volume polyethylene glycol to a patient which cannot tolerate volume, in this case because of congestive heart failure. However, if you look at some data about the effect of polyethylene glycol on plasma volume, it says that most patients, the increase in plasma volume is minimal. However, there are some variability in this response. So that's why I agree we should very, very careful in this case. If you want to prepare a good bowel prep for colonoscopy in congestive heart failure, what I used to do is to combine the modality to reduce the volume of polyethylene glycol. For example, I used to administer what we call Dulcolex?
Bisacodil.
Bisacodil for 2 tablets at night time, and ask the patient to drink the PEG as they can tolerate. And once they have a bowel movement, and then I think all the liquid will be flushed out. So in that case, I think quite safe. But again, we need to observe the heart failure as well during the preparation. I think some cases I used to prepare using enema. It can also very helpful, or in combination.
Okay, so the most important thing is do not add more harm to the patient, right, Prof?
Yes, and we need to clear the colon for colonoscopy.
Yes, that is the most important thing.
The Dr. Kaka question, Prof. Murnani, about the gastrointestinal bleeding.
Yeah.
how we improve
Yeah.
the the colonoscopy.
Yeah. Fortunately, GI bleeding, we know that blood is also something like effect like laxative. So, but still we need to clean the bowel if we want to perform colonoscopy procedures. I think bowel preparation, even during the bleeding situation, very important. Yeah, Dr. Kaka.
I think informed consent is the key, right, Prof? You have to
Yes.
inform the condition, right? And the patient,
Agree.
and if he wants to give this, the patient's family also has to know about the risk, and they have to sign.
Yeah.
Nowadays,
Yeah.
it's very important. Okay.
Agree. Dr. Kaka, according if the lower GI bleeding, one of method we can use that water jet injection. I don't know if in Chipto already have a water jet injection. This is one of the new methods that replace the bowel preparation for acute lower gastrointestinal bleeding when we want to examine it.
Please, Dr. Jimmy first, maybe. What do you think about replacing bowel preparation with a water jet in gastrointestinal, lower gastrointestinal bleeding?
I think water jet already have in Makassar, because in our institution we have. So sometimes we can use for water jet for clear the mucus, for evaluate source of bleeding. I think before Dr. Fada already discussed and explained, for patient with the lower bleeding, use high volume like 4 and 2 and to 6 liters. Dr. Farda.
Yes, Dr. Jimmy. Yes, you're right. So this is the new method because of there is some limitation, especially if we want to the urgent endoscopy for acute lower GI bleeding. So one is the choice is just using water jet injection about 500 cc per minute without doing some bowel preparation, or we can use enema bowel preparation while colonoscopy.
Okay, maybe Professor Mudani, do you have any thoughts about this?
Yeah, I think enema is a good choice, and water jet also another additional action we can do during colonoscopy procedures to increase the adenoma detection rate in this case, or to find out any source of bleeding.
Oh, without bowel preparation, what do you think about the fecal material? Will it be very harmful if we do colonoscopy without clearing the fecal material, just using water jet? What do you think, Professor Mudani?
I think bowel prep is still necessary, mostly in lower GI bleeding. I'm not sure. I don't have any experience. Only rely on water jet. Mungkin Dr. Farda, you have more experience in this case.
What I told here, because of this is one of the recommendation from Europe method. So I think Dr. Putut have studying about the water jet injection in colonoscopy examination, Prof. Mudani, or Dr. Jimmy. I think Dr. Putut already have study about water jet injection for improvement the bowl preparation.
I think we didn't have a study, but I think water jet only adding for clearly source of bleeding, but we still use bowel preparation with the pack, but maybe high dose, high volume, high volume. So Dr. Fada mentioned before, use high volume like 4 to 6 liters. Use PEG, and then we adding with the water jet for increase the visualization.
Yes.
Okay, thank you so much. Yeah, Dr. Fada, would you like to add any information?
No, thank you, Dr. Kaka. I'm very upset because of my presentation always 2 times stopping.
Okay, it's okay because you are far away in Makassar. Okay, it's okay. I think this is a very fruitful and interesting discussion, and it's a very lively discussion between the audience, and also all the speakers very actively engage with the audience. Thank you so much. I give you so much applause for all of you. And
Dr.
yeah.
Kaka.
Thank you, Dr. Kaka.
Because due to the time limitation, we
Dr. Farda,
we will reach the end of this session. I would like to conclude that the one thing for sure, that bowel preparation is very important for the adenoma detection rate and for the successful of the colonoscopy, either for diagnostic and also for the therapeutic, like polypectomy. And also we have to be more precaution about special condition like cardiac failure or kidney failure. Okay, I hope it will be useful for all of us. Thank you, Professor Murdani. Thank you, Dr. Jimmy, and thank you, Dr. Farda. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Kakak, Prof. Murdani, Dr. Jimmy.
Thank you to all of the professors
Kasih.
and doctors. We will have a photo session. So if you may please look into the camera, and we will have a photo session. So I will count in 1, 2, 3, capture. Okay. Thank you very much once again to all of the moderators and speakers for a very nice session. Ladies and gentlemen, now we almost get to the end of this session. But before that, we would like to have your comments and thoughts about this symposium. So you would kindly go into this following link that will be shared on the chat room. So this is the link, bit.ly/IDDW 2020 batch 2. So please fill in the survey form. Your voice will be so meaningful for us. And finally, this is the end of the Virtual Indonesian Digestive Disease Week 2020 batch 2. And we will meet again on the next occasion next week on the Virtual Indonesian Digestive Disease Week 2020 batch 3. And it will be held on Saturday, 24 of October 2020. Don't forget to come back next week at 8:30. Thank you very much for your attention. See you. Assalamualaikum warahmatullahi wabarakatuh. Thank you.